when you're in the middle of something, it's more difficult to evaluate, to actually look at it truly objectively, but I can, because what I'm going to do is to take you on a bit of a journey to see the value of taking a higher helicopter perspective on a large-scale challenge and the value of collaboration and securing consensus. And what we're talking about here is people taking advantage of advances in science and technology, which we see all around us, but it's very disparate. We have devices that are supposedly connected. We have smart homes, which are not necessarily as smart as they think they are. So how can we actually connect the dots? How can we create something which is more holistic? This is the challenge that we set out to navigate. And this was back in 2014, 2015. And it began with a commission from the European Commission. They were interested in how age-friendly housing could be used to improve the quality of life for aging populations across Europe. We took a slightly different approach, which was not just the house, not just the home, but to look at the built environment as a totality, the neighborhood, because it's kind of fundamental. You can create a situation whereby even if you get the best technology in the world, you could end up with this wonderful, what I would call a technologically gilded cage of a home, where a frail older person is perhaps unable or even frightened to step outside their front door. So we have to do something that extends this idea of healthy aging into the neighborhood. So we started off with a roadshow. We wanted to define what good looked like. We had a roadshow across Europe, 12 different locations, and it concluded 12 months later. It began at the European Commission and it concluded at the European Commission. I came across this slide from a presentation that the Commission did at the end of 2016, and it was quite an interesting year because you may or may not recall, but the referendum fell right in the middle of it. So here's a project being run by a UK company, and then suddenly it's slightly embarrassed, but that's another story. So what we learned, this is what the Commission said in this event. Don't isolate older adults. We need intergenerational innovation, not ghettos for the elderly. So the idea of retirement living and just sitting, in one home, one demographic, no matter how well you treat them, being the solution is not the solution. Don't lose the human touch. Look to technology, yes, but maintain the human touch. Don't talk about end users in need of education. Help older adults to become informed buyers. Treat them as consumers with the power and responsibility to invest in solutions that best suit their changing needs. This means making new product and service solutions not only technologically proficient, but they must also be desirable. Again, it comes back to the market that we need to create. We must work harder to involve more financial institutions, construction companies, and property developers in the conversation. Big business industry needs to be at the table. We need to identify best practice, quantifying scale success factors through standardization. We said this in 2017. We now have a standard. I'll talk about that momentarily. Stakeholders are looking for practical advice, opportunities for collaboration and knowledge exchange. There is no appetite for theoretical frameworks. So to summarize, the value in collaboration. Again, this came out of the research that we conducted. Engage relevant stakeholders in development of the solutions, build on regional, national, and European activities, mobilize policy initiatives, standardization and investment. Again, the idea of standardization being a fundamental consideration in terms of potential to scale, and create scalable national, European, and global markets. Again, a reason why I felt I should attend this event, because that is part of your philosophy of wanting to create this interconnection between different nationalities from different parts of the world. Off the back of the work that we did with the European Commission, we published an associated white paper. It was sponsored by McCarthy and Stone, which is the largest developer of what they then called retirement housing in the UK. And they talked about new forms of technology and big data presenting possibilities for everyone, especially older adults. However, their impact on those in later life is relatively unexplored. This is of great interest to us, and how they can support this age group to live better at home. And as I say, they actually wrote this in 2015. And they would like the report to serve as a valuable resource for all housing providers, to be open source for the benefit of everyone. And this is, again, fundamental to the philosophy. And we come full circle. I'll explain in a bit. But we looked at that future at that time. We actually looked at various technologies that were on the cusp. And it's really quite funny when you look at that report today, which was published January 2017. Some of the technology at that point, which we thought was kind of out of this world, is a reality today. We take it granted. It's not necessarily embedded, but it did generate quite a lot of media exposure at the same time. So thereafter, we again engaged with partners, because this helps to ensure that this isn't just a research project. And one of those partners was Swiss Re. The reason I'm flagging this up is because data is a fundamental consideration in terms of our neighborhoods of the future and how we keep people healthy and more active. Again, this was written in 2017. Today, the insurance value chain relies on data, but relatively little is captured and used. You could say the same thing in 2024. Next generation of wearable devices transforming our understanding of health. We've still got these, you know, they're not much more sophisticated today than they were there. All right, they're a bit smaller, but we haven't really moved on as dramatically. Well, the devices, you know, we've got, this is more sophisticated because everything, I'm responding to looks. It doesn't really work if you're online here. What is he talking about? Better futures through the value of your data. Data is fragmented across the web and used by others who benefit from it, still factual. Bringing it together under our control unleashes its true potential, and exchanging it on agreed terms creates mutual benefits for all, users, businesses, and society. That's radical thinking even today, right? As I say, something has to change. Thereafter, we moved to our next report, and the focus there was more on the bricks and mortar. What does building look like in this neighborhood of the future, and how can it be applied in different countries? So we've partnered with Tata Steel because they were interested both in the West and in India, how what we did in the UK in research and Europe terms could then be, through a long tail, beneficial to developing countries. And they looked at the platform approach, which has stalled. You know, we have a housing crisis, not just in the UK, but pretty much globally. Modern methods of construction could make a difference, but it's stalled. How can we get that going again? And how can that benefit the work that we're doing? Because the reality is you can factor technology in at a much earlier stage to make it truly seamless. The other thing that we did at this particular time was to think about building a support network, a user-centered open innovation ecosystem to help the most promising science and technology to transfer from the lab to market, to foster collaboration and co-creation among universities, SME and industry, and help to scale up innovation and solutions, promoting knowledge exchange and best practice and nurturing ecosystems with content and thought leadership. You need to expand you need to embrace more people in the conversation. It's all very well to be talking in conferences like this to stakeholders who are privileged enough to know what's going on, but that doesn't necessarily impact in the real world. And so we need to move the debate away from purely emotive to pragmatic, from find the right people and the right organizations to become advocates for transformation, engage a wider and very much a younger audience to become part of their solution. We're not doing this for the people in the room. We're doing this for future generations. Okay, you will benefit, but the reality is we have to work collectively and collaboratively to pave the way for the future. Give our senior citizens a voice in their own story. Co-creation is fundamental. Demonstrate the role of innovation in delivering change. And we've got plenty of evidence as to how this has worked. And shortcutting, this took us up to 2020. And since 2020, between 2020 and 2024, we've had two primary focus points. The first was we were invited to join this project. It was called SHAPES. It was a European Horizon 2020 large-scale demonstrator, 21 million euros over 4 years. SHAPE stands for Smart and Healthy Aging through People Engaging in Supportive Systems. It also involved more than 2,000 older adults across 14 countries. And our responsibility was ecosystem building, community engagement and standardization. The basic principles have been looking at what kind of platform could be deployed, interoperable platforms that could enable people to take better charge of their own health and care moving forward. That's what the 4 years of research, pretty substantive. Now, obviously, with the time I've got, I can't go into detail. So I'll switch to the second focus that we've had since 2020. And it's actually January the 13th. I know specifically 2020. I was approached via LinkedIn by ISO, who said they'd heard about the work that we were doing in terms of multi-generational neighborhoods, and would I be interested in leading the development of a global standard, which we now call, which has now got a number, ISO 2553, Smart Multi-Generational Neighborhoods, i.e. collective responsibility. The reason I remember the date is because I was actually in the intensive care ward of the Royal London Hospital, which is on the top floor, with what turned out to be COVID. But it wasn't called COVID on January the 13th. It was only called COVID 2 weeks later when they turned that same intensive care ward into the COVID ward. So the purpose of ISO 2553 is to define what good looks like. And in scoping it out, we aim to normalize the creation of lifetime neighborhoods that care, where putting people and the planet's needs as a priority can combat loneliness and mental health issues while easing the associated burden on health and social care systems. Now, we started this in 2020. Last week, literally, I gave this presentation, or a variation of this presentation, at the ISO Global Plenary, which happened to take place in London for the first time. It's usually around different parts of the world. So it's a BSI. So there I am, 4 years later, talking about this standard that we're in the process of completing. It was both physical, lots of physical, and online at the same time. We have people all over the world because we have a working group contributing towards this. And the point is that it's real. You know, so from going from a theoretical perspective to something which is really substantive is very exciting. And actually, it's something you can measure, which is really the point here. How can you progress and measure the impact? Well, we see this as a manifesto for change. Our primary aims are to improve the capacity for older adults to live well and thrive in integrated multi-generational communities, incorporating technology-enabled person-centric care, to involve older adults in the neighborhood design process and co-creation of digital solutions, to define guidelines for digital infrastructure so that smart technologies can be easily and invisibly weaved into new neighborhoods. What I mean by that is it should be there as part of the primary infrastructure. You don't put it in afterwards because it's so much easier to build. It's so much easier to create interoperable solutions. It's so much easier to create a scenario where you can have plug and play, which is what we need. To give due consideration to retrofitting and remodeling. Obviously, most of the housing stock already exists. So there is a benefit, there's a knock-on benefit. You have to look to the future. Otherwise, we end up making the same mistakes and building using regulations and using antiquated processes and planning schemes again and again. We need to generate evidence-based guidance to inform public sector, industry, establish new business, service and financial models, and be equitable and inclusive, benefiting high and low-income regions, countries and communities alike. We've also joined forces with the UN. There was a bit of a quid pro quo, to be honest. We wanted to obviously engage with them. We wanted their input. They said, what are you doing for the environment? I hadn't really thought about it too much because I thought, well, this is the environment, but actually they have their own more specific views on the environment. So we factored the environment into our mission. And the consequence of that is we now have a collaboration. So we're looking at the SDGs that relate to aging societies, which is an important consideration if you're looking at a holistic approach. So getting to the end here, if we're co-creating a brighter future for our elder selves, there are too many, way too many independent pieces of work that are going on all over the world, funded primarily by grants. And those grants have a finite life cycle. I've just finished one, right? 4 years. It was great for us, gave us a bit of a luxury to be able to collaborate with 30 odd universities. It's fantastic. But what happens once the funding switches off? Nothing. You get a dead website. No matter what people say, there is no continuum. And that doesn't make sense. There has to be a way of pooling resources. So this project aims to put people and the planet's needs first, leading to a better quality of life, attitudes and behaviors, and to do it together. And this lady is the director of the Global Disability Hub. And I haven't mentioned disability, but actually it's a fundamental part of what we're talking about. Don't just look at older people because they share a lot of similarities to younger people with disabilities. So if you're going to build, be much more inclusive across the board. And as she said, you know, together we can change the world. Whoops, don't want to show you the film. So where are we now? The idea of creating that collaborative approach means we need a center of excellence. That's what we decided. And that's the model of what it kind of looks like, if you like. Different actors feeding information in, generating knowledge, insights, leadership, etc. And what comes out the bottom are new codes and standards, promote scale and sustainability. And we're actually doing it. We're launching in the autumn. And along the way, I've become a professor, an honorary professor at UCL, at the Bartlett School of Architecture, which is recognized as the leading school of its kind in the world. And we've partnered with Imperial, the civic engineering department, which was 2 weeks ago recognized as #1 in the UK, number 2 in the world after MIT, and we're also working with MIT. And the aim is to drive innovation, foster collaboration between academia and industry, and facilitate the development of sustainable and human-centric solutions, serving as a hub for knowledge exchange, interdisciplinary research, and practical applications, ultimately contributing to the advancement of urban development and social well-being. I'm not going to read this to you, but it touches on the tiers of action that we've agreed to. Collaboration and partnerships, community engagement, a whole of society approach. I'm finishing. Sorry. I did say at the beginning of this, it's going to be difficult to fill it in, but I've got 2 more slides, I think. So building a collaborative platform that I talked about at the beginning, we're actually going to put it into the real world. And we come full circle. I mentioned McCarthy and Stone at the beginning. They've partnered with us on that first report. They've been following our route, and the consequence of that is they are going to be practicing what we're, if you like, preaching. So they're about to develop, this is confidential information. It's
worldwide.
It's a small group here, right? A community of interest. And David's very persuasive. But the reality is, this is who they are. Their customers want independence, companionship. They provide supportive communities. They've got 23,000 homeowners, 530 managed developments, and they're the largest developer of new housing with care schemes in the UK. I also found the fact that they serve 1 million meals and 500,000 hours of care per annum pretty impressive. But the context changed in 2024. Societal change, we have a disproportionate impact upon housing availability, health and care system under strain, the climate emergency. And so they want to inspire new buyers, making it aspirational to be thinking about right sizing, not downsizing. And technology can play a part in that. This is the way they measure things. Smart digital platforms can predict and enable real-time interventions are the future of our sector. This is actually from a presentation that McCarthy Stone did themselves last week. I've just pulled a couple of slides. Whilst technology will never replace the human touch, digital convergence will drive innovation, support later living, reduce risk, and boost service improvement and efficiency. And what's next? Making the standards sustainable. So they see this as a valuable resource, what we're doing for the whole of the sector. And at the other end of the spectrum, just so you know, we've also partnered with Clarion Housing, which is the largest social housing scheme in the UK. We also have relationships with housing developers across the world and focusing very specifically on these 2. And to conclude, this is the last slide. This project is a wonderful opportunity to collaborate with some of the world's foremost thinkers and practitioners to co-create living test beds that will help to define the essence of best practice, where young and old, disabled and able-bodied persons can coexist in well-designed, technologically enabled housing with access to bespoke services that will help facilitate independent living and enhance well-being across the life course. And the bottom line is there is still an opportunity to contribute to this because we're in the process of refining the draft of the standard. There are live projects that are going to be going on stream. And if you want to know more or you want to think about, you want to tell us why you might like to engage, if you go to our website and look at follow standards, there's a form that you can complete. That's it.
Okay. Well, thank you very much, Ian. We're starting to get a full room, thankfully. I think this was absolutely great. It's a natural lead into some of our other speakers. I would like Mustafa. Would you like to introduce yourself and just say a few words?
My name is Mustafa Latifami. I'm from Turkey, president of the IKSAD Institute. Thank you very much.
Okay, well, you will have a chance to speak to Mustafa over the.
She'd had those things recently, so it's amazingly accurate. Cholesterol, autonomic nervous system, 45 seconds. So I think that's the latest tech, FDA approved. So, these devices are moving on. Thank you so much for the invitation. I'm going to skip because we can't all speak for 25 minutes when we've got a 50-minute slot. And we do want some time for questions. So I make no apology for going through quickly. You can read faster than I can talk. Those are my learning outcomes. This is what I'm going to cover. But we are in that interdisciplinary space. And the British Society for Lifestyle Medicine only started in 2016. We're 8 years old. It has grown exponentially from 100 attendees to 200 to 400 in the Cardiff. Obviously, that little pandemic thing had an effect on us too, not least. Yeah, I've done better thinking about it. But we've had to change how we do everything. But we are still growing. We have over 3,000 members. It's very multidisciplinary. Over half of those are GPs. But, do come, do join. We think that this is a main driver for equipping the world to cope with this epidemic of lifestyle-related disease and for us to live more healthy. And let me explain over the next 5 to 7 minutes why that is. Because we are growing, and it was only really last year. There's been long-term, about 20 years, an American Lifestyle Medicine Global Association. But only last year, the World Lifestyle Medicine Organization was incorporated as an independent charity in Switzerland. And the European Lifestyle Medicine Council is growing. So we have networks, and those networks are growing like we are. I've spoken at Croatian and the Portuguese and spoken in Greece. They are on a similar path to us. So it's a movement, okay? Now, sadly, obviously, we lost Michael Mosley a few weeks ago in Greece. Greece is intensely hot, and he was going to speak at our meeting. But, that work goes on. His wife has made it very clear to go on, and there are lots of people who are doing a lot of high-profile stuff in this space. So let's tell you about our approach to lifestyle medicine. There are 3 principles, 6 pillars, and we do group consultations, and that's about creating the community concept, recreating community that we have lost in most of the Western world, but a lot of cultures have kept. It's not just about having structures and grants and smart homes. It's about people coming together and using the latest technologies to do it. So firstly, we need to recognize social determinants on health. And obviously, Michael Marmot's updated report and the amazing 14 years we've had from what seems to be, apparently from what Rishi says, a very successful government. Let's see whether they stay in power. We need to have people able to eat. We need basic schooling. We need to have that. But after that, we have proven techniques that can support people to make positive changes to the lifestyle, which have less effect, probably 20% at most, compared to the 30% from social determinants. But these are important together. And then the 6 pillars, and these are based on the 6 modifiable risk factors for non-communicable disease from World Health Organization. So these are evidence-based and underpinned, and we know we can change them. It's healthy eating, mainly plant-based, not least for sustainability, but also for its health effects. Physical activity, recommended guidelines, 150 minutes of moderate. Strengthening exercise. Michael Mosley was very keen on his planks and his kind of high-intensity exercise because it was very effective. Harmful substances. We shouldn't be smoking. We shouldn't be drinking too much. There are cultural issues here we need to address. Toxins is a huge thing. Sleep, very important for quality and duration of life. Mental well-being as a positive thing, not just avoiding mental illness. and healthy relationships to bring it all together. So we believe that when you incorporate those changes and that ideal way we want to live through group consultations, we can leverage existing healthcare systems, existing clinicians to deliver more care at a better quality to more people. So, who did that first? Let's go back in time. In 1905, and I'd like to acknowledge Beth Freites, who's just stepping down as the president of the American College of Lifestyle Medicine. She first found this slide. He started with groups, and he used this approach for people who were poor, who had TB, who couldn't afford to go into hospital, couldn't afford to stop working, and through what he called class method, they met regularly, and their outcomes were just as good, if not better, than the people who were admitted to hospital at that time. Okay, so with a small amount of money, charitable funding, he set up a system that worked. It rolled out for chronic disease, and then he was also the forerunner of group psychotherapy when he moved to the Boston dispensary. So what we're looking at is a very successful and sustained model of care that we forgot about, because these publications in 1907 in JAMA, these are quite good journals. Journal of the American Medical Association, conference reported in the New England Journal of Medicine. That's their local rag when you work in Massachusetts. But these weren't available until they were scanned, and they're still not easily indexed, these kind of older publications. So this is over 100 years ago, and it was very successful. This is our kind of STEAMER, our Centre for Integrated Research into Musculoskeletal Aging. We did some artwork and some poetry to try and engage people in what we were doing. And this is a kind of Dali-esque version of Joseph Pratt. He has broccoli for hair. He has broken cigarettes for eyebrows. He's got sleep in one eye, social connectedness in the other, training shoes in his moustache. And his cravat represents the British Society for Lifestyle Medicine logo. Of course, all these little ants in his pocket are people in the group consultations. So, this is the problem. Our waiting lists get ever worse, and of course, there's even a junior doctor strike this week. And this is replicated across Europe, across the world. We don't have enough clinicians to deliver care. So, and obviously, massive excessive deaths. The UK did particularly badly as regards Europe and the global situation because we were late, we were slow, we were ineffective. But what great care looks like is it meets this quintuple aim of healthcare. Great outcomes. If you've got diabetes, you reach your target. If you've got blood pressure, high blood pressure, you reach your target. But also, you have patient satisfaction, and maybe the clinician should be happy as well. They shouldn't be so stressed that they go off with work stress, okay, because that impacts on care. And then it needs to be cost effective. In fact, obviously, Don Berwick, who came up with the triple aim, he said low cost. I don't think it needs to be low cost, it just needs to be cost effective. And then you have to embed effective education. That's not just the education for the patients, it's education for people coming through the system. So that means we should be embedding this stuff in undergraduate systems. We're going to have a session on that led by Jane Dacre at our meeting this year. But actually, postgraduate education, where you change people's approach to care by seeing this in practice and then being inspired to deliver it yourself. So it ends up multiplying the effect. It's like these kind of pyramid schemes, except it's good. It's good sharing instead of bad sharing. If each of us teaches this to 10 people, in 5 years, the whole world could be practicing this way. So, lots of different models, and this slightly holds us back. Some of the models are really good for access, like cluster visits, drop-in groups, group medical appointments. Some are good for chronic care. And Ed Nossinger did lots of stuff on shared medical appointments, various versions. One of the most powerful ones was a publication on multimorbidity by a group called STOPS on the cooperative healthcare clinic model, and group medical visits done through the Kaiser Permanente system. But then in that sweet spot, you've got models good for access and chronic care. That's Joseph Pratt's class method, our own group clinics in arthritis, and group antenatal care. But there's lots of evidence this is very effective in all regards. But we need to not get bogged down in the name of it. Group consultations is the overarching term. We need to persuade PubMed to mesh on that term so it's easily accessible. But at the moment, systematic reviews need to do searches in all these terms. Looking forward, obviously, we've learned during the pandemic you can deliver this kind of care virtually, and the engagement events that we run now for menopause with the Homerton, they might have 400-600 people online. Most of the people attend one session, they've got all the education they need. People who have greater needs want to go on HRT can attend smaller groups with maybe only 15 or 20, and it's much more interactive at their level, but they're on the platform already. So the virtual group system works well. if you have an in-person group and we have a limited size of room, I have to say my biggest groups had 32 people attending. So they might be struggling to get in here. So then we were already experimenting before the pandemic with hybrid, where you put up an iPad and a Bluetooth speaker and you actually have the option of either coming. The thing that really annoys me is when my patients say, I wanted to come to clinic, but I was too ill. My joints were too sore, my ambulance transport didn't come, my daughter-in-law didn't come to give me a lift. You should still get your care. You shouldn't let anything get in the way. So we need to be flexible in how we deliver care, and having virtual, in-person and hybrid solutions along the pathway is the best way to do that. But the group care delivers the efficiency, it delivers the peer support. And I'll show you what the patients say. Lots and lots of evidence across life. I'm not going to dwell on this, but we've got transformative examples. So Kids Bowel and Bladder Service, they put this in. They saw 37 families the third time they did it. So they had 100 people in the room. Their waiting list, their 3-month waiting list was wiped out the first time they did it for 17 families. Okay, so it means better access, better care. And with things like stigmatizing conditions like bowel and bladder problems, amazing for the kids to know they're not alone, the parents to know that other people are affected, and you're sharing and you're supported, and the problems start to improve straight away. Diabetes, hypertension, obviously these are important because they're common. Groups are more effective, very simple. They're at least as effective, but more cost effective in the worst studies, and they're more effective in some studies. The very biggest study was in China, in community, over 1,000 people in an RCT of a group intervention at the same size of group that we run, about 20 per group for blood pressure, better blood pressure control. Well, that has measurable effects on future outcomes, predictable. And then I mentioned the Scott study on multimorbidity, because lots of people think you can only do it if you've got one single condition, but that's not true. Everything went in the same direction, better direction, when you did it for multimorbidity. And there are systematic reviews, as you'd expect, supporting this. This is a recent one you can look up in my reference list. Here's an example I like to share. David Unwin, the low-carb GP, he runs groups, monthly groups for his low-carb diet, published his 8-year data last year. 50% of his diabetics, pre-diabetics come into the group, 50% remission in the people who do, with a predictor. If you see them early, higher remission rate, 77% seen early. But even when people had 15 years disease, it's still 20% remission rate. Lower weight, off the drugs for diabetes, off the drugs for hypertension, lowest prescribing costs in the country. So this is win-win, amazing outcomes without any expensive injections. So that's what we should all be doing. And this is our positioning for this. It's a value proposition for healthy aging, which needs to be embedded, yes, for pandemic recovery, but there's such high value here. We're looking at basically improving people's self-care, improving people's connectedness with or without technology. That means they spend much less time here, and here, and everybody's happier and healthier. Because we shouldn't be medicalizing the world. Everybody should be able to live their lives. This is the journal that we run, and this was the first special issue we did. If you want to scan the QR code, feel free. Compassionate Communities is all about changing everything, bringing ourselves together. And there's various, powerful articles in this. I'd flag you to Julian Abel and Tommy Wood's editorial, but every single issue in that article in that issue is well worth reading. That's the content. Social genomics, you heard it here first. So overall, this is happening, and a new government's going to be much keen on this. This QR code will take you to the Personalised Care Institute blog that's just published, which links into a lot of this evidence. Women's health I've mentioned. There's going to be a menopause toolkit going live shortly for the NHS. We are engaged with NHS England. We have one pilot site in Cheshire and Merseyside. Hopefully a new government will roll that out across the NHS. Very engaged with future outpatients, and hopefully we'll become embedded in the Further Faster programme as well. And this is what the patients say. They say they're more listened to, better access, better understanding, better decision making, more involved, would recommend to family and friends. On the left is the website for group consultations. On the right is the app, which allows you to download free resources once you register. So I'm just seeing people scanning in the room. Obviously online you can take screenshots, show them to your family. Once everybody's finished their scanning, I'll wind up, because this is my final slide, really. Come and visit us. Our meeting is the 19th till the 21st in September at the amazing Glass House in Newcastle. I'm just living opposite there at the moment. Amazing, inspiring conference. You'll be more than welcome. And this is what I've covered, and these are my references. Very happy to take questions in the discussion. Is that 15 minutes?
Yeah. Thank you very much indeed. I think that was excellent. It was a natural segue from Ian's presentation, and Alan and I have to say I'm not bragging about this, but I was a practitioner of lifestyle medicine before I even knew it existed, as I started practicing lifestyle medicine some 11 years ago. And it was really just to see if I could gamify my health by using wearable technologies. And at the time, the technology I was using was called a Jawbone Up, which measured my steps, my sleep, and I could put in what I ate. And what that taught me was the fact that although my 10,000 steps that I do every day, and I've done for the last nearly 11 years, are important, also sleep, diet, my home circumstances. As soon as I started when I was living on my own, so it was very easy to control what I ate and when I went to bed and everything. And as soon as I got involved in a relationship with somebody who likes a glass of wine in the evening, likes food as much as I do, my weight started to go on, even though I was still doing 10,000 steps a day. So I realized over a period of time, pretty much all of the factors that are your pillars of lifestyle medicine. And this really leads me on to our next presenter, Neil King. I just need to load his presentation up. So I'll do that, Neil, and I'm still getting used to using this technology because it has a dual screen, so you're not quite sure where the cursor is until you.
You'll be able to escape.
Yeah.
You're all forced.
Escape this. There we are. So I think we're there. And so I will load up Neil's presentation. Unfortunately, the audience don't see my messing about with the screen here. Okay, Neil, I just need to share. Your screen should be shared. I'll just check. Yep, it is there. So, so Neil, I should just introduce Neil. He will introduce himself, but the reason that I know Neil was because through social media, I saw quite a lot of adverts for this new gym called Longevity. It kind of piqued my interest.
Good at that.
And so I thought I would go along and just see what it was all about. And I was impressed by Neil himself, because pretty much when it came to exercise, strength training, diet and nutrition are also part of their practice. But the key thing for me, which is the reason I go 3 times a week now,
Doesn't he look amazing?
Yeah.
and so I've lost about, my weight was stable for quite a while, but I've lost almost a stone since I've been going to the gym without trying. And he will tell you about the way that his gym works. But for me, the great thing is that all of the machines in the gym, unless there's a problem with the internet, they are all synchronized. So you don't have to wait for a piece of equipment. You come in, you have your personalized exercises, which on each machine would probably last 2 or 3 minutes. So you can do 2 circuits in half an hour. And the results are amazing. On my phone, I will show you my longevity app, and I will show you, I'll prove to you that my strength age has gone
5 years lower than your chronological age.
well, it is. My strength age is 40. I'm as strong as a 40-year-old man.
Yeah.
So I was you.
When compared to 15 million other people in
Well,
that
yeah.
Right, okay. Thanks for having me today. I'm here to obviously talk to you about the longevity studio that we've recently opened up in Milton Keynes. Just a little bit of background about myself. I've basically worked in the health and fitness industry for 35 years. Finished my sports science degree back in 1989. Since then, been a cleaner, a personal trainer, managing director, chief exec. And between us, I think I preferred the cleaner and personal trainer than the MD and the chief exec. But look, recently we've opened recently we had a look around the fitness industry really, and our view, and this is a generalisation, is that 90% of the fitness industry in the UK certainly today focuses on people that are aged 18 to 35. Well, what if you're slightly north of that 35-year age number? So on that basis, we wanted to open a very different sort of physical activity proposition. So we've opened our very first longevity studio. We're coming out the end of proof of concept. If we get to the point where we're happy with everything and it works, we're then going to try and scale this business throughout the UK and throughout Europe. So we kind of refer to ourselves as a proactive, personalised healthcare company. We try and avoid the word gym, fitness and exercise at all costs, because it basically turns as many people off as it does on. And we're on a mission really to provide people with the tools to live a long, strong, active and healthy life. Our vision is to improve the functional fitness of over 1 million people, and we want to improve their health span, their quality of life, by literally adding life to their years, which is what we're about. We measure all of this through evidence-based bioweight assessments and a range of other scientifically validated tests. And this concept of evidence is really important to us. I think if the fitness industry is guilty of anything, it's about making assumptions about how fit people are, or how they're feeling internally. So everything we try and do is evidence-based. You get a start point. It doesn't matter if it's good, bad, or indifferent. But 4, 12, 6 months later, we can reassess an individual person, and we can provide some evidence-based feedback as to how they're progressing and how they're getting on. So there is tons and tons and tons, as you guys all know, of science and tech that's kind of out there in the longevity space at the moment. And in fact, the more I've got into this, and I'm pretty new to this, and I do not claim to be a clinician or a longevity expert or anything like that, but the subject matter is fascinating, yeah? And there's loads of money going into it. What we're trying to do is bring some of that science and tech to market and make people aware of some of the things that are available to them, which up until this point, they may be unaware of. And the whole outcome is to try to increase the health span and the quality of life and help reduce people's bio ages. We are advocates, and again, this is new to me, but we're definitely advocates of medicine 2.0. We're advocates of prevention, not cure, although at the moment we do spend a lot of time in the cure zone as opposed to prevention zone. We're all about improving functional fitness, improving quality of life, and as Fraser said earlier, mentioned a couple of times, in this active aging space. And I've got a couple of books up there. I think the work that people like Peter Attia and David Sinclair are doing, not only is it fascinating and thought-provoking, but it's really going to change the way that we age over the next sort of 10, 20 years. And we're trying to bring some of that thinking and some of that science in the simplest way possible to our customers that we've currently got up in Milton Keynes. So why now? Well, 1 in 2 of the population is going to be over the age of 50 in 2030 in the UK. And our view is that, fundamentally, normal aging isn't normal. Some of you have probably seen the Netflix series, which I love, the Live to 100, the Blue Zones, yeah? And in it, the presenter, Dan, I forget his surname, but he basically talks about how we've engineered physical activity out of our lives, yeah? We wake up in the morning, we go down the stairs, we put the kettle on. We come back up the stairs, we sit in bed, we watch breakfast TV, drinking our cup of tea. We walk 5 paces, into the shower, which is now in our bedroom. We get washed, we get dressed, we walk down the stairs, we get in our cars, we drive to work. When we get to work, we sit at our desks in front of a PC. If I do, this is personal, if I do a normal day's work, I walk about 2,000 steps a day. I have to physically do something different in order to get to the point where the physical activity that I'm doing has any benefit whatsoever to my health. Yeah, we've 21st living, we've engineered physical activity out of our lives, and we need to get it back in. So our solution then, we've got a small studio in MK, 1,200 square foot. We've got a science-based solution which covers the key components of health-related fitness. So we look at all of our customers, we look at levels of muscular strength, mobility, flexibility, cardiovascular fitness, and metabolic health. Metabolic health being a really important indicator to overall physical fitness and physical health. We have evidence-based biological age assessments. We do results-orientated fitness programs, loads of educational content, and access to specialised quality coaches. And it isn't actually that complicated. As Fraser said earlier in his presentation, it is about making sure you've got the right nutrition and diet. It is about making sure you've got physical activity in your life. It is about sleep. It is about stress. It is about family connections and social. It may not be that difficult in theory, but it doesn't mean it's that easy to deliver in practice. Yeah. So at the core of our brand, as I mentioned, we've got a muscular strength training circuit, resistance training circuit. And for us, strength training is the elixir of life. The benefits of strength aren't just about being strong, although frequently that is the reason why people become frail and infirm in their late 70s and 80s. My parents sadly being an example of that. But there are so many other physiological benefits to strength training that we need to tell people about. Yeah, because if you don't know, you don't know. So strength training, just a couple of them. If you are a regular strength trainer 2 to 3 times a week, there's more going on than just building muscle size. You're oxidizing fatty acids, lowering traditional triglycerides, helping to reduce cholesterol. Your body produces endorphins when you exercise. That improves mood and mental health, and it helps combat anxiety and depression, and so on and so on and so on. So many benefits to regular physical activity and to strength training. So that's at the core of our brand. But then around it, I mentioned earlier, we're trying to commercialize some of the science and tech of longevity. So around that, we build a customer journey. So if our customers want to, we do DNA and epigenetics testing, and then we have a whole different lifestyle conversation with our customers when we get those results back. We do things with omega-3s and 6s and cellular health. We're about to begin doing stuff with gut health and cognitive fitness, so brain health as well. So bringing all of those things together, we're beginning to build up a consumer proposition for people that might be over the age of 40 and who are just as interested in what's going on the inside of their bodies as opposed to what they might look like, just from the outside. So our market, our youngest member's 38 and our oldest is 87. We do get some people who join our studio that are already longevity advocates. But that's not a widely known message yet. Yeah, but a lot of people who join have been inactive for many years. A lot of people join, simply don't like going to gyms, and a lot of people who join have got a range of different medical conditions as well. And as Fraser mentioned in his presentation, we're already starting to see people move away from being pre-diabetic, beginning to come off hypertension medication, because the benefits of physical activity are making a difference in their lives. Tech in process, well, we're in the process of developing an app which is going to deliver everything that I've just said to people that aren't in a position where they can use our studio. It will be based on muscular strength, but you can do strength training in your bedroom or your lounge or your kitchen at home. You can use body weight, and all of the sort of features of the proposition that I've just mentioned will be available via the app. And on average, people who follow our programs for 12 weeks reduce their overall bio age by 7 years. So technically speaking, that's an extra 7 functional years that they've just added back into their life. Because at the end of the day, it's not the years in your life that count, it's definitely the life in your years. And that's us. Thank you very much.
Thank you very much, Neil. It was interesting. Has anybody got any comments or questions to Neil before we move on to the next presenter?
Thank you very much. That's great. In terms of your outreach and marketing and people finding you versus you finding them, what has your strategy been?
Well, we messed it up completely when we first went to market, because everything that we were doing was all about longevity, slowing down, reversing aging, compare your bio age against your chronological age. No one had a clue what we were talking about, to be quite honest. So we flipped all the marketing messages January time. Now they're much more specific, largely around, well, we got one marketing stream, which is all about a range of different health conditions and how we can help. There's another marketing stream just about, do you want to still be your best when you're in your 80s? And then we've got other marketing streams all around people that don't like gyms, people that haven't got time to go to the gym, and those sort of messages. Yeah.
I'm Anthony, by the way. Nice to meet you. Do you do anything with virtual working out?
So we don't at the moment, but as I mentioned, we've got an app in development at the moment, and virtual workouts will definitely be part of that.
Okay, yeah, I'd love to chat with you about that. I know during COVID that it was really big, Joe Wicks and things like that.
Yeah.
So I think there's really important. Yeah.
Okay, well, we're still playing with the technology to load Andrew's presentation. So just keep talking.
In terms of your attendees, do you find that once they've joined, they stay, or is there a reason for a little attrition?
Well, so if you compare the average length of stay of one of our customers, it's significantly higher than the average length of stay of the normal fitness industry. And the reason for that, I think, will be twofold. Number one, we're dealing with a slightly older clientele, so they're a bit more settled and they're not transient and all that sort of thing. But also, they're there for a reason, and they kind of know that, our mantra is, if you're 65 now and strength training in our studio, you need to be 85 in 20 years' time and still strength training in our studio, because you should never stop.
I mean, I think as a medic and an oncologist, I deal with cancers.
Yeah.
One of the tantalising things that we're dealing with is there are some people who have difficulty, making those changes. And are often in the predicament because they've obviously had habits form and environmental circumstances that make it very difficult to change.
Yeah.
And obviously, it's making those sort of inequalities, I suppose, in terms of their mindset, a little bit more plateaued,
Yeah, I guess the people that we see have come to us in the first instance, they've made that initial effort to actually leave the comfort of their own house and come to the studio. But you're welcome to come and have a look at any stage. But we only allow 8 people in the studio at any one time. It's very personable. There's always a qualified member of staff there. The main reason that people come to begin with is normally some sort of physically related outcome. After a few weeks, it's all about social. It's all about inclusiveness. It's all about being part of a community, and it's all about coming to meet their friends. Yeah.
Okay, thank you. Well, we now move on to our next presenter, Andrew Cowen. If you'd like to introduce yourself, Andrew. I explained the reason why I invited Andrew, because it seemed to me that we had the first 3 presenters were all dealing with very important different aspects about healthy living. Ian with the environment, the built environment, smart homes, etc., creating the right multi-generational atmosphere. We've got Fraser talking about group consultations and lifestyle medicine practices, and Neil talking about the strength and the holistic approach to this new gym. Andrew has been involved in wearable technologies. That was the reason why I invited him to speak. So if you'd like to say a few words about yourself.
I'll take it away. You need to give me 5 minute notices because I can grab it.
And don't worry, I will stop you.
Well,
you've only got 4 slides, so
yeah. But a bit of a background. Well, first of all, let me say that I've just come back from the Global Indian Forum, introduced by Ben Thompson, and also with the Shadow Secretary for Foreign Affairs, the Labour Party. What's his name? David Lammy. And everything that you said today should be transposed to that conference because it was just amazing, the cerebral, high level of some of what you're all working at. My background is a little bit more sort of, I'm dyslexic, I'm a disruptor, an innovator, coming from a very wide and diverse background. I won't go into that, but my care journey has 2 areas. One is when I was looking after my 2 children while my wife developed a career as a translator. And then when I was post various serial entrepreneurial endeavors, I was working at IBM. My mother was diagnosed with Alzheimer's. That was in 2000. And I ended up being a family carer for 5 years. So walking into the sector saying, where is the technology here? I mean, the silly thing you wore around your neck. And if you're a dancer, which I am, you know that if you fall on your hands and that thing gets buried and you can't do anything. Not to mention the fact they don't even use the button because they forget. So I was dealing with all of this issues around home care. I developed my own home care agency. I was trained by the Alzheimer's Society. And over the years, I've known David and Ian, amazing amount of progress, and what you've achieved is absolutely phenomenal. So hats off to you. We've changed as a company. We started off with a wearable device that I thought that would be for pediatrics, neonates. I was told we couldn't do it. We had to go to the adult version first, which threw me back into my background. Running a home care agency specializing in dementia, supporting families and those service users. We then changed the dynamic of the wearable to a chest device, supported by Arrow, which is a $30 billion business. And I was then given one of their senior engineers, also a serial successful entrepreneur, to second it to our business to help us develop this technology, which I will go into in a minute. And that entrepreneur stroke engineer has brought in his team. So David and Ian, we're a completely different company as of February, and we have some serious serial entrepreneurs, heavyweights, not to mention 10 years consultancy with Tata Services Consultancy.
Arrow is good.
Well, yeah, I mean, it's amazing. I just feel so excited and honoured that these guys want to work with me. I'm a bit of a visionary and a bit off the wall, as Ian will know. He hasn't worked with me for, known me progress over the last sort of 5-10 years. So, what I believe is that we've reached what's an inflection point. It's not me, it's the only one. Technology is converging. We all know that. I don't need to tell you the references, etc., etc. The problem, my stall, I'm setting it out here, is that I actually believe regulatory, although I believe in regulation, regulation is actually one of the barriers for us moving forward. And my take on that is that why are we not using the data coming out of these amazing devices? And don't mind about my device or approaches. There are fantastic devices out there that are delivering fantastic high quality data. The problem we have with regulatory is that I'm not interested in the device. If I'm a GP or a technician or a clinician or a health professional, I just want the data and I just want to know it's accurate to a 2B plus standard. That's it, finished, job done. But unfortunately, the health professionals cannot accept that data because of the regulatory processes, the nightmare. So that was my stall at the Indian conference, and seemed to have gone down quite well. The other issue is that we've got a multidisciplinary and fragmented society where actually the little itsy bitsies of 4 or 5 years ago, pre-COVID, actually don't work, because the requirement and the AI integration of those itsy bitsies is a lot more complicated than we even think about. And working with these guys from they've got 250 years of IT experience behind us, which is a lot of time. These guys are serious. They say it's all very well saying open APIs, but unless you actually have done it, trying to integrate data is a mess, a total mess. Anyway, I'll talk to you about that later, because we're talking about a thing called with Richard Foggy of Innovate to talk about interoperability. So when we talk about a problem, we've got to take it in a much more broader context, which is all of what you're doing, which is really lovely and it's wonderful to see, and I want to be part of it. But that's the issue. It's the interoperability of this data. And then the last point I'm making is the education. Without the education, the only place that I've seen real data integration is at Imperial. And I was very fortunate in being able to write them a letter saying, well, I think this is really important. And they got a massive amount of funding for a helicopter. David, you will know about this, a helicopter initiative where not only are they pulling together all the data that exists within the university, but they're educating the professors and the lecturers. And it's going to break down the silos. If you've ever tried to work with a university, you've got absolute silo mentality. We're working with Sheffield Hallam on a data lake with Google around one of our technologies. I need you to talk to engineering in Sheffield University. So you've got 2 universities back to back, side to side. I need you to talk to engineering. It's taken me nearly 4 months. Not even, and we're not even close. It's a nightmare. Anyway, so AI is going to throw it all apart. Our proposition is we need to talk. So hence the art of the impossible. Oh yeah, I'm going to do this, don't I? Just right down. Oh, there we go. So what we want to do is talk to potential people who will collaborate with us, because without collaboration, you can't do anything. It's too complicated. And the data issues that you want to get out of it, that we all want to use, is very multiple complex. So previously, as I said, I was working on a wearable device. I thought this was going to be amazing. It's a chest device. It's got all your vital signs. It's a walking ICU. I don't care about what you call it in terms of a CE mark, but the data is class 2B, finished, job done. Second is it's got a stethoscope, because if I'm a GP or a health professional, there's no way I'm going to give you a diagnosis unless I can listen to your heart and lungs. So not only do we have this device that's got a 5-channel, multi-channel stethoscope in progress, but we can actually democratize the stethoscope. So we can actually change the sound to a visual and then bespoke visual to an individual own lung and heart. Now, it's a complicated issue. It is very hard and technical, but if nothing ventured, nothing gained. And there's no such word as calm in my language. So this stethoscope has an integral part. In addition to the stethoscope, we've got a chemical signature sensor, because we want to test that if we can detect chemical signatures from exhaled breath. And that's where the chemical signature sensor. But this device that we're wearing is extremely complex to put together. I've been humbled by, in terms of being a disruptive visionary into what is happening and is practical and can be done within time and budget. So what we're doing is we're looking and working with a chemical signature sensor to identify mold. That's a multi stakeholder problem. There is legislation around Iwis law, if I pronounce that correct, where a young child died from a black mold respiratory condition. The stakeholders are obviously your landlords, your property developers, but also you've got the legislation around it and the litigation against those who are perpetrating poor quality housing or not responding to mold within the property. You've got the housing associations, social services, housing, and then you've got the actual NHS itself. The hypothesis, it is a hypothesis, is that if we can detect the chemical generated from the pathogens from the mold, we can associate that with actually the mold within the lung. Then you've got a way of claiming back money from the cost of care to undertake the medication that is as a result of that mold. And this goes for young people, aging anywhere. It's not 5 minutes. Oh my gosh. Okay. Secondly, we're looking at new schools. This is all part and parcel of a project that we're working with a retailer in looking at how they can deliver healthcare through the retail high street. These guys are already working with it. They brought in the business, and these elements are part of that process that we're working with the retailer. New Schools is a national system to measure, everybody knows what New Schools is. So it's a national system of monitoring vital signs throughout the secondary care process. Why aren't we using that knowledge and technology, or lack of technology, shall we say, to put it into primary, secondary, social care, nursing homes? If we had a pathway, and it could be that we could use it for small, for consumer apps, whereby we can maintain the same method of monitoring throughout the whole care path journey. And that's really exciting, because then you've got a constant data source that fits in with the NHS system rather than trying to fit up and work against it. So we're working with the systems. And the last one, there is a triage element to the nursing home, which is interesting, but I won't go into that. And then the third element is stress. So we have the wearable device. Yes, it can do all sorts of weird and wonderful things. I'm very interested in mental health and how we can use and detect stress through the telltale signs, physiological telltale signs of stress. And we're doing our first early stage trial with UCL on how we monitor 3 examples of generating stress and how we can then extend that later to a much more complicated, integrated process of applied to post-medical trauma, post-medical intervention trauma, maybe helping people to maintain and be sustained on a drug abuse program, rehab. You're talking about all sorts of femtech issues, et cetera, et cetera. So it's not rocket science. Stress is a real problem. We don't have an accurate way of measuring it that relates to physiological hard evidence that we can point to and address and say this is an issue that can be used by clinicians. So the art of the possible. These are the people who are going to be delivering it. As I say, it's a whole new board coming from my colleague working with Arrow. These guys have got 250 years of experience. One of them is, I'm very fortunate, I've got 2 CTOs. One that developed all the technology for mobile payment and ticketing systems in the UK. Fantastic. Worked with COVID, one of the top 10 companies in the world that instigated a track and trace system. And also he was one of the first people to develop the computer, the chip for the Acorn app, which went to ARM eventually. My other CTO is, again, worked with 10 years with Tata Consultancy Services, who Ian will know very well. Serious transformation, integration, systems, analysis, etc. The CPO is Arrow. All these guys are serial multiple successful entrepreneurs. Then we have the ex-finance director from Siemens, and someone who you may all be very interested in is a colleague called Robert Foster from Red Ochre. He is an expert registered with Hansard, and basically he's into social impact measurement, return on investment, and theory of change. None of this will happen unless we understand how it changes society and how services are being delivered to meet those objectives. And that's that guy, amazing fella. Look him up, he's brilliant and very, very approachable. So I would love to work with you. We're very small. We are very influential, as I've been around a while. I know people. We are moving slowly, steadily towards those end objectives. We're working with various universities to deliver the services and the initiatives that we're working on. How can we work together? Thank you.
Okay,
Any questions?
thank you very much.
You forgot to say, and very persistent.
Pardon?
Yeah, very-
Well,
very
say it
persistent.
very
This is not always a bad quality. Though.
Well, Ian, come on, Ian, you know, I might be doing it slightly different. You're at the top level. I'm working, you know, at the hard end of the coalface.
I admire it. Well done.
Well, thank you, thank you, thank you.
We do have a couple of the other speakers who are actually online now, but they've actually muted themselves and switched their camera off. So I presume they've gone for a cup of coffee. But I was going to test the technology out and bring them in to the conversation, see if they have any question. So we are at our scheduled coffee break. There is coffee break there. There's some coffee on the side there and some fruit. If you'd like to help yourselves. And I don't know whether people would just like to go around the room and introduce themselves. Most of us introduce himself. Would you like to just introduce yourself?
Yes. My name is Mustafa Latif. I'm the president of the IKSAD Institute of Economic Development and Social Research. Yes, thank you very much. Thank you very much, Mr. David, for your organization.
Okay, Lisa.
Yes, I'm Lisa Forrester from Language Line Solutions, based here in London. We specialise in medical and life science translations, so very much within this sector. Just here to find out as much as I can.
Sure.
Thanks for the invite.
Cheng Fen.
Yes, sir. So my name is Shen Fengqin, professor in North Design School. I work on design for well-being, mental health, and emotion. I'm really looking for the collaboration with David. We already have some collaboration looking for the proposal that really about this, the wearables. We cover the wearables. So one is human wearables, is machine wearables. We're looking for the office and the working force care with the wearables. We cover wearable in two terms. So one is for the machine or object with the wearable, and also the human wearable. I really like the total aspects. Yeah.
Okay, and sorry, I don't know you. So.
My name is Elisa Gabolsa. I'm from Albania, and I'm a nurse in profession, but I'm working for almost 12 years as a lecturer at my university, University of Corta.
So yeah, you're doing a presentation later on. Yes, yes. Mary.
Hi, my name is Mary Akube, President Zenith Global Health. We established to bridge the Global South, Global North divide, and through partnership, collaboration, and shared learning, and then foster health equity. So we work across UK, UAE, and Africa to enhance healthcare provision and innovation and technology.
And
So my background is nursing. I'm a specialist in minimally invasive surgery and robotics.
And you'll hear from Mary later on today, but she's doing some remarkable work in Africa. Ian, you've introduced yourself. Sarah?
Hello, yes, I'm Sarah Partridge. I'm a clinical oncologist at Imperial Healthcare NHS Trust, but I've also had a long-term fascination in hypnosis, clinical hypnosis, set up Transform Medical with a rather aspirational mission, and we'll be telling you a little bit more about that, and I'm really excited to collaborate with many of you here.
There's a next session, the power of the mind and mental health. We've got some great speakers to I know there are other people in the room know about as well.
Yes,
Skip.
Yep. I'm Dr. Anthony Skip Basil, Bournemouth University. My area is research and learning technology, so I'm happy to chat with people about that.
Tre, you want to say a few words about yourself? You'll be on in a minute.
Hi, I'm Tre, founder and CEO of Myndplay. We're a UK-based brain technology company. We create a wearable BG headset and a number of applications for mental health, brain training, and research.
Okay, Andrew? Yeah, he's- Don't give you another chance.
Hi, I'm Helen. I'm a clinician by background, physiotherapist, and work in neuro rehab and rehabilitation across the spectrum. I'm also the one of the people that founded the Mint Academy, which stands for Masterclass in Neurotechnology, where we provide the clinical partners for people who are developing devices by kind of working with them, advising them, and providing the clinical research trials with patients.
And Helen will be speaking this afternoon. Ellis, you're going to be talking in a minute, but please introduce yourself.
Hello everyone, I'm Ellis, engineer by background, but also CEO and founder of Neumind, and we're a technology company trying to make it easy for providers to deliver gold standard neurocare, and you'll hear more about that in a bit.
Okay.
Hi, my name is Serdar Demira from Turkey. I'm a professor in theology from Khaldun University.
Thank you very much. Well, there is coffee served there. If you'd like to help yourself, I'll just put a banner slide up on the screen. Give us a 5-minute break and just let people know we're just changing the presenters.
Next,
doesn't really work for me. Adam, can you hear me okay, Adam?
Hi.
Hi, Adam. Yeah, we can hear you. I've just been getting the individual people just to introduce themselves. So I just wanted to check your system is working okay. You can hear us.
Yes, yeah, I hear you loud. Yeah, loud and clear. It's very good.
You'll be on this afternoon. You know the time of the presentation.
Yeah, it's all good. Yeah, I do have to. I've got to go into a customer call around over lunchtime, but I will be back in time to hold the afternoon session.
You're scheduled for 2:30.
Yeah, fine. Yeah. I'll be back straight after lunch.
Well, if you are online, then when we have a Q&A, if your camera is on and your sound is on, then I can, if you want to ask questions, you'll be able to ask questions to speakers.
Perfect. Yeah.
I'm just going to bring also Rebecca onto the stage as well. Rebecca, you're muted at the moment, but if you'd like to unmute yourself, just so we can. Yep. Okay. So we can see you, and you are on in about 3/4 of an hour. Yeah, you're on after the first two presenters, but please join us and watch the other presentations. Okay, so I will take you out of the studio now, so people won't see you. But please don't go away. Introduce you on your Okay. Thank you. And the same with you, Mark.
So appropriate. I'm going to shoot.
Thank you so much for taking it. Very good. There is a live feed. Can you send it? Well, yeah. Share. It's on LinkedIn. So if you find me, you should be able to. Yes.
That's just around experience.
Oh, do you want me to send you the link?
That's the system there. So it would be so the one would pay for the center to go into the cheap extensively use that. So how do we use
So this is roughly what this company 360. So you no, he did originally say, but I think he's very cheap. He's got a yeah, you cycle from the station. Yeah. Very nice.
When are you coming in September?
presentation to the screen and choose the layout. Okay, away we go. Ellis, would you like to introduce yourself? I saw Ellis and his twin brother at Helen Hobbs Rehabilitation, and I was very, very impressed by the story. It was very, very moving and inspirational. So I'm really looking forward to what you've got to say.
Thank you very much. So, yeah, hello everyone. My name is Ellis. I know I just introduced myself, but the company that I founded with my brother is called Neumind, and our real mission is try and make providing gold standard neurological rehab simple, because it is certainly not. And the reason why I got into this is my brother Luke. So this is my identical twin. He suffered a brain injury back in 2012. He had to learn how to walk, talk, feed, wash himself all over again. You know, it really is one of the most difficult challenges that someone can go through. And as a caregiver, being with him kind of every step of that journey, and it really is like, you know, the caregivers outside of that acute phase who are ultimately the ones who are there delivering that support day to day, and they're also the ones who are perfectly placed to help support not only their basic needs, but try and help them towards independence. So Luke's not alone, and I've got different conditions here, and I'll explain why I'm going to bring these together. But this is a huge global problem. 275 million people living with a neurological injury or condition, and they all will likely have short or most likely even chronic long-term problems with memory, fatigue, emotional regulation, and a really important one actually, insight awareness into their own condition. And you know, these are huge numbers, but imagine waking up and not, you know, knowing what day of the week it is, how to use the dishwasher, perform simple tasks. So these are the challenges these people face every single day. And when you factor into the caregivers, this is a huge, you know, 500 million plus, actually bigger than that. And put this in perspective with other kind of, you know, in vogue conditions like diabetes, blows it out of the water. And by this is actually 2050. So excuse that. It could be about, I don't know how the population of the planet can support, but it might even be 100 billion by that distant future date. But yeah, what is kind of like effective? You know, what's going on here? It's different companies coming in to this massive problem from different angles. And I've got neuropsychological rehab at the top there because this is what is considered the gold standard. It's what where my brother got fortunate enough to go to an NHS funded centre. It's now closed due to funding reason, but it is the most effective. It's gold standard, as I said. It's very versatile across different conditions because it's focused on that individuals based on their values and their goals, and it's a program developed around those unique challenges, and it is complementary. You don't get good outcomes by just applying one of these things. You apply these things, you know, some great recent innovations in AR, VR, cognitive training, but you get the best outcomes when it's combined with a specialist-led program. The same application, if you look at even some of the latest drugs being released for dementia, the outcomes are not very good when they're just given in isolation, and when they're given with a proper program, you know, you get up to 10 times enhancement of those outcomes. So the problem is also it's incredibly expensive. This is a multidisciplinary team. Often you might even have a ratio of 3 to 4 specialists per patient. Capacity is limited. So, you know, the effects of this really is that the majority of people don't get the care they need. And if they do get the care, it only lasts a matter of months or weeks, whereas they will live with these challenges for the rest of their lives. So this should be treated more akin to a lifelong problem like diabetes is managed, not an acute issue like a physical rehab problem. And the impact this has, really, the burden gets picked up by family members. So this is on average 8 hours a day, and someone's talking earlier about their father who had dementia. This is something that 1 in 3 of us in this room will become a caregiver in this field. So it's something that we really want to pay a lot of attention to. So why is this system failing? And I could probably have listed about 50, 60 problems, but I'm trying to kind of simplify this because you need that simplicity in order to then make a change. So in the neuro field, 6% of clinicians still rely on paper-based methods, primarily the adherence to therapy. So prescribed therapy, go do these exercises, do these times, is incredibly low, and it's also got the highest portion of time spent on non-patient tasks and admin. Like why? Again, there's many reasons, but some of the main ones is that these individuals have cognitive impairment. So you can't expect them to deal with or interpret education, therapy prescription in the same way as the general public. And also, unlike physical rehab, where there are digital platforms where you're able to digitally deliver and remotely monitor this, in neuropsychological rehab, that technology doesn't exist. That approach hasn't been developed yet. There is some great brain training stuff, but it's difficult to relate that directly into real world, everyday living. So this is a big slide, but I'll just want to kind of pull out some of the key points here. But it's a process of developing understanding and awareness in that individual, and then developing strategies to help them manage and overcome. And in the field, again, it's simplifying things, but you have compensatory strategies and you have restorative strategies. So restorative strategies is actually improving that cognitive functioning, brain training, cognitive training, physical rehabilitation. Compensatory strategies is a little bit more nuanced, but actually longer term result in better outcomes. And they are internal, so thought processes, behaviors. We have, all of us, many ways of, we get a problem, what do we do? We feel anxious, what do we do? These are these internal strategies that we've developed in our brain, and also the use of external ones. And what is cool is actually these two things are much more linked than we think. By doing certain training, you can develop internal thought process and strategies, and by doing the internal, you can actually make neuroplastic change. So where did we start as a company? And there's someone in the audience who's been alongside this journey for a very long time. So we got some grant funding from Innovate UK. It's the first thing to kickstart it. And Ian was my monitoring officers. We've probably seen some of these slides, but my brother got a paging device, and it was used in rehab to practically support as medication reminders kind of stuff, but also reinforce some of the therapies that he was doing in the centre back home. So we took that and we just thought, right, let's just put this into a mobile app as kind of V1. And we added some stuff where you can add your caregivers. We did location trigger prompting. We did some space retrieval, and it was effective. But really, we needed users. So we managed to get this out there for free. Lots and lots of data that we used to then inform the next kind of iterations of the product. And so I'll go through this a little bit quickly. I'm not sure when I started, but let me know.
Okay.
So people need guidance that is relevant, easy to action. It sounds, in hindsight, it sounds so simple. But with someone with cognitive impairment, you need something which is a simple, I hear this, I do that. Like, it needs to be absolutely timely, and there needs to be a clear action associated to it. And professionals have been at delivering this. So when in our app, those individuals who are connected to so in their care circle, they had a professional. The engagement, the usage, the way it was used, it wasn't just used for simple, things that you might use for Google Calendar for. It was used to improve the adoption of their therapies and integrating them into their everyday life. And there's also this big area around accountability. Any technology in this field needs a foundation of cognitive support. And I'd like to put this here, this is simplified, but if you're not dealing with some of these bottom kind of pillars, you can never get to these higher points. And healthcare delivery needs in this field you need to account for these bits from the kind of bottom up. Otherwise, it all falls down and nothing will really kind of get ingrained, and you won't get those outcomes. And I find designing for engagement is critical. And like one of the reasons I think like brain training is a great example of how you can really incentivize and gamify. And the engagement in those things is brilliant. The more boring kind of therapy tasks, keeping a log of what you've been eating or fatigue is nowhere near as fun. So how can we bring some of that gamification in? And we did some experiments around memory challenges, which I can go into a little bit more detail, but it massively drives engagement in the platform beyond just that individual user feature. And obviously, drives of both of this is personalization and involving nearest and dearest. And by that that's quite a subtle point. That is, if someone is just aware that these are the challenges that are important, this is what you're working on, it's as simple as a little, you're making lunch for someone and said, oh, have you done this? Have you done that? That kind of stuff, those little conversations make a huge impact. So it's getting those people coordinated and kind of, on the same page. So for that kind of simple app that we developed, we got some more, really it was capitalized by some grant funding, we also got some external funding, and we began a collaboration with some clinical leaders in this field to really add an element in. And we wanted to kind of address some of those lessons, but we knew we needed to integrate into the care pathway. This isn't something that you can just give someone 3 or 4 years after an incident. It needs to be part of that rehab journey. So we teamed up. We did a huge amount of discovery work at the Wilson, which is a very good specialist neuro rehab centre. And we were basically just sat in the background observing a group of engineers and designers with some lived experience, but just kind of involved. A lot of it was specialist one-to-one sessions, but also group sessions, lots and lots of interviews, and lots of Zoom videos to go through. And so what we have now is a two-sided platform for the patient and the caregiver. That's a companion app, and this combines this cognitive tools. So there's a kind of suite of tools powered by some of the recent developments in AI, and that's there to support daily living and independence, but also form that basis of how they can use the therapeutic content that's delivered on the app, so improving that usability. The therapies that are delivered are personalized, engaged, and this uses some of the data that we collect on the platform, and also provided by the clinician, which you'll see in a bit. And there's a caregiver portal, so a side of the app for them, which gives education, also lets them remotely kind of manage and see what's going on with their loved one. And for the professionals, the dashboard to help them deliver some of these strategies and reinforce them outside the clinic, track progress and goals, and finally automate some of the clinical tasks and admin. And this is just like a little example of one of the strategies that used to be used for remembering something. So this is actually what young people unfortunately get. They've got a serious memory problem. Why don't you try this thing to remember this, your carer's number, and we can turn it into something with a single tap, and it generates confetti and a score, and people love it. So we've got a group now of early adopting customers, some in the US, some in the UK, and we're getting some really, really nice results. So 2 times improvement in memory. This isn't memory in terms of a artificial context. This is things that they want to remember. So examples might be, a joke to tell friends down the pub, or how to use their dishwasher. So we're getting some really nice real examples of that. Therapy adherence is increased to 82% for tasks that are delivered on the platform. 85% of individuals and caregivers report improved independence after 30 days. And finally, we deal a lot with the US. That's where a lot of the investment in this field is coming from. You need an incentive for the provider to adopt this. So recently, there's been some new CPT, basically billing codes for those who aren't aware of the US system, which are used heavily in other fields, not used in neuro. And what we can do is the tasks that they're currently doing, by doing a little bit of kind of clever use of these codes and re-applying them, we can turn that non-billable time into billable time and incentivize adoption. So what we're trying to do is take, this gold standard, try and reduce that cost, whilst also trying to add value. So we can reduce the cost up to 50% whilst trying to improve quality, duration, and support that caregivers provide. So I don't know how much time.
5 minutes. 5 minutes, max.
5 minutes. Okay. So what next? I mean, we've got we're doing a fundraising round at the moment, which is big. But what I want to focus on, which is a bit more kind of maybe interesting to you guys, is what is this next generation technology? So obviously, as an engineer, I've got very excited the last few years with AI actually becoming useful rather than just being this thing that we kind of saw in movies. And I won't go through this, but effectively, where you've seen the greatest leaps is the large language models, and this is the kind of that you're chatting face with something, and it's so effective because it is kind of mimicking many science believe it's mimicking how the human brain operates. And what is really, I think, the advancements is it is now really accessible and easy to use. And I think there was a talk earlier, I'd love to go into a bit more detail about like what's the next steps for it. But where we're looking at it is, accessibility. These things on the left used to be super, super difficult. Now, with a few API calls, you can turn text to speech, you can generate a custom image. Maybe someone wants to conceptualize a bit of information you want them to learn. You can simplify information, and you can do this also in a personalized way. So you can take someone's they suffer with these impairments, and then you can use that to really personalize that. In terms of ease of use, like automate many processes, reduce the number of taps that someone needs to do, have adaptable UI. This is all stuff that is, I think, coming. And for us, when this is stuff that we do now that going to support, helping sequencing, scheduling, this idea of a cognitive assistant used to be a massive engineering challenge. It is now feasible. And what we like to do also is provide kind of real-time support for users of how they can use our solution in a way to give them maximum kind of therapeutic value, and also in the recommendations. The challenge around this really is it's an engineering integration challenge, which is where I think that I see the future of this going. A lot of this stuff is possible, but the amount of different platforms that people use, for example, if you're using ChatGPT, I want to send an email, you want ChatGPT to send that email, and that is this it's an integration engineering challenge. But yeah, I think we're gonna see a lot of this in the future. And I'll just finish with my brother Luke. So this isn't me. I can nowhere near as fast as that. But he's made a brilliant recovery. A lot of that was thanks to getting that gold standard care. But he was one of the lucky ones. What we want to try and do is help the millions who don't get that make exceptional recoveries like Luke. So thank you very much, and hopefully chat with you all later.
Thank you very much, Ellis. It is an extremely inspiring story. So now I'm going to this while you're doing.
The question is, you set the scene by going far beyond your brother's condition, and you talked about dementia by way of example.
Yeah.
Where's the connection?
Yeah, we actually have about 15% of our users are dementia. So we went kind of condition agnostic. We looked more at the services that are out there. So a lot of these services, neurological services, they won't just deal with stroke, they won't just deal with ABI, they deal with people who have some neurological condition.
But it's a different approach, isn't it? Because one's a recovery and one is really will have to be prevention.
Yeah. Well, So that idea of the compensatory strategy, that's our kind of focus. And that can be very, very effective for people with dementia. So it's like adapting their environment, trying to get routines that allow them to still operate or get value out of their life, despite memory issues that will decline. And actually, if you get those in place earlier on, it can lead to longer. They can live longer.
Independent.
Yeah, independent.
So put it into your going back. Thank you.
Okay, thank you very much. Now we will bring in Sarah, if you would like to introduce yourself, Sarah.
Oh, thank you very much. As I said, I'm a clinical oncologist based at Imperial Healthcare Trust. I'm currently on sabbatical, however, and I'm trying to take forward a long held and implemented passion for clinical hypnosis, which I have found very transformative, not only personally, but for many of my patients. And so I'm hoping to tell you a little bit about that. My other roles are within the RSM, the president of the section of hypnosis and psychosomatic medicine. And I've been talking around the country in that capacity as well. But I'm also founder of Transform Medical, which is my my wish to try and get this out there in a much more meaningful way. So it's wonderful to collaborate with so many people who are probably further along the route than we are with this. And I think maybe many of you in this room have probably heard about hypnosis in the media, rather than actually in any way through your training or education to date. And indeed, actually, it is the wider medical profession who is not sufficiently aware and somewhat held back by many misconceptions, which are often born of stage and film representation, which is somewhat scary, really. This is nothing new. We know hypnosis has been recognised in various ways. It was initially introduced across the panel by Franz Anton Mesmer, who coined, well, he didn't coin, but we've coined the name mesmerism for somebody being entranced. But it was James Braid who coined the word hypnosis, which again is a little bit of a misnomer because it's not about sleep. But when it sort of was realised that it had some really fascinating properties, many clinicians got very excited about it, one of whom was John Elliotson, who founded UCLH. And he had a couple of very highly hypnotizable sisters who he demonstrated upon. And such was his enthusiasm that he actually hacked off quite a lot of his colleagues and they forced him to resign. So we went off and set up a mesmeric hospital that did an inordinate amount of good in an age where medicine was quite limited. But another of these clinicians was James Easdale, and he was a surgeon who had a big practice in Bengal in India. And he had a number of assistants that put all of his patients into deep hypnotic trance when they were thereby hypno-anesthetized. And he was able to undertake painless operations in an era where they had no anesthetic other than alcohol, perhaps. And he wrote back and said that in his knowledge, he had seen no bad consequences whatever arise from people operated on in mesmeric trance. Indeed, they actually healed very quickly by first intention, and in the rest, they had no subsequent problems at all, even less pain after the operation, not even a death. Now, if you look at the date, not even a death in that era was quite something, because you didn't have blood transfusion, antibiotics, and the sort of care that we now take for granted. In fact, you often didn't survive, because of your doctor. But anyway, I would put to you that hypnosis is indeed a Cinderella science, and it's time to get it to the ball. But it's an untapped resource that we really don't educate ourselves about. It is actually highly effective and very versatile. It works in the majority of us, albeit to variable degrees. And indeed, all hypnosis is actually self-hypnosis. It's a very permissive process which empowers the individual. And actually, we have a lot of evidence that it works. And there are very few contraindications, and probably more so in this medico-legally sensitive age. We wouldn't probably advocate it in people with unstable epilepsy or brain tumours and maybe severe mental health issues. But actually, it helps a lot of people across many specialties. There's a lot of basic science and investigation that show it as a distinct brain state. Indeed, it is on an EEG characterized by alpha and theta waves, not the delta waves you see in deep sleep, and distinct from, you know, our normal cognition, which is characterized by beta and gamma waves. But we can see that certain areas in the brain light up if you've got hypnotic pain relief, and that's borne out by regional changes in cerebral blood flow shown on fMRI, functional MRI scans. But, you know, we're held back by lack of education. And although there are some countries that are doing this much better, we're held back in exploring it further, which does need to be done, in understanding the mediators and moderators of hypnosis. But actually, I'm taking on the challenge of trying to develop more effective dissemination strategies, hopefully with your help as well. But what is it? Really, it is actually a very valuable tool that allows an interaction between the mind and body, affecting therapeutic changes, which actually engender coping strategies, help people to connect those innate healing forces that we're actually beginning to delineate are very much part of the mind-body connection. It's actually just a focal state of attention that's coupled with a relative suspension of peripheral awareness. And it allows an effective communication with your subconscious that actually allows you to implant therapeutic suggestions that improve well-being, which without the need to rationalize them in the conscious state. You can say it's like resetting your hard drive a little bit to patients. But I think it's important to say what it's not. It's not a one-size-fits-all. There is considerable variability in the population I've mentioned, and about 10% of us will probably not be able to use this, but actually there'll be highly hypnosuggestible people, and the majority of us fall in the middle. With motivation and repetition, you can improve that. And it's certainly not a substitute for all that we know is good and effective in medical and surgical care that we obviously want to utilise too. There is lots of data in a surgical setting that show that actually it's a really good moderator of pain, nausea and vomiting, and anxiety. It reduces perioperative and postoperative anesthetic requirements, and indeed the anaesthetists are catching on quite fast now. They like hypnosis because patients are much more stable intraoperatively. They have less blood loss, they need less transfusions, and their procedures require less drugs, and they have less consequent behaviour disorders afterwards. I love this slide because Kathleen Varga was an inspirational professor of psychology who is in Budapest, and she had an alliance with her ITU specialists and did a series of 2 or 3 randomised control studies using therapeutic suggestions for patients so unwell that they were on ventilators in ITU. And there were 2 groups equally divided by severity, and the controls were treated normally. And the 2 studies she did replaced latterly those psychologists reading the therapeutic suggestions to the patients who were apparently unconscious. And she did the second lot with audio files, saving a bit of manpower. The results were the same. They got patients off ventilators on average 2 days earlier. They got them out of ITU significantly sooner. But look, those patients who got off ITU, they were so much better set up to engage with their rehab. They had less pain. They worked harder, and they had a much better feeling that they could get better soon. And indeed, patients who spend a lot of time on ITU do get PTSD, they get post-ITU psychoses. There was a lot less of that seen, and they integrated it into their own sort of journeys with less trauma. It was a real miss that we didn't put that in over COVID. I did actually try and email my colleagues, but they were busy. But maybe now we can take it forward. As an oncologist, I've been really keyed into trying to capitalise on what we know works in oncology, and we know that it helps pain, but that's really important for chronic pain sufferers. But look, it even works 2 years out. It's a really durable intervention. We get people out of hospital quicker. We need that now. And we improve people's body image, and I can very much that head and neck, because that's my specialty, patients benefit. But if we can reduce depression and distress, improve sleep, which it certainly does, then we are actually improving quality of life on so many parameters. And it works in breast cancer, for hot flashes, helps with needle phobias and anticipatory venipuncture, anxiety, helps people learn, which we found when we're trying to gate radiotherapy with lung motion. And I've found it instrumental in managing phobias and PTSD, as most head and neck patients have to wear an immobilization plastic mask to hold them to the couch. If you have claustrophobia, that's a no-go zone. And 80% of patients anybody who's willing to work with me on it gets better. So I think from the point of view of palliative care, I think we have to include it there as well. There's data showing that it's not only able to improve a huge number of symptoms that patients coming towards the end of their life obviously have in greater number, but actually their affect, their outlook on life facing death can be fundamentally changed by the way we as clinicians can talk to them and encourage them, if only just to have a mental holiday from that angst. And that in its own right, I think, switches on a whole new set of your own immunological therapy that actually, I think, gives people a longer length of life. It's fantastic for pediatric patients. The little ones, they have such vivid imaginations, they don't really need a formal process. But hypnotic language is very, very powerful. And although there are limited studies, meta-analyses do show that this form of psychological intervention has huge scope for improvement. So we have a lot of challenges. There are randomized controlled trials. We've shown this is the best intervention for irritable bowel syndrome in drug refractory patients. And actually, how many gastro departments integrate clinical hypnosis? There's one at UCLH, though, yeah. But actually, it lags behind Europe. We lag behind the US. We have sort of less integrative care working, I think. And really, what I want to try and do is to persuade, educate our medical fraternity to just add this in as an adjuvant intervention. It's not a complementary therapy, it's not an alternative therapy, it's an adjuvant therapy. And actually, it's also going to be brilliant for us as clinicians to preserve our own well-being, because I can absolutely vouch on a personal level that that is really effective. And of course, we can do this now in a better way, because actually we do now have this wonderful ability for recombinant innovation, and we have so many examples today. But I gather the guy who suggested putting wheels on suitcases was laughed out of the office. But you know, now we we know that telephones and computers go well, and we carry them around all the time. But if we could only just put in some therapeutic audio suggestion with our medicine and the digital technology that we're now using, we could have enhanced recovery. And I think that, all right, that's jumping a bit, but it's really about empowering patients. We need to actually have them much more participant in their own care. Everybody does better when they're in control. Hypnosis gives you more control. And it's actually the education and the signposting from us as healthcare professionals that allow us not only to select the patients who could best use this tool, but actually obviously identify patients who it may not work for. But actually we could improve resilience and quality of life and responses to treatment, perhaps. There's a whole other set of work that needs to be done, and hopefully integrated with proms and patient feedback. But actually, it's also really important for us as healthcare professionals, because we're in a really desperate state at the moment. We're all overwhelmed and inundated. And actually, this will buy us time for the patients we need to spend time with. That would make us feel better, because we all want to care for our patients. So we set up Transform Medical, my colleague Rumi and I, looking at delivering some core audio files for people. And we want to try and improve that on an organisational level to deliver improved symptom control, save bed days, and actually the health economies that we hope and know are proven. This is our website, and it's in its formative stages. We've got a long path to tread, but we're appealing both to healthcare professionals and the patients themselves. And really, I think this is the win-win-win, isn't it? I mean, the patients benefit from education in a pain setting. Just telling patients how pain works helps their pain. Take this to another level with a little bit more signposting and hand-holding. They can choose their own specialist audiophile, nurture their own self-care in a framework of less anxiety. We know that this actually speeds healing way back from the 1840s. And actually, it's a huge asset and a life tool for managing stress and getting the best out of life. And that also plays out for us as healthcare professionals, for our own well-being and resilience. It's an amazing skill as a communication tool as well. And it helps build rapport, it will save time, and it enhances the placebo effect, which we use as a baseline for all of our studies, but we don't actually plumb into what that is. But we know that hypnoplacebo works better than placebo, and it reduces nocebo. And healthcare so often these days introduces nocebo effects because we have a litany of doom in every consent form, and it usually ends with the risk of death. And that obviously activates a huge fear for most of us because it's a bit taboo in the West. And of course, for organisations, really what everybody wants is to have a happy crowd of workforce. That's not the case these days, many organisations, and we want improved patient outcomes, improved bed utility. We want to reduce wait lists, lower complaints and claims, and have better compliance with the treatments that we know that work. So actually, this is a huge asset for public health as a prevention tool as well. And actually, with all the things that we've so far heard about today, these actually amplify any of those interventions, I feel. So this is something that conjoins with so many other things that people are talking about and will reduce drug costs, which is a little bit of a problem when you're trying to be sponsored by anybody from pharma. But ultimately, I think really it's all about how we all knit together and form the jigsaw that we are hopefully starting today. I think it's all about education and empowering patients. Having a much less hierarchical relationship with patients is what hypnosis is all about. And actually, I think I'm on a very steep learning curve about how we can use the digital tools that we have and now are learning from and integrating with healthcare as one of the very few things that came out as a positive from the pandemic, really. And so I think we're trying to provide webinars for both patients and healthcare professionals. We're trying to appeal to organisations to bring us on board to try and do that hand-holding from within, maybe on a specialist provider level for different services, and hopefully then actually implement a broader outreach and education where people can use that and self-sustain with mentorship groups, patient groups, to help on a wider level. So I hope I've got in with my 15 minutes, but I think that's it. Thank you.
Do we have any questions from anybody?
I've just got one. What are the blockers then? What are the things that are?
Well, it's interesting. I managed to get a couple of medical student groups to do a little sort of pilot service development exploration. And I think there is preconception still. Yeah. And an education about hypnosis. Yeah. So a lot of the stuff, I work hard to try and, affect my circle of influence. But actually, even if you have posters and flyers on the wall, people switch off to hypnosis. There's a lot of cultural preconceptions as well. Sometimes people confuse it with a religious viewpoint as a barrier. We've started calling it audio therapy a little bit more. But actually, the studies are slightly mixed on that front because there is a science to hypnosis, which actually works for some patients. But how you integrate it, introduce it, is probably very key. And actually, if it comes in on the back of other things, I think it's probably where it's going to be powerful.
Yes, and who?
Sarah, it's really interesting, and
I'm keen to talk to you about my own personal requirement of hypnosis and my wife. I think the problem comes with everybody in who's dealing with a piece of technology. The technology isn't the problem; it's the adoption and the mindset that needs to change to adopt the technology.
Indeed.
And we're developing. We recognised this way considerably a long time ago. And we're developing an educational program for ourselves, but to educate doctors in adopting technology. So what are the problems? What is the technology taking place in their careers and their professions? They're dealing with their barriers to adoption, which you need to address before you begin the conversation. Then once you get that, how to actually adopt the technology into one's work practices. So you're taking them through a journey. It's all about VR and education. Nothing about the technology. It's just getting it in there.
Yeah.
And then once you've got the technology and the agreement that yes, we can use this stuff in our daily work practice, the next stage of that educational process is how do you deliver it to the end user? So you need a database very much similar to the. As we spoke to the TSA about this, Telecare Service Association, in how you get those technologies in a database that can be delivered in the same way the GP is familiar with delivering drugs. So you type in your symptoms, you get a whole bunch of drugs that are appropriate for those symptoms, discuss that with your patient, and then you prescribe them. The same principle applies to these type of technologies and therapies. And I think that's the problem, and we all face it.
Yeah, but I think the other side of hypnosis is actually trying to breed a different form of communication between clinicians and patients that actually engenders hope, empowers them to find different ways, because no person's journey is exactly the same as another's. And what we find is that hand-holding bridge is where I think, having gone round and round, there are certain patients who are that they're already like that. They're actually going to be slightly difficult patients because they're searching for another way to get better. And it's the people who are closed down that, are difficult. But I think it's sometimes all in a name, but it's getting your foot in the door. You're quite right. Yeah.
Well, it's the education of the doctors.
Absolutely.
Education of primary care. And possibly, if you can get anywhere near it, social care, because we're dealing with frontline people who benefit from therapy, all sorts of therapies, but there's no way for them to take that knowledge of the problem and escalate it as a frontline care worker or as an agency. There is no way for us to escalate that and say, these are some of the technologies. Why don't you talk to your GP who can give you a smorgasbord of these interventions? And that's, I think, the missing bit. We're all facing it. Every individual in this room who's dealing with a product is facing that problem. How do you get the adoption? However good the technology is, how do you get the adoption?
I think it's cost efficiencies, and it's pounds, shillings, and pence these days, really, or whatever currency you work with. But in terms of making it,
Can we move on to the next presenter now, because we are a bit behind time. Our next presenter has been sitting there patiently in Northampton to join us. So I'm going to add her to the stage now.
Hello, can you hear me okay? I can't hear anything myself now.
No, well, you can now because I've added myself to the stage. So, Rebecca, I'm going to hand over to you now. So you will be able to share your screen and run your presentation. So I should see your presentation as soon as you choose to share it. So I'm going to go quiet now and just leave you to introduce yourself and run your presentation.
Is that showing okay? I'm sure you'll be telling me if not. I'm sorry I can't be there with you today, but I'm really excited to share with you about the power of virtual reality. So I'm going to talk about how we're using virtual reality and immersive experiences as digital therapies for the elderly. So I'm taking this technology out to the community and benefiting the people that really need it most. So I started VR Therapies, which is an innovative social enterprise. And this is just a little bit about me and my background. I'm a qualified learning disabilities nurse. I worked for a nurse for about 10 years. A big part of my career was in brain injury rehabilitation, so it's really interesting listening to you, Ellis, and really spoke to what my experience as a nurse was as well, with the difficulties people are finding in following their treatments. And I found out how we could gamify it, and that really excited me, and it's part of one of the inspirations behind what I do. So I'm set up this social enterprise to really make the most innovative and fun therapeutic technology accessible to as many people as possible. Now, I actually work with everyone from children with autism up to the elderly with Alzheimer's, and we're really harnessing the power of technology for that positive, meaningful impact. And a lot of the people that I'm supporting are the least likely to access this technology, but are actually the ones that are benefiting the most. So as I said, I found out a little bit of some of the medical benefits behind this, and that sent me down this rabbit hole of research as a nurse. And once you start looking, it blows my mind. There is so much evidence out there behind virtual reality and immersive experiences and how they can support all different ages, all different conditions, from managing chronic pain to rehabilitation to mental health and so much more. Now, obviously, I'm going to focus in today on using it as a digital therapy for the elderly. Now, we found big evidence behind emotional well-being, so reducing anxiety and depressive symptoms, because they're in such an enjoyable and happy place that's meaningful to them. We can transport them from the middle of the care home off into a beautiful forest surrounded by deers and rabbits, or we can go and sit and relax by the beach. Now, these experiences can also be shared as a group, so I'd also do individual and group sessions, and this helps reduce those feelings of isolation and loneliness. You know, we're able to bring this experience to everyone and go on these adventures together. And then we've also got games and things that support physical activity, and this is helping with physical rehabilitation and reducing just sitting in front of the TV all day and not moving. So one of my favourite experiences was when I went and did a session with a little old lady, and as soon as I walked in, before she even said hello, she said, "All right, dear, my arm's hurt and it won't go above here, and I've got a bad back, and I can't do this and I can't do that." And then as soon as she saw in the VR a dolphin swim past her, she suddenly went, "Wow, look at that dolphin." And the arm's up and she's moving fine and she's not feeling any pain, and the look on her face when she realised afterwards. And this wasn't because it was a distraction therapy. It's because she was actually so scared of feeling pain that she restricted her own movement and her own activities. So you can start to see the wider impacts of using virtual reality. And as I said, there is so much evidence base out there that it's both inspiring and exciting, but also really frustrating. Why is this not out at the community? So how do we use it? So I do a range of different sessions using virtual reality. We could do trips down memory lane where we visit where they grew up. We could walk around their favourite holidays. We could visit the church they got married in. And we can really transport them back and use those reminiscence therapies in a really immersive and powerful way. I've already talked about how we can support with mental well-being and physical health and mobility. We can also support different areas such as history and geography. We can make it meaningful to their interests and their passions throughout their life that might not get the experiences now that they used to go for. So we can travel back in time and walk with dinosaurs and do all these silly little adventures that actually bring a smile to people's faces, makes a difference to their day and gets them moving as well. We do things with ticking off bucket lists, you know, flying off to the Bahamas and swimming with dolphins. You know, we're able to climb Mount Everest and do things that we might not have been able to do in the real world or might not be capable of doing now. We can also support people's religion and spirituality. So during festive periods last year, we were able to bring the church to them. We were able to help bring their religious ceremonies to them and help take them to Lourdes. You know, these events are really important to their well-being and their happiness, you know, especially those that are getting towards end-of-life care as well. It is so meaningful that we're able to support these areas of their well-being. And also brain boosters. I'll talk a little bit more later about how we can support cognitive rehabilitation. But instead of having boring activities with your therapist, that are painful and slow and they aren't enjoyable, we can create really interactive and fun games that support their cognitive function and accessible adventures. Let's go skydiving from the care home, you know, such wonderful things we can do. And this is my favourite slide because this shows the response that I get. You can see immediately all of their happy faces and how much fun they're having with it. You can see some photos on the left-hand side in palliative work care as well, oncology. She's actually doing an experience that was designed with David Attenborough and St Giles Hospice. So this is specifically designed for end-of-life pain and reducing end-of-life anxieties as well. So you can see what a meaningful experience this is for her. And we was also able to bring the children into this activity as well, the grandchildren, and they were able to all go swimming with dolphins together. So we were able to create some really happy moments for this family. Now, meta-analysis of 18 studies shows that reminiscence therapy was associated with significant improvements in cognitive function and well-being with people with dementia. So being able to take them on trips down memory lane in such an immersive and powerful way is much more meaningful than just looking at photos. We actually get to step inside their experiences. And for those that might not be able to articulate these memories and bring them to the forefront, the staff are able to bring them to it. And we're also able to give the staff that opportunity to step inside their shoes and actually see where they came from, where they lived, what the culture was around them, you know, who they are as a person. And that then can shape how they support and approach that person. And the top left was a lady that is obsessed with tigers. She is so fascinated with cats, and that's her favourite thing, and her bedroom's got all cat-related toys and wallpaper and pictures and everything. So being able to take her on a safari adventure, walking with elephants and giraffes and looking for tigers, you know, that was such a fun activity. And that high that she felt lasted through the rest of the day. And we find actually that people need less pain relief. You know, they've got less anxiety, they're sleeping better, reducing the risk of falls. You can see the different connections and benefits start to make a really big impact. And one of my favourite is doing the creative therapies. Now, we already know that creative therapies support self-expression, building confidence, social interaction, helping them express themselves when they can't find the words. The music and the art can do it for them. But we've also got evidence that by stimulating the neural pathways, we're able to encourage brain plasticity, which then enhances memory, attention, problem-solving abilities. And they're going to be intrinsically linked to their mental health, their level of confusion, frustration, depression. So you can see in the middle photo, we've got a lady that is obsessed with Frank Sinatra. And she was proudly showing me a photo that she's got signed and the ticket stub of when she went to see him live in London. Now, she's another one that when she showed me her bedroom later, she's got all the photos, signed pictures, she's got all the records still. That was her big passion and she loved it to bits. So being able to take her and give her a private performance with Frank Sinatra, that's not something we can do in the real world anymore. But the power of VR allows us to bring that to her. And she was in tears afterwards. It was such an amazing experience and moment for her. We've also got other creative therapies that merge art and music. So each colour has a different instrument or a different sound associated with it. So we can paint a picture and then pick up a drumstick and make music out of the artwork. So as a group, we were able to create this art piece together, and each person added their own little bit to it, and they each chose their favourite colour. Some drew flowers, some drew different things, and all together created this artwork. And then we were able to make music from this artwork. So I've got a little video of Sheila, and she's waving her hands instead of holding the controller. She was using the hand tracking. So also occupational therapy, fine and gross motor skills, feel the benefits. Sheila. It was beautiful, Sheila. So upcoming
You've muted yourself, Rebecca. You need to unmute yourself.
Sorry, that must have, when the video played, it must have automatically muted me then. Okay, let me get it back up on. Okay, hopefully you can hear me now. And so this is just one of the photos from the pilot study we're doing at the moment. So with the lady on the right, we were able to transport her back to her roots in Japan. And she had to leave this country as a child. So using the VR, we were able to take her swimming in Okinawa. We were able to go strolling through the tranquil Buddhist temples and really rekindle those lost memories of her youth. And another resident, we were able to take her back to Somerset, where she grew up, and it brought back all these stories of the lifelong friendships and the vibrant communities that really shaped her past. And from revisiting the schools and the churches to reliving really significant life moments where they got married, our experiences were able to really foster connection and social interaction, stirring emotions, and allowing us to visit each other's memories, which was just beautiful. I'm not sure if you heard the first bit, if it had gone muted, but I was just introducing the pilot study that we're doing with West Northants Council, and it's actually the social services that are supporting it, and the World Health Organisation has supported use of the assessment tool. So this is a study looking at supporting holistic health and quality of life for nursing care home residents, and the long-term plan is to be able to get it into all of the care homes that are run by social services in the county, and for it to be a part of the care packages. So we've got long-term big plans for the county and how we're going to be able to support the wider community with this. And this is a really novel and exciting project for the council. So it's going to have an amazing impact, and we started 2 months ago. But if you'd like to connect with me on LinkedIn or any of those, then you can follow the journey and the results as we come across them. And then here's another story I'd like to share with you. So I was invited to go do a one-to-one session with Charles. Now, this is an elderly man. He wasn't in the best of health. He started to deteriorate cognitively as well. There was concerns with dementia. And he was just spending every day sat in front of the TV. And his family were getting increasingly worried about him. So I went out to do a session with him. And the magic of what we do is we're able to personalise it to each individual and really make it close to what's important to them, what makes them smile, what's meaningful to them. And that is what makes it truly effective therapy. So he proudly started showing me these photos from his youth of him and his brothers. And they used to all do boxing together. And you can see they took it seriously. They got trophies, they were doing really well. This was a key part of his childhood and his connection with his family and his brothers. So you know what we're going to do? We've got to get him back into the boxing ring. And then that's Charlie in the boxing ring. So I've got a short video, but I'll play that in a second because I think it's going to mute me again. And using the VR, we were able to rekindle his inner strength, confidence, muscle memory kicked in, and he was back to his youth, fighting his next victory. He was, winning 3 matches in a row, and he just came out so empowered, full of smiles, laughter, and he got a really good workout in. He was dripping with sweat after this. And it's only afterwards I spoke to his son, and I found out a little bit more about Charles. And I found out that his mother had passed the year before. And his mum and dad were childhood sweethearts. So they were married all their lives. They'd lived together, since they're in their 20s. They were true romance of every imagination. And it broke his heart when she lost his heart. And he said that this experience of seeing how his dad responded to it, that massive smile on his face, this is actually the first time he saw his dad smile in over 6 months. So you can see that not only was this helping him get back on his feet and physically active again, it was also helping him through his grief and smiling again. His grandchildren arrived and they were able to see their granddad in a new way and this new side to granddad, and that helped build their relationship and kind of foster a deeper connection. So there were so many holistic benefits: physical health, mental health, emotional connection, social connection, grief, all these different elements, benefits from just one session, and all thanks to just one game. But you can see on there, both fists were flying, that muscle memory, he was blocking, he was doing it properly. He wasn't just sat there passively, you know, saying it. He was properly boxing, you know, and you can see the impact it has is so meaningful. And these are fun games that can make such a difference when utilised in the right way. So thank you for listening to my talk. I would love to connect with you all as well. I'm obviously on LinkedIn and all that jazz. The website is vrtherapy.co.uk. And my email is rebecca@vrtherapy.co.uk.
Well, thank you very much, Rebecca. We really enjoyed that. A few technical problems, but with all the brain power in this room, we managed to get them sorted out. So do any of you have any questions to Rebecca? Yes?
Yes, I mean, I think it's wonderful, and I would, given my hypnosis enthusiasm, say that obviously you have captured focal attention with suspension of peripheral awareness, which is the definition of hypnosis, in terms of the visual distraction, which is obviously so positive in many of the ways you describe. I wanted to understand a little bit more about how you integrated and personalized your video experience, whether you were tapping into photo albums or indeed getting, I suppose, current video footage of places they've been, so that that sort of package of care is personalized, but also to try and understand whether it's actually your enthusiasm as the audio accompaniment to their VR experience that is obviously seeding so much can-do positivity, which I would also say would probably be hypnotic affirmations, and then actually maybe that could be built in as well, you know, in a more sort of headphone immersive experience.
Yeah, I'd never considered utilising me in the experience like that. What I actually did note down from your talk as well to create is to recombine. And I love that because that is my passion. Traditional therapies, occupational therapy, psychology, physiotherapy, and combining that with VR technology. And I was already aware how we could connect with what you're doing as well. To make it personalised and bespoke, part of it is I come with a massive library of experiences of games, different applications. Some of this is commercial entertainment and games. Some of it is clinical platforms. Some of it is, you know, different experiences that have been created by developers who want to make a difference. So in their spare time, they make something that they think their granddad would enjoy because they can see how it can support people. So we have a lot of different content and applications that we bring with us, a lot of different headsets. No one size fits all as well. So that's also what kind of stands us apart from other tech companies. Is we're bringing all of the different companies together and making it accessible to the community. Regards to the ones where you're tripped down memory lane, there's an application that utilises something similar to Google Maps. So with that, you can type in any address and go and revisit that area and walk along the street. And it's so simple. I see you nodding. It just makes sense, doesn't it? Like, of course we could utilise it like that. Why haven't we done that before? And we've also got 360 cameras, so we're able to go and film meaningful local experiences, landmarks, favourite places, and create our own as well.
Well done.
Okay, any other questions? Quick question before we move on? No? Oh, thank you very much, Rebecca. As usual, I'm sorry that you're not here in person, but thank you for joining us. I think you probably enjoy the next session as well. But thank you again.
Thank you, everyone.
Okay, so Tre.
Yes, need to switch to the cable.
I apologize, I don't have presentations.
Yeah, Tre's going to do a demonstration, and I'm sure you are going to find this absolutely fascinating. What was the TV program that you were on? Was it a Dragon? Was it a Dragon's Den program that you were on?
No. We'll talk about that one after.
Okay, another.
Okay.
Another
We
time.
start looking at crime watch. So Myndplay started about 15 years ago with a simple vision. I was doing therapy at the time as an honorary therapist, and I was also a documentary filmmaker, also working in technology, so classic ADHD. And as a therapist, I wanted to find a way, because I saw that there was a lot of alternative therapy techniques. There are a lot of different types of therapy, everything from hypnotherapy to TFT to CBT, EMDR. The problem was it wasn't accessible to a lot of people. So I had a concept of, imagine if you could create videos which had teasers of a number of different therapy techniques and some way of measuring the effectiveness of those techniques. What you could do is then adapt the video in real time or the content in real time so that one piece of content can treat a lot of different conditions and pace the treatment based on how effective it was. So the concept of Myndplay was born, which was effectively a video player that changes in real time or adjusts the story in real time based on how you are responding to it. The problem was we needed the technology to measure the brainwave. The problem was also that EEG technology at that time was very cumbersome and very expensive. If you didn't have £10,000, £15,000, you couldn't get a license to any kind of a consumer EEG device. All the lab-based EEG stuff was far too sensitive to use in the real world, so it wasn't really all that effective. So we set about kind of creating a piece of hardware to complement the Myndplay platform, and our EEG headset, the kind of Mindband, was born, along with the concept of this interactive video platform. Sadly, what we found was that actually, although there's an incredible amount of talk of mental health all around the world, there's very, very little money. And no matter how many grants and stuff you go for, manufacturing is expensive, and an ambition like this required a lot of different therapists, a lot of contacts around the world. But what we realized is what we'd actually built, I guess, in essence, once we had the prototype, was a mind-controlled video player, which could tell an interactive story, it could change narratives based on human response. It didn't necessarily have to be therapy video. And once we put that out there, we started to get responses that weren't necessarily mental health, but allowed us to develop technology. So, for example, HSBC came to us as we were working with a lot of athletes with the technology and said, well, you use your video platform to make a round of golf that you play with your mind, you're benchmarked against professional golfers. So your outcome in the video is determined by how well you can match the golfer's mindset. We said, okay, yeah, that's very easy for us. It's an interactive video platform. All we do is, if you can hit this level of tension, this level of zone, this level of meditation, you'll get a hole in one. If not, you'll swing it into the water. But the point is to give you a real-time feedback loop. We then had an interesting request from the prison service. And they said, look, one of the judges came to me and said, look, we have a real problem with anger in the prisons and young angry men, aggressive men who think of anger as a benefit. Can we create a piece of content that will punish their anger? So we created a gangster movement, in which every time you respond with aggression when aggression is presented to you, your character on screen gets slapped about. He then gets punched, he then gets stabbed, and eventually gets shot. So the only way you get to keep your character alive is by training yourself to become less and less responsive to the content. And what they found was not only did they have the largest sign up for their meditation services after, because people realized that actually, in this case, aggression and anger were giving them a negative result, and therefore no more reinforcement of the kind of positive aspects of anger. And all of a sudden, we had all these young people who were joining meditation classes to train themselves to calm down. We also found that there was, luckily, an opportunity within the film industry, because if we can make interactive film, we can create interactive trailers, interactive storytelling, we can create content that can measure an individual's bias and change the narrative. We can look at how we even created a piece of content called Paranormal Minds, which was a horror movie which punishes you for getting scared. The more you feel fear, the scarier it gets, the way of negative reinforcement. So for us, what we then realized as we were doing all of this different content and gaming was that you didn't have to train your brain in the traditional way of neurofeedback. And you didn't even have to use all of these therapy techniques. When people were playing the games with their mind, using their mental focus, their mental calm, their zone, they were able to learn automatically through the reward cycle how to enhance their attention at demand, how to enhance their calmness at demand. And what we found is this is exactly the same training that our coaches were giving to athletes. in order for them to be able to perform under pressure, under stress, under duress, under the kind of feeling of being antagonized and everything else. So we thought, well, instead of making therapy, why not just create neurofeedback gaming and content that allows people to become mentally stronger, mentally fitter, and therefore the impact of the other stuff becomes less significant. And what we found is that actually neurofeedback had a lot more benefits, and the research is getting even better. I mean, everything from addiction, pain, anxiety, stress disorders, performance enhancement, ADHD, autism. There are a number of benefits with brain training technologies. The only problem is most of them were very boring. Traditional neurofeedback relied on what I call the lines and the bings and the bongs. So you looked at a screen and you had to make the line go over a threshold, and as it went over a threshold, your brain learned, and eventually you learned to do it. The problem with that was what happened when you're not sitting in front of your screen and you're under real life pressure. Can you still replicate? And the thing is, you can, but it requires a lot longer training in order to do that. Because really, there are 3 stages of brain training that we feel. First one is consciousness. Recognizing you have the ability to train your brain and control certain faculties of your mind. Most people think attention is something that is drawn. It's not something that is drawn and also given. If you can actively control your attention, you can actively control your thoughts. You can actively turn off to avoid burnout and increase to improve efficiency. If you can train meditation, you have the ability to control the input, meaning and the external input, so things that are coming from the outside world, your stresses, and negative thoughts. So if you can train those 2, that was what we found was the closest thing to what an athlete might call a zone state or a flow state. So then the objective became, well, how do we make it more fun? How do you get people to engage? Because, most people, when you think of any kind of neurofeedback brain training, they think, well, if I haven't got nothing wrong with my mind, there's nothing to fix. Reality is, we've all got something wrong with our mind, and we've all got something to fix at every level. And even if it is the simplest element of when you take a child and you show them that they are not a slave to their attention, they can control their attention, it's like an instant change, instant effect. You go from becoming helpless to becoming active and to becoming somebody who recognizes that there is a level of control here. So after consciousness becomes control, training yourself to increase your attention, your meditation, getting into yourself into a positive brain state, an ideal state for performance, being able to anchor it. And then the last stage is mastery. And in order to gain mastery, we must be able to test ourselves in a number of conditions. And that's where the Myndplay content came into play. The content is designed to create lots and lots of different stress-based environments or scenario-based situations, and then either punishing you or rewarding you for the right outcome, and thereby giving you a way of playing interactive games. We realized that we could enhance that by combining it with, for example, VR. So our headset, which is the Mindband, is a very simple single active sensor EEG headset. Comes with a kit, so it can go directly inside your Oculus headset and now give you immersive VR and immersive neurofeedback that's going to train meditation and focus in a more controlled, immersive environment. And as we know, the real power of video to evoke emotion is even greater when we can't escape. For me, the next stage after that, sorry, I'm just going to take a bit of water, if that's all right. I talk so fast, I give you guys a minute to process what I'm doing.
I'm going to have colleagues from
Oh man, my mind's all over the place.
And I could just say, just very briefly, I was an early user of Paranormal Mind, and it was assessing my capability to be a, what's the right word?
Did it for you?
Sorry?
Which one was that? Paranormal Mind.
Paranormal Mind, where you get rid of spirits.
Yeah.
Yeah, I was only an amateur. I never got past the amateur stage.
He was only an amateur exorcist, yeah. So the next stage for me was, all right, we've created content, we've created a platform, but I really want other people to be able to develop upon it. And luckily for us, we were able to do a lot of contract work in between, a lot of commercial work. I don't think anyone in our industry survives without undertaking funding or moving into the commercial space. Luckily for us, the commercial space worked out really well. We ended up doing a ton of commercial projects, everything from making a happiness blanket for British Airways, which changes colour in real time based on the happiness of the flyer, to creating personalised drinks for Tanqueray, where you smell different herbs and it creates a custom personalised cocktail, to deciding where you want to go on holiday for Expedia, to using Department of Travel for South Africa to create a personalized itinerary. So, things like attention training and brain training are one thing, but actually there's a real power of personalization once you can look inside the mind. For me, the final frontier was taking neurofeedback beyond what I was saying was the things, the bongs, the lines, and then the auditory feedback into some form of sensation, experiential feedback. Imagine I could sit down and meditate and have a fan get stronger and weaker in real time. It's my meditation. So I know without having to stop, pure sensation alone, how relaxed I am. Maybe in my chair, a haptic feedback to tell me to relax or to stop working when I'm mentally burning out as a form of fatigue monitor. Or even having a lecture in your home while you're working, saying, oh, you're getting tired, take a 5-minute break, or your kids aren't focusing, that kind of thing. The whole point is to create a way of bringing your feedback into your home. And that's what led us to our newest product, which is the Mind Hub. Now, this little box here connects to the EEG headset. And now anything you plug into it becomes mind control. So we have, for example, a lightsaber, which allows you to train like a Jedi, where you can choose the level of focus required to turn the lightsaber on. When you hit that level of focus, the lightsaber will come on and stay on as long as you're above that threshold. If you want to get better, increase the threshold. Actual Jedi training for attention. But then, you can tie it into things like just plugging in a simple LED light. You can adjust it and set it up so that it will tell you when you're burning out. You can use it for training or for monitoring. And you can use it, for example, to plug in a fitness device. So one of the things we're doing with coaches is synchronizing mental fitness with physical fitness. So for example, with reaction training, where you've got one of these light reaction time walls, plug it through the Mind Hub. Now the lights only come on when you're above a certain level of meditation or focus. So you are now training yourself to be in the ideal state and still be able to train your physical faculty. So it's about really giving the tool to allow anyone to be able to create their own neurofeedback experience. Everything from, we're working with an amusement park to be able to create like a maze where you can open doors and lift bridges with your mind by being in the right state of mind, to being able to tie it into physical products or allowing children to create their own circuits. One of the fun products we built off this is the meditation chair that treats you like a yogi. As you relax, you go up, and then as you lose your focus, you go down. And using that haptic feedback, you're able to train yourself and accelerate yourself to be able to learn to get into the positive state that you're required to get into much faster than if you were relying on traditional kind of meditation or stuff alone like that. But one of the other things, coming back to some of the other speakers now, is that we are very much an enabler. And it was interesting to hear you talk about alpha theta, because we've just worked with a clinical hypnotherapist to develop an app to train future hypnotherapists in how to recognize when their patients are in alpha theta. So instead of you trying to rely on your visual feedback to know whether they're in the ideal state to progress the hypnotherapy to the next stage, we have an alpha theta monitor that they're wearing, and it will effectively give you a signal as a therapist, now is the time to progress the hypnotherapy. So it's a way of kind of tying into existing and other techniques to enhance the experience both for the patient but also for the therapists themselves as a way of accelerating the learning within hypnotherapy. And then some of the new research coming out, which is amazing, and we've been lucky enough to supply to almost 400 universities for research, a number of published papers mentioning our technology. So with the ADHD I completely forgot what I was going to say. Thank you very much.
Rebecca just asking a question online. She's just asking if you've got any games. She thinks it's fantastic. Any games for the Oculus?
Yeah, so we've got a number of games inside the Oculus, and we've got a custom player inside the Oculus as well, where you can just use so it's like when you wear it, it's almost as though you're inside a mesh of your own brain, and then the colors are reflecting in real time your state of attention and meditation, so you can just use the environment as a way of doing neurofeedback. The reason I've got this is one of the most exciting applications of the Mind Hub is what comes from third party. So one of our friends who's been using our Myndplay tech for a while works a lot with stroke victims and people with a number of different neurodegenerative disorders, but specifically stroke victims who have lost the use of, for example, one of their hands. Now, this kind of a glove is an off-the-market product, costs about £70, and it allows you to press a button to open and close your hand, which is fantastic. But the thing is, could this be made better? So we found that actually just by directly plugging it into the Mind Hub, instead of you having to press a button, you can actually choose the level of concentration at which you want to open and close your hand. So you're using your brain to open and close your hand now. And one of the beautiful byproducts of that is that it accelerates the neurorehabilitation as well, just because of the synchronization of your thought to do it, active thought, and the reaction of your hand in real time. So simple off-the-shelf products like this can be given a completely new lease of life and enhanced massively using the Mind Hub, but without having to do any coding, any programming. The whole point of the Mind Hub is to make it plug and play for just about anything and to incorporate it into a number of different technologies. But I think things like this are what excite us, because we've had people who were able to use their hands for the first time with what they said was their mind, even though we don't have their attention. But it was a phenomenal feeling to be able to connect that physical sensation with the will to do it in your mind, something we take for granted pretty much every day.
I have a Mind Hub at home, I have to confess, and when I first went to see Tre, to see in its early stages, he set up the Mind Hub connected to a little fountain, so lights came on and water started flowing when you reach the right level of concentration. And I do have a video of myself controlling this fountain, so I can, it's not vaporware. This actually exists, and it does work. So Rebecca, next time maybe I see you and come over to you, I'll bring my Mind Hub with me, and you can have a play. Yeah. So Mary.
Thank you very much. This is great for two reasons. Number one, late last year, I fell ill. So afterwards, my whatever appointment, my doctor said I was overusing my adrenaline. Apparently, there's a name for it. And they asked me if I don't mind taking part in mindfulness. So I said yes, because I'm always on the go. So maybe, that will work. Really nice, but they gave me 20 minutes, 30 minutes. So far, 45 minutes. Different programs. I haven't gone past 20 minutes.
Yeah. It's very difficult, isn't it?
Yeah. Well, the 3 minutes and 20 that I'm doing, I can see, the benefit. So this is where, when I saw you actually brought that out before you spoke, I thought to myself, this might work. Now, for everything that you described will be really, really useful for the youth and young adults. But I'm thinking, when we think about their concentration span, how can you make it more fun for them so that they can, go through and actually have the full benefit?
Yeah.
Because I don't know, maybe with full demonstration we can grasp more, but it looks so intense to me that I think they may be put off at the beginning.
So I have a 9-year-old. I've got 3 others, but the 9-year-old is the most annoying one. The way I got him to get involved in the technologies, he used to love the scale electric. So what I did is I plugged the scale electric into the Mind Hub, and now he can only play it if he's above the required level of concentration. And what that taught him was actually I can really concentrate when I want to. But what it also did is it trained him to recognize what a high state of concentration looked like. So you're right, it's very difficult to get the kids to do it, but the whole point of the Mind Hub is to give them a number of different ways. So for example, another thing I did is my son's got a little remote control car and these little robots, really cheap, like 20 quid a little one, just to go forward, back, left and right. And what I do is I put a little remote receiver into a couple of wires into the controller. I can plug the controller into the back of the Mind Hub, and now he can steer with the controller, but he can only drive the car with his mind. So really simple little things like that to try and incorporate it into their life. And even sometimes just having a light on for them is fascinating, because remember, you're allowing them to be excited about the insights of their own mind. When I say to my son, how long can you keep this light on for? Suddenly it's a challenge. But to keep that light on, he has to be above a certain level. And, he'll start to get frustrated when he can't do it, come back a little while later, and then he's able to do it. So really it's about the incentive. And the other thing is not to overdo it. I think people think of something like this as, to me, 20 minutes is way too long anyway. We find even with athletes, we can do 5 to 10 minutes 2 times a week and get the same benefits. You just don't need to be doing it all that time, because you will fatigue. Your brain will get knackered.
I mean, I'm fascinated by this, and of course it is a brilliant tool for identifying people who, if you like, are in your demos hypnosuggestible, and amplifying their ability to get into a trance state. One of the other fascinating things about hypnosis is obviously taking forward what people take on when they're unconscious or in an incredibly sick state, is seeding those suggestions. And actually, I'm thinking about how one could, with audio suggestion, amplify the speed at which people can train. Because actually, when you look at the athletic potential, there was a wonderful set of experiments done by a psychologist in the Netherlands who was hypnotherapeutically training elite athletes. And he showed them that actually their performance enhanced when they lay on the sofa and actually imagine themselves training. And actually, so the imagination side of things is these sorts of tools, given that they may be expensive for a wide array of the population, it could allow people to have those potentials seeded, the anchors made for them to be able to utilize this in a learning facilitation, basically. And I think it's wonderful, because I think the way you've described it is obviously with a biofeedback, which is fun. But actually seeding on the back of that some audio suggestions may also be
absolutely, and knowing what state of mind they're in will definitely allow you to pick the perfect moments. And what you were saying about visualizations is actually fascinating, because we're doing a lot of work with racing drivers, and racing drivers are very unique in that if I asked any of you to kind of work out your journey, or sit here and imagine your journey from, say, a journey you make every day by car, and say, okay, try and tell me in here, you've just left your house, tell me when you got there. None of us can time it anywhere near exact. In fact, we massively accelerate. A racing driver who can get around a racing track in 1 minute 33 in his car can do the same 1 minute 33 in his head, which is phenomenal. And what you find is they go into an incredible state of gamma. There's the gamma frequency is linked to prana, it's linked to pleasure, but actually it's linked to that ability to get out of yourself and be somewhere completely different, to the point it's almost fascinating that you'll even see them cringe when they're going, or react when they're going around a particular corner that they will react to in the car. So their level of immersion is phenomenal.
You're talking about use cases here, which is fascinating. But at the end of the day, this is potentially beyond single use cases. You coming here, have you in mind any kind of what would good really look like for you to take this up another notch so it goes beyond single use cases?
I think the next stage for this technology is going to be the algorithm development. Actually, it's using AI to be able to get a wider range of emotions that can be understood. The thing is, the applications are many, and they are being applied in a number of different areas. One of the things you were mentioning about the cost as well. So it's about making it cost effective at the same time, and allowing the application side to be led by the application experts. So we don't, we started off as an application company and realized we are much better suited as enablers than we are application developers, because you're never going to get everything. It's like you said, you're going to pick a very small area. And what you'll find is, even though there's a huge overlap, people want to stay within their lane. So it's really hard to get people to multiply and be able to use it for multiple applications within that one area. So we almost learned over 15 years to stop ourselves from going too broad on the application scale, because immediately it turns people off, and then they think, well, it's clearly not a specialist item. And no, this is used clinically in so many of these settings, but it has the potential across the board. But it's almost now getting to the point where we're having to niche it further just to be able to make enough of a dent. But for us, we're fortunate in that, because of our reputation over the last 14 years in the corporate space, we've won maybe 20, 30 awards for our clients. So it's allowed us to have our very unique positioning that allows us to keep doing this kind of development. But I feel very sorry for anyone else who kind of comes in with EEG, because it's a costly game, and actually it's still very far behind where it should be, given how far the technology has come. I mean,
you said that you were really excited by the hand thing, and I can see lots of different clinical applications within the neuroplasticity area and pre-priming motor cortex, prior to doing rehab, combining it with robotics, using VR as well. So I think in that neuro rehab space, I think it's got masses of different applications. Speech production for people in a semi-conscious state,
and predicting who could be most susceptible to these sorts of interventions
It's almost scary how broad it is. Like we had this problem when we first started. We built an application for ADHD, very specific. We built an application for ALS. So people could use their blinks and attention to control a keyboard. And like this was like 12 years ago before it kind of became more commonplace. But you're right. This is where we kind of wanted the technology to go, but we had to go through this really long-winded process to be able to get to this stage and be able to be, I guess, profitable and survive in the industry. Because, you know, as great as an NHS contract can be, sometimes it's not worth the freaking aircraft. 2 years for 60 grand, I didn't run that in my sleep. But yeah, that's one of the.
And your stroke patients, the number of people that have communication problems, speech problems, just being able to think and turn that into output would be phenomenal.
Yeah, so it's very exciting for the possibilities. Yeah.
I think it's very smart that you're going down a platform route the way. So I think like you know, going down like connected. I don't know how you're what technology you use, but it's something like Zigbee or something where you can start connecting with different devices. With the so I know one of the problems there, the EEG is like their sensitivity or like determining. Ultimately, you're looking at like frequency of brainwave and looking at those different states. Because I follow this space quite closely about more from kind of brain-computer interface kind of stuff, which is kind of what we're verging on now. Is there can you see EEG commercial grade, so not loads of electrodes, but just maybe a practical number, being able to get into higher levels of sensitivity? So you could, because it's kind of like, I mean, how many states?
It's not so much sensitivity; it's the noise filtering, isn't it? The problem is it's almost oversensitive to technology, and in order for it to be effective, I think one of the best advancements has been electrode technology.
Which like a research grade when we'll do brain activity in certain locations, which then we kind of map out. Right.
That depends on how. So I had set the research grade, but we only focus on left prefrontal.
Right.
Because the more sensors you add, the more complicated it gets. The harder it is to maintain connectivity. I can't use dry sensors if I want to do anything overhead. So I don't want to have to shave everyone's head. And then the other problem is what are you going to do with that data? So one of the things about the prefrontal cortex is we have more algorithmic data from the prefrontal than a lot of other places, typically related to emotion. So for example, attention, meditation, joy, anxiety, learning, creativity, familiarity, memory, problem solving, all of that occurs on the prefrontal cortex. So I don't necessarily need to go anywhere else, because if you're using a multi-channel system, you're using it because all you're really interested in is in activation, right? So you're looking just at the raw signal. I'm not so much interested in that. I'd rather focus on the algorithms that we've developed around it. I've still got the raw data there, coming in at 512 hertz, but I'm more focused on the algorithmic data that allows me to determine a state that's most common for everybody. Because then, if I say to you, I want you to go and train your beta for 10 minutes, low beta. How do you do that? Whereas if I tell you I want to train you to concentrate, I want you to focus, something that we can relate to. So I think having the algorithms and specific states that are recognizable will definitely help the industry in overcoming some of those barriers. And I think,
do you reckon you can do like thoughts more rather than kind of states go into?
I think that anything around thoughts is well off, and I think that that's going to require more of the invasive type stuff, or much deeper. To me, actually, we're worried about thoughts, but we haven't even got close to controlling emotion yet. And I think that's one of the problems in the industry. Everyone's looking too bloody far ahead. And it's like, well, let's pass stage one. Like, if we can manage our attention and meditation, we can worry about the deeper frequencies and cognitive processing and cognitive enhancement. If you can't even control it when you're going to scream your lungs out or get pissed off at someone down the road or perform, or I can't perform today because I feel like shit, then you haven't gone over the first barrier of kind of human limitation. To me, Mankind 2.0 and the new generation is actually incredibly emotionally resilient and stable. And once they're emotionally resilient and stable, then you can look at other levels of enhancement. So let's tackle level one first.
My PhD, we work with some guys trying to do the optical brain interface stuff, which is like, you have kind of like your heart rate through here, trying to do blood flow through the skull. And it was just like ridiculous. It was like maybe in like 30 years, this could be something that you might be able to turn light on.
Whereas now they're doing it in earbuds, aren't they? which is also to me a load of crap, quite frankly, because if you're picking up EEG from inside the ear, you're picking up an absolutely generic nonsense level of EEG. What the hell does it relate to? Auditory cortex, cognitive processing, occipital, I'm looking at what I'm looking, you're just giving me an overarching blur. And that's what my frustration is a lot with that as well. And also with stimulation, like neurostimulation scares the living daylights out of me. We're not at a point where we can control it, and yet we're looking to augment it and replace our own faculties with devices that we don't know if they're going to stop our brains from producing the natural abilities. That's kind of how the brain works. You find me an alternative, and I will stop using your brain for that because I've got other shit to do. But yeah. So I got a little bit lax in my tongue at the end. We're at lunch now, so we're all right.
No change there then, Tre. Well, thank you very much again. Well, we're now actually towards the end of our lunch break, but there is coffee there. I'm sorry I couldn't run my budget to getting you all a meal at lunchtime, but there is a cafe down on the ground floor. If you would like to buy yourself lunch down there, you're welcome to go down there. Alternatively, please stay in the room because we've got other presentations. We've got our colleagues from IKSAD who are going to be presenting shortly, and I've also got some video presentations to play before that. So it's up to you. Stay here by all means, and if we find time, I might even do a few slides myself towards the end if I can fit those in. Okay, so I'm going to now.
David, if you're going to have someone do the PowerPoint, you need to change the table.
Yeah, I'm going to stay with this for a minute. Yeah, let's stay. I'm going to indulge myself. You don't have to listen to me, but this is what I'm going to be broadcasting. So they will see me, and this is a presentation that I put together for actually presenting on a cruise ship. So this is one of the things that I do, is present on cruise ships, and so this is all about future technologies. But this was the one I presented recently on the Queen Mary on a trip from Southampton to New York. It's a 45-minute presentation. I'm going to do it in 15 minutes, so I go through very, very, very quickly. So I won't amplify in the way that I did on the cruise ship. So the big question is, how is technology going to affect healthcare longevity and the quality of life? So I bought these pictures from the 1950s just to show you what I looked like as a child. And one of the points that I made was all of these are in black and white, because we all lived in black and white in those days. And you see the picture at Skegness with me as a little boy with my granddad and auntie and uncle. You know, the photographer who took that, he had to go and get the film developed. No digital photographs in those days. He got the film developed, and this goes in a photograph album. And in those days, the only people who ever saw that picture were people who came around to our house and were bored to death looking at a photo album. Now, it can be seen by thousands of people. And the implications of that, of creating a digital identity which will live on after you've passed away, that has, I think, some profound implications. But anyway, these are all pictures of me in different stages of my life. And of course, in the 1950s, this is pretty much what my doctor looked like. I still remember his name, Dr. Azam. And we had family doctors in those days. You had the same doctor, and he actually came round to your house when you were sick. You know, so these are the characteristics of the doctor in my childhood. And doctors were dedicated to individual families. When the tools they had in those days were really quite limited. But you had the same relationship with your doctor as you used to have with your bank manager. And all of that's changed. But the doctor's bag in the 1950s hadn't really changed in half a century. You know, doctors have been using these same tools for donkey's years. And so these devices remain unchanged for many, many years and also unconnected. But life in the 2020s is different. So again, pictures of me and the life that I live now, which is in colour, of course. And I travelled in the way I would never, ever have managed as a child. The picture there is, you probably guess, is in Thailand. So my dad died when he was 69. And my life and my health is infinitely better than my father's was. And when he died, he was an old man. He was an old man at 69. He was an old man when he was 60. And I like to think that I'm not. Doctors look very different today. They're smartly dressed. They have laptops. But you don't see the same doctor all the time. You see a pool of doctors. And they tend to be a bit more focused on prevention than they were in those days, in the early days. So you like to have a different doctor every time. The doctor's bag looks pretty much, it's a more modern bag, but what's inside it is not that much different, except you've got a smartphone and devices now are connected and data is stored over a longer period. So the impact of digital technologies on the doctor's bag, you've got greater accuracy, of course, from these technologies, and the doctors have got more decision support tools. So what's new? Today, we've got the challenges of the ageing society, which is what we're talking about in this session. We're talking about the impact of digital technologies on healthcare, about personal health management, about healthcare. I wanted to talk about on the cruise ship about how I lost 21 kilos in 3 months. And that was when I first discovered lifestyle medicine. And there's a video at the end. I did a bit of a skit on Black Lives Matter and call it Old Lives Matter, to show some of the prejudices that exist about older people and some of the misconceptions. A little video. Well, this is my mum. This was my mum when she was in hospital. She died of dementia, and so she went through what I now know to be the Liverpool pathway. Only the trouble was she wasn't dying when the nurse came and told me she was dying. She wasn't dying. She said, the nurse told me in Kettering A&E, she said, your mum's exhibiting chain stoking, which is a form of breathing which people have when they're near to the end. And I thought to myself, my mum's snoring. I know my mum's snoring. So, anyway, the nurse said we'll take her up to the top ward, and you can, be with her. So I was with her, and she was still breathing, and eventually I had to go home. Came back following morning, went into a room, and she opened her eyes and looked at me and smiled. And shortly afterwards, the doctor came in, and he again repeated what the nurse had said. You realise your mum is very seriously ill. We're not giving her any medication. We're not hydrating her. And I said, she just opened her eyes. He could have knocked him over with a feather. He looked absolutely gassed, and so he said, Mrs. Wortley, can you hear me? If you can hear me, raise your arm. Arm went straight up. So they put her back on hydration, and the net result was that she was able to be discharged, and she went into a care home, and she lived another 3 or 4 months after that. But it gave me a good idea of some of the challenges of the aging society, because my mum was very typical of what is happening in households all around the world. So we're living longer, we need more medical care, we all know about that, but there are fewer people working to be able to cover the costs. And the caring for the elderly is a shift from how it used to be, people were looked after in the home, into care homes. And today, I believe elderly care is a poor relation of public health services. Because when my mum first went into independent living, the quality of care, this I'm talking about 15, 16 years ago, she had her own apartment, and there weren't qualified medical people there, but social services looked after her. And I argue that she had a quality of care which was too good, because she never had to do anything for herself. People came in to do a washing, different things. And so because of that, my mum just sat watching television, getting fatter and fatter, waiting for me to come and see her. So that's not really good for people. And it's gone too far the other way. And coronavirus really has exposed our vulnerability to the unsustainability of public healthcare services. So longer life, and Neil is doing something about it now. Longer life means bigger healthcare costs and more time in poor health. And this is what longevity is trying to address. So you have more time in good health. So this is a little chart basically to show this imbalance, is that the number of the burden of cost as you get older is disproportionate, and it causes a strain. And digital technologies, whilst having a positive effect, they can also have a negative effect. People are getting obese because they're just sat in the chair being entertained and stuffing themselves with fast food. And young girls are following their social influencers with their body image. And as a result, they're becoming extremely depressed. So digital technologies not only have positive benefits, but they also amplify the temptations and the stresses that affect your health. This is an interesting website, if you ever get to it. So it's called the Death Meter. It shows you almost in real time how many people are dying at that moment and what they're dying of.
Oh, lovely.
And it's great. It's great. It's
So we look at when you can't sleep.
They were Death Eaters from Harry Potter.
But the point about this is to show that people are not dying of infectious diseases these days, even with COVID. The majority of people were not dying from infectious diseases. They were dying from non-communicable diseases, which are lifestyle related and largely preventable. So that is what people are dying of today. And 70% of all deaths are from these lifestyle related non-communicable diseases. So how can we address these solutions? Well, I put them into two categories: preventative healthcare and improving the productivity and performance of staff. On the prevention side, we've got drugs, we've got the healthy exercise, longevity strategy, and we've got technologies that improve the productivity of staff. The problem is that the temptation is there. You know, drugs are an easy fix, and I think all too often the medical professionals go for that because it saves them time. You know, give them some drug. My partner's just gone onto statins, and it's affected her health already, and so we need to be more conscious of comorbidity and the real problems behind people's death. So the role of drugs is an easy option for both doctor and patients, not just doctors. Patients want the quick fix as well. So this is a picture of taken of somebody having the injection for anti-obesity. You know, so it's designed to stop you eating so much and not get. And of course, for people who are overweight, you know, the idea that you can carry on eating or have a little injection that will stop you is really quite tempting, but it's not really a solution. This is my partner's father. He lived with us for the last year of his life, called Eric, and that was his drug regime on the left-hand side of the table. That's what my partner had to make sure he was administered with. I mean, fortunately, Eric didn't suffer from dementia. His brain was quite active, but he had many other medical problems, which led to him living with us, so he could be cared for. When it came to the end of life regime, you can see the number of drugs was drastically reduced. So what we're trying to do today is make this transition from cure to prevention, and behavioural changes in our lifestyles are critical to that. And this is a quote from Sir Simon Stevens when he became the head of the NHS. He said, "We've got to do something about increasing our lifespans and quality of life, and the only way we can do it is to adjust our personal behaviours and to do so at an early age." So how can technology solve the problem? Not just at the individual level, but also at a group level. Well, as we've heard from Fraser this morning, that there are very important health and well-being influences that we can do something about: diet, exercise, hydration, sleep, mindfulness and stress management, and the importance of social support. So these are the 6 pillars of lifestyle medicine. And the role that consumer digital technology, and I use the word consumer, I stress the word consumer because this is where we are going. I know I'm a geek, and I've tried pretty much most of the wearable devices that, you know, come onto the market. I got 2 at the moment. There's my watch, and there's my ring. And I'm very excited about this because it measures a lot of important vital signs, and the battery life is about 10 days. So I don't have to worry about it. And I've got a very good dashboard. And the thing about these technologies as they are today, and I know people in the medical profession rightly are worried about the accuracy of these devices, but my view is that they measure changes. That's the important thing, is if you see changes in your vital signs, it doesn't necessarily be 100% accurate, but it's the changes over a period when you can track the history of the changes that's absolutely vital and important. So these devices, they not only measure the key influences, they can allow you to set your own benchmarks and set achievable goals. So I started in 2013. My goal was to walk 10,000 steps every day. That was how I started. But you also have to have a supporting environment to encourage and help you. And this is where the group consultations that Fraser mentioned are so important. And it's all about trying to encourage personal responsibility and giving people the tools to be able to do that. So these are a range of technologies today that I think are great enablers. And my background, I founded the Serious Games Institute. Gamification is one of the areas of my expertise. And it was gamification really that led me to explore whether I could gamify my own health. And I found out that you could. And we've seen from several examples today that a lot of people are already using gamification, not only for themselves, but also designing it into the kinds of products and services that are available. So we've got exercise technologies. These are some of the types of wearable devices. The device I use is in the top right, and that's what I started with, the jawbone or jawbone up. And now, of course, we have these kinds of rings with associated mobile apps, and these are dashboards of some of the devices that I've used over the years. So with the jawbone up, which I still think was a great device because it measured my sleep, it measured my physical activity, and it rated what I ate. And these are two other devices that I've used over the period. But there are demonstrable results. So this is what I looked like back in 1998, 26 years ago. I don't believe I'm that old. But that's what I look like in my hobby is acting. And this was a screenshot from one of the plays that I was in. In 2011, I've not got much better. I've still got my Partridge. This is me presenting in Kuala Lumpur in 2011. And in 2013, this is what I look again on the stage. And this was one of the things that prompted me to do something about it. Not because I looked at that picture, I thought, oh God, do I look like that? It was because friends had come to see me in this play, and one of them said, "Hey, where did you get your stomach padding from?" And I wasn't very And another friend said, "You're getting fat. You know, you need friends like this all the time." So it went over like a water off a duck's back at the time. But I then met a friend in London for a coffee, and she said, "You should get your DNA tested because I think you've got Russian blood in you. You look like a Russian bear." Because I got the thick neck, I was bulky, and she said, "Go to 23andme.com and just send them a sample and you'll see your genetic origins." So I thought that would be interesting. So I sent this off. No, I don't have Russian blood, but I did find that half of my family comes from an area in the North Sea now, Doggerland, and the other half was from the Basque region. Very little anywhere else in the world. But the interesting thing was it also told me that my likelihood of getting diabetes, and it told me I got a 50% chance of getting diabetes too. And that really made me think. And so I decided to do something about it. So I got, and then the final piece in the jigsaw was I was lying in bed one Saturday morning, nothing much better to do, looking at my phone, and there was on BBC website, there was an article about 10,000 steps and this device called the Jawbone Up. So I put all of these things together and decided to gamify my health. So I'm going to start walking 5 miles, 10,000 steps every day. So I started, and within 3 months, it's a transformation, you know, quite remarkable. And so ever since then, I walk 5 miles every day, and I still do. I've missed very few days. The only time I am likely to miss it is if I go on long haul flights. And even then, I walk up and down the plane or in the airport terminal. I'm still doing that. But I did learn that it's not just exercise; it's about many of them.
How much time do you allow for your 5 miles?
Well, it takes me. Normally it takes me about an hour to do 5 miles, about an hour and a quarter. It's a quarter of a mile. I do a mile in about 15 minutes. And I've started doing webinars when COVID came along, and I got people to come and talk to me, and I made this little video about healthy aging tips with a guy from the USA who is a specialist in health psychology, and he does pretty much the same as me. I'm not going to play this because there's not enough time to do that, but this gives you an idea of what the video looks like. But here, Neil, thanks to Neil, here we are, longevity app. This is quite a while ago. I'd only earned 595 activity points at that point. And my bio age was 69 years. My strength age was 55 years. My cardio age was 67. And you see how it's broken down. I haven't shown you the other two things because my metabolic age was 71. But I'm ashamed to say that my flexibility age was 85. I wasn't surprised at that because I've never been that flexible, and I think the tests that you give me are a bit flaky. So now I have a bio age now of something like 65.
And that's not flaky.
So that's not flaky. And these are some of the dashboards that I've got from my ring, JC ring. You can see some of the status there, and the other one is this watch that I wear that measure my vital signs. I'm not so interested in the absolute figures. It's the trend that's most interesting. Of course, diet technologies as well. There's lots of diet and nutrition apps. I did have a Fitbit, which stopped working when Google took them over for some strange reason. But they did also incorporate recipes. And then there's epigenetics, and again, longevity work with a company called Moodoo, who developed technology, again, taking a DNA sample. And Moodoo was designed for elite athletes. I don't put myself in that category, surprisingly. But it was designed for elite athletes to give them advice based on their DNA, what the best exercise and best diets work for them. And so that will work for everybody. But today I'm using Zoe. Zoe is my new girlfriend. Zoe is the app which comes in a box which measures your blood sugar levels. You take a blood sample, you take a stool sample. So it tells you what your gut health is, what your blood sugar health is, and what your blood health is. And it gives you a gamified environment that ranks every meal that you eat. And I've discovered, and my diet has changed quite dramatically, so that has some influence on the reason why I've lost weight. It's not just all down to Neil and his gym, it's to do with Zoe as well. But I discovered from my eating habits that I'm all right. I'm pretty good. I have very good scores on my diet until it gets to dinner time. And that's when it goes pear-shaped. And so I blame my partner for this because she buys food for dinner. And one good example was she bought Charlie Bigham's salmon en croûte, which sounds really great, and it's a lot very, very tasty, but actually on the Zoe score, you get nearly 0. So I suddenly find myself, with bad ratings for unhealthy fats and a lot of processed food. But Zoe is a good example of the way where things are going. So this is where we're going as far as diet and nutrition are concerned, and personalised diet and nutrition based on epigenetics, but also some influence of medication and AI machine learning. But increasingly, and we are seeing this with a lot of food services that deliver either fresh food that you cook yourself with a recipe, or things like food service which will deliver healthy meals to your door. So I can see these things starting to come together. So you are actually supplied with the things that will be good for you, and feedback, neurofeedback we've seen from Tre, but also feedback from the biometric data collected from wearables. Hydration technologies, there are devices that give you a water bottle and they nudge you when it's time to have a glass of water. And it is very important to have 8 glasses of water a day. That's another one of my disciplines. I don't have any apps that nudge me, but one thing I found very effective is I have a pint glass on the kitchen sink. So whenever I come in and have breakfast, or when I come in and have a coffee break, I see the glass there and it prompts me to fill the glass with water and drink it. So I have a healthy habit, but I need that prompt to remind me that it's time to drink some water. Sleep technologies. Again, this was something that I learned quite early on, and that was from the Jawbone Up. Gave me some links to websites that explain how to help with your eating patterns. One example is leave at least 3 hours after dinner before you go to sleep. So don't have a late meal. That's going to help you. Make sure you're well hydrated. Hydration is also very important for sleep. Then the stress management technologies, there's a variety of tools and apps to support that. And then you've got social support technologies. And in today's atomic families where kids move away from home, it's very important to be able to make those connections. This is an example of a screenshot from Portal, where you get as far as you can do it, the impression that the people are at least close to you or in the same room with you. So when it comes to healthy active aging, these are the messages that I've learned myself. It's about creating new behavioural habits, so it becomes more of a routine. But the technologies, particularly for older people, they must be plug and play. And gamification is very important. So it's important to challenging is very important component of gamification. You don't learn anything without having a challenge that you fulfill. But if you incorporate that with a bit of fun through a game, that will help. Connecting and engaging with family and community, we've seen in rehabilitation the importance of the family in all of that. And it's a bit about providing feedback and diagnostics, both for motivation and health tracking, and giving people more control over their own health. So these are the steps that I think are important in changing your lifestyle. And now, partly because I've gone into AI and digital twins and deep fake and all that kind of thing, I can see in the future you will have your own digital coach, which will be an avatar. And it could be an avatar of yourself, giving you advice on your own health, taking the data that comes from the wearables and everything else, and having a little chat with you in the morning or determined times to give you an additional level of support. So this is one of my digital health avatars. So in conclusion, lifestyle medicine is key to preventive healthcare. behaviour change is very complex, and it depends on your personality and socio-economic circumstances. And digital technologies do have a role to play because they what you can't measure, you can't influence, but if you can measure something, you've got a chance of influencing it. And these are becoming more and more affordable. And these technologies don't exist in isolation. They're all part of a health and well-being digital ecosystem. And this can facilitate win-win collaboration between health stakeholders. So the message is the power is in your hands. The tools are there, they're available today, and we should make more use of them. Maybe I will just show you a little clip of this, just to give you a bit of a laugh, but this is my Old Lives Matter video. This is exercising my thespian tendencies. Where's the sound one? Anyway, yeah, so you can see the point about it is that when you look at me, you get an impression. Some of you know me already, so you've already formed that impression a long time ago. People don't know me, will look at me, and you know, if somebody watching this video would think I'm talking to an imaginary person, and because of what I'm saying, I've got hearing difficulties, and so, or I've got failing eyesight, and I made this video to make the point that old lives do matter, and older people have got a great potential in shaping the future of the world we live in. And I know I've experienced ageism myself in reactions to me and people. I do understand it exists, and it saddens me because like everyone else, I just want to contribute the best way I can. Anyway, that's enough from me. I'm going to stop that playing now and go back to the agenda. So, does anybody have any questions or comments?
Are you casting that? Because I don't see it on the LinkedIn.
It wasn't
it?
No.
Oh, why? What a waste! I should have done that on the machine there. Well, never mind. Now you told me. You were
I didn't
there.
want to interrupt. You're in the flow.
Right, yeah, I was. Yeah. So
the problem with communication, David, is the thought that you communicated further short.
Well, anyway,
you said the illusion that you communicated, but I like to say it's the thought because illusion is too vague.
I now need to go back to making this work again. So I think we've got the next presenter, Serdar Demirel. Are you ready? Let me see if I can find your document first. So you were talking about religion as a progenitor. Okay. Do you want the PDF file or the PowerPoint file?
No problem.
Okay, let me load the PowerPoint file. Okay, that's loaded. I'll go into the screen share. Okay, if you want to come and sit here, you can control your slides, and I will get you back on stage. Hopefully. For someone I need to Sorry about this.
No.
Need to start your screen share. Are you seeing it? Skip, wake up.
I'm awake, but I don't see it.
No, because I have to, I think. No. Yeah. Well, you just have to present to everybody and while I try and sort this out.
Yeah. My name is Serdar Demira. I am going to talk about the religion as the originator and pair of culture. I am going to shift from medical sciences to social science. And my study about the role of religion in creating the culture. In the first chapter of my study, I focused on the broader meaning of culture. And in the second chapter, I focused on, in general, what is the role of the religion in creating the culture. And in the third chapter, I focused on the Islam and the Prophet Muhammad, how he played in the life of the Muslim in creating the culture throughout the history. So, because of the time limit, I will focus only on the Quran and the Hadith. Hadith here refer to the same deeds and the tacit approval of Prophet Muhammad, have a very important place in the formation of religious perception and religious practices in Islam. These two sources determine the worldview, values, and the behaviors of Muslims. The beliefs, worship, inner worlds, moral teaching, and social solidarity of individuals and communities, which constitute the identities of individuals and societies, are closely related to religion. In this context, Muslims believe that Prophet Muhammad is an example in every aspect. Their belief in this also guides the cultural phenomena they create. There are several principles. I believe these are the most important principles among the general principles which create the Muslim culture and the Prophet Muhammad directed. These are, first of all, the monotheism, belief in hereafter, separation of the divine and the human, consciousness of identity and cultural belonging, balance between material and spiritual life, and construction of language and the concept reflecting the Islamic worldview, culture of consultation, and multicultural living model. I will focus on two of them because of the time. Belief in the hereafter. The belief in the hereafter from Islamic perspective means believing in the existence of a second life that begins after the worldly life and continues eternally. This belief is repeatedly emphasized in the Quran and the Hadith, urging individuals to prepare for this eternal life that begins after the death, and to align all their deeds with the pleasure of Allah and the hereafter. This belief has given life to cultural phenomena in the lives of Muslims. One of these phenomena is the institution of waqf, endowment. One of the most important features of the civilization established by Muslims is the institution of waqf and the services they provide. In Islamic civilization, the most significant foundational element that brought the culture of waqf to the life is the belief in hereafter. In the historical experience of Muslims, the desire of attaining Allah's pleasure and in this world and hereafter has brought individuals and society together on a voluntary basis, forming the tradition of waqf. The term waqf, which means to stop, to hold, and to prevent, waqafa, in its literal sense, refers to a charitable institution established through a legal process where an owner dedicates their property permanently for religious, social, and charitable purposes. This is a significant component of Islamic civilization. As the definition suggests, a waqf transforms individuals' material possessions into religious and social services through voluntary and altruistic acts. For this reason, the definition of waqf as an institution established by the deceased and which does not die with the deceased and produce continuous service describe the historical phenomena of waqf. It is an act of dedicating one's wealth to Allah, driven by the consciousness of earning His pleasure. The words, actions, and the encouragements of the Prophet Muhammad have instilled this belief in sentiment in Muslims. The Prophet said in a hadith, in one of his sayings, when a person dies, all his deeds come to an end, except for three: continuous charity, beneficial knowledge, and a righteous child who prays for them. In this hadith, continuous charity refers to lasting and perpetual acts of charity, such as building a mosque, a bridge, a school, a hospital, or an orphanage that continues to provide services even after the person has passed away. As long as these institutions benefit people, the person's record of good deeds remains open, and the rewards continue to be recorded. Therefore, Islamic scholars often associate Sadaqah Jariyah with Waqf. Waqf have provided significant services in various fields, including religious, cultural, military, civil, economic, and social sector. The schools, madrasas, and libraries established by Waqf have contributed to the advancement of education and culture, fostering the development of science, technology, and arts. Waqf have supported calligraphy, illumination, miniature painting, ceramics, marbling, music, and carpet weaving, ensuring the preservation and transmission of cultural heritage to future generations. Additionally, Waqf have offered services aimed at ensuring social justice, reducing income inequality, and maintaining social peace. These Waqf institutions, where different segments of society comes together, have promoted cultural tolerance and social harmony. One of the most significant contributions of Prophet Muhammad to Muslim society and state life, both during his time and throughout Islamic history, is the culture of coexisting he established. This culture allowed for the coexistence of different languages, religions, and ethnicities, leading to the emergence of new cultural phenomena. Prophets initiated his mission in Mecca based on two principles: to you be your religion, and to me be mine. And there is no compulsion in religion. He sought to establish these two principles of freedom in Mecca, and later, when he immigrated to Medina, brought them to the life by signing the Constitution of Medina with the Muslims, polytheistic Arabs, and Jews living in Medina. This practice includes the coexisting aspirations and state models developed by Muslim states throughout the history. With this agreement, different segments of society managed to organize themselves as a political unity, while maintaining autonomy of their internal affairs. Thus, without imposing pressure on anyone, they accepted the other as a natural reality, embraced them as they express and define themselves, and showed tolerance towards their way of living and thinking. Some of the principles envisaged by this agreement are as follows. Disrespect for sacred values is prohibited. The sanctity of holy books and the careful protection of sacred persons and places must be ensured. Different religious identities have freedom of belief and worship. The free practice of religious identities should be guaranteed by the state. The order established by the Prophet Muhammad through consultation was inclusive, transparent, and just, rather than exclusive. Everyone knew where they stood and the extent of their rights. To conclude, it is clear that the religions create cultural phenomena. In this context, Islam has played an important role in shaping the social and cultural phenomena of Muslim throughout history. Thank you very much for listening to me.
Thank you. So we have a technical problem. Do you have any questions? Mr. Dunn?
So I think, religion is so important has been so important for building that kind of good, like guidelines to live a healthy and fulfilling life. In the UK, lots of people are more people are becoming atheists. Can you see any kind of way of transferring some of those important concepts into someone who may not believe or may not believe as strongly?
Even in this, let's say, in Muslim society, we have atheists, but they are Muslim culturally.
Right.
Let's say they don't eat flesh of the pork, although they don't believe in God. And what's the reason? Because they have this culture throughout their ancestors and family from the society. So still it plays a great role.
Yeah.
I mean, I think that's a lovely talk you've given. I think it exemplifies the ideal of allowing everybody to be who they feel they need to be at the time, and actually containing that environment for cross-fertilization of ideas and multiculturalism that makes everybody's lives richer and advances education on a multiple levels. I think it's also interesting to say that in parts of the world where those ideas have been changed to be a very one size, you do what is one facet, leads to the breakdown of those ideas. And
this the Constitution of Medina, which Prophet Muhammad signed with those settlers of the Medina, it guided Muslims throughout the history. Just as an example, Ottoman state. The system was based in Ottoman state, which is called Millah system. Millah here refers to the different religions. So the Muslims, Christians, Jewish, they used to live in Istanbul side by side. And up to the collapse of Ottoman state, the number of the non-Muslims in Istanbul was 45%. But it is only after the collapse of Ottoman state, the number of the non-Muslims reduced after the national state. Because national state recognized only one nation. If we look at the Abbasids, if we look at the other Islamic states, let's say in India, Mongols, we will see this multicultural existing in the society, and based on the religion, based on the Constitution of the Medina.
yes, I mean, I think we can all recognise that diversity brings strength and a mutual growth.
Yeah, yes. Here, the Quran refers to the three types of identity. In the one of the Quranic verses, it says all human. you have been created from a man and a woman, male and female. And for what reason? You recognize each other. And the best of you in the sight of the God, the best of the one who is the righteous one.
Yeah.
So here, three identity has been talked about. One, everyone is human, belong to the human family. They are equal in this stuff. Number two, you are having different nations, Arabs, Kurds, Turks, and others. This is not to claim superiority. This is to recognize yourself, each other. But who is the best in the sight of God? The one who practices good deeds. This is a two identity. One is in general, one is the upper identity, lower identity, and the special identity.
Okay, thank you very much. Erisa, would you like to do your presentation now? Just need to close it down. Find your So you're going to
I got the email. I know, I read but very quick. If you want anything done, always ask someone who's very busy.
Does it matter that your cables are plugged in there?
no, it isn't.
That's what I was. It might be a song to do the Wi-Fi.
Can you just read your
supervisor?
I'm sorry about this. This is because this is a PDF file, and so that you can't do a split screen with a PDF file. So, Erisa, would you like to introduce yourself and then just do the talk? Just do a talk.
First of all, do you mind if I sit down because I feel my heart?
No, I know the feeling. We're all friendly.
For some reasons. First of all, after hearing all your presentation, compliments to each one of you. Secondly, because of my poor English skills. I'm so sorry. And the last reason is because I received a week before an email from your from the British embassy in Albania, just 1 week before, and I had no time to, because I was abroad, Albania. I was on holiday, so sorry for this. So introducing myself once again, my name is Elisa. I'm a nurse, but it's been almost 12 years that I work as a lecturer at University of Jakarta in nursing department. And alongside me is Dr. Gentian Stroni. I have to mention him because he is my lead researcher, my supervisor, and because I embarking on this academic journey, I'm a doctoral student in my first year, and the thesis, if I'm right, it's early diagnosis. Okay. Early diagnosis of Helicobacter pylori through urea breath test among the students of Korça University. So the study focuses on Helicobacter pylori as the main pathogen causing progressive issues in the gastroduodenal area. Numerous studies have shown that more than 50% of population carries Helicobacter pylori, and this value is higher in my country, that is it's a country that is included in developing areas. Therefore, this study highlights advancement in detecting the presence of this microorganism in the human body through the urea breath test. This test is being conducted for the first time in my city, even if it is presented for the first time, I think, 50 years before, in 1983, in USA, but in my city is for the first time, and we decided together with my professor. This test is being conducted, as I said, for the first time in the city of Corcha, and brings innovation as it is rapid, simple diagnostic test with high sensitivity and specificity rates. The aim of this study is the early assessment of Helicobacter pylori in the students' population of Corcha University, identifying carrier cases to prevent the complication caused by this microorganism, such as peptic ulcer, thank you, till the more complicated, that is cancer in the gastrum or upper small intestine. So the use of this diagnostic method will be an innovation in assessing Helicobacter pylori for the city of Corcha, different from its widespread use in developing countries. About methodologies on that. The study is conducted at the University of Corcha. Detailed question. First of all, I am at the phase where I'm preparing some questionnaires for the students, and I will give them this questionnaire to identify those who are with high risk levels of Helicobacter pylori. Then, at the second phase, they are being part of this, let's tell, taking this example, or that is with urea breath test. I don't know if you ever heard. So early diagnosis with through urea breath test, early medical treatment and prevention of complication, evaluation of treating effectiveness by repeating the urea breath test for students with positive results at the beginning of the study. I don't know if I was clear.
It is clear.
But thank you very much. You have to understand that if I was in your position and had to speak in Turkish, you wouldn't see anything. I do sympathise with you. You did a very good job. Thank you.
I have to thank Mr. Mustafa for giving me the chance to be here. It's my first time in London. It was my dream to come here. And here we go. I think only 10% of people who apply in British Embassy have a positive answer.
Yes.
And I'm one of these.
Yeah.
So I'm very grateful. Thank you.
No, thank you very much. And thank you very much for making the journey to talk to us. You know, I think it's very important. This is what IKSAD are very good at. They are committed to sharing knowledge from all around the world. And this is what I would say to all of you. One of the reasons why I invited all of you, apart from the fact that, you know, I admire and I respect everyone in this room for their knowledge and expertise. And in arranging this event, one of my dreams is that you will share your knowledge through future IKSAD events. As I said, there are international conferences literally almost every week. I do not know how they do it, but there are opportunities to present online at all of their conferences. If you're a student, if you want your work published, it always goes in the proceedings of the event. So I encourage you to speak to Mustafa and just be informed about their events, and particularly if it's a theme that you have something to contribute to and want to present, then I'm sure that they will keep in touch with you. So thank you very much. So now we have Helen, and all being well, I shouldn't speak too early, but the challenge is finding where the cursor is. That should appear on the screen. No, yes, here it is.
So when she was done, all you can see is the panel. You couldn't really see her.
And we are. Yours is here somewhere.
I don't know why. Oh, wait a minute. Oh, maybe it is.
Or hide
Go
that.
back a slide, maybe.
Yeah. Okay. So you want to? I'm afraid we have lost our link to. We've lost our link to LinkedIn. I think that's probably because the event has lasted longer than LinkedIn wants you to. It allows you to. But we are still recording, so you will have access to recording. I will intend to publish the individual video recordings on social media, so you'll still get the profile. We've been recording for 5 hours now, so I'll have a bit of video editing to do over the next few days. Anyway, Helen, please introduce yourself and where you go.
Hello, everybody. First of all, I'd like to thank David for including me in today. And I'm just as nervous as you are. So as you know, I'm Helen, and I'm a neurophysiotherapist. So I'm a clinician by background. I'm the co-founder of Hobbs Rehabilitation and one of the founders of the Mint Academy. So Hobbs Rehab was founded in 2005, and it's one of the largest providers of independent interdisciplinary neurological rehab in the UK. We provide a range of services from intense residential rehab through to outpatients and community, offering our patients a seamless service. We also do postgraduate clinical education, take students, and we work with universities in collaboration and research on projects. And we're also early adopters of neurotechnology, which we embed into clinical practice alongside traditional therapy. So we not only work with clinical networks, but we also work with tech industry, academia and research institutes, both in the UK and worldwide. We have a close working relationship with the NHS, and it's through this extensive network of relationships that we have developed the Mint Academy. I'll move this down, does it? Sorry? Can you hear me? So we've this close working relationship, and it's through this close working network of relationships and through the Mint Academy that we've influenced the design of technology and its adoption into clinical practice. So MINT, you may ask what MINT is. The MINT stands for Masterclass in Neurotechnology, and it's a clinical research development clinical education platform. MINT evolved out of the recognition the need to address the disconnect between device developers and research and the clinicians, where we identified there was a large gap. The clinical education delivered through the MINT Academy empowers the therapist to use the technology as part of an intensive rehab program to drive neuroplasticity through a process of clinical reasoning, education, research, and product development. We run clinical consultancy days with industry, which so hearing some of the projects that some of you are developing, I thought there may be some potential collaboration there. But we include patients and specialist therapists, and this ensures a patient-centered design approach to any clinical product being developed. We run feasibility studies, we develop clinical protocols, and run multiple site research clinical trials. The MINT Academy educational platform is designed across 5 levels, from the science behind its use to the application into clinical practice. We've also developed the MINT logbook to collect and record clinical data and patients' responses to intervention and the clinical outcomes. So we launched MINT officially at Rehab Week. I don't know if any of you have heard of that conference, but in Rotterdam in 2022. And we now have active projects with companies across the globe. And clinical partners, I should add. They're not all companies, some of them are clinical partners working to collaborate to produce education. So when David asked me to talk today, I wasn't sure what my topic was going to be, but this is a very shortened version of a presentation that we did at the World Conference of Neuro Rehab. It's in recognition of something that we know is a global problem, and we're trying to help find a solution. So in the next 10 minutes, I'm going to try and present that solution to you. But in order to find a solution, we need a really clear understanding of the problem. And I'm trying to stick to my script because I have a habit of going off on tangents, which means I won't get it done in the 15 minutes. So I apologise if I appear to be reading a bit. Okay, so data. Everyone's collecting it. It's come up in lots of conversations today. We're all protecting it, and it can have monetary value. It's the foundation for AI, but it also needs to be useful and meaningful if it's actually going to serve a purpose. We need to look at why we're collecting it and what we are actually collecting. So within healthcare, there are multiple different types of data sets. I'm going to focus on clinical data. What we want to know as clinicians, what are the data that shows us patient outcomes, diagnostic and prognostic indicators, effective treatments, data that guides future research and informs treatment guidelines. For data to have meaning or purpose, it must be shared, transparent, and actually connected. I'm going to explain a little bit of why in rehabilitation this is particularly a particular challenge, and in an ever-emerging, growing technology healthcare market, this challenge for clinicians is getting even greater, and collecting that data is getting harder. Okay, so the process of rehabilitation is complex. It needs to be delivered for multiple conditions, and it's also delivered across multiple locations. The type and intensity of rehab required is different every single stage of recovery. The funding streams are complex, and they differ within the same country, across regions, and worldwide. And sometimes there's just simply no funding allocated for rehab. Investment in rehabilitation saves money in long-term care costs. We need better long-term planning and joined-up thinking over the whole patient journey. We need to collect the right data to demonstrate long-term benefits and cost savings by delivering the right rehabilitation at the right time, and importantly, to the right patients. Not only are the systems and structures of rehab complex, but so are those who need it. Anything can happen to anyone at any time. We're all different. We all do and enjoy different things in our lives, and every injury is completely unique and any injury will affect each one of us differently. Life consists of multiple facets, but an injury or an illness will impact on all these areas of our lives. And this needs to be reflected in both the assessment and the delivery of rehabilitation. The delivery needs to be recorded, measurable, and reflect meaningful change to individuals. The assessment in the rehabilitation process is delivered by a multidisciplinary team, all with a different focus, but all working towards the same end goal, the best outcome for our patients, the maximum independence, and the best quality of life possible for that individual. Each profession will assess, treat, and measure and record their own findings. But the big question is, how are these findings recorded, measured, and how are they actually linked to each other? I'm going to say very minimally. So the International Classification of Functioning and Disability and Health, or otherwise known as the ICF, was developed by the World Health Organization. And it's a framework used for describing and organizing information on function and disability. Using the ICF for documenting a patient's status allows a common language, provides a scientific platform for understanding and studying health-related outcomes. It also provides a systematic coding scheme. And importantly, the functioning of a patient and their participation in daily life can be described. It shifts the focus from health condition to functioning. For example, someone with above-knee amputation could be competing in the Paralympics running 100 meters, probably under 10 seconds. Or for someone else, it might mean the difficulty of getting on and off the toilet. They're the same diagnosis, but have completely different levels of function. And in the same way, somebody who can't walk to the shops to buy a pint of milk, maybe for multiple different reasons. It may be because they have a mental health problem or they're scared to go outside and they're anxious. It may be because they've got an underlying cardiac or respiratory problem, or it may be because they've had a stroke and they can't walk that far. So multiple reasons that end up in the same disability. You can't label a disability through a diagnosis. And it's so important that we're shifting the measurement of disability from diagnosis into activity and participation. In this diagram, I've broken down the assessment process as a clinician might approach it. In this process, you can see at the top, we use the ICF framework to take information, detailed information from the patient, their medical history, their social and personal outline, as outlined by the ICF. As a therapist or a clinician, we then identify impairments, and these you can see on the left. For example, there's pain, loss of movement, muscle weakness, and multiple other things, loss of sensation. And then we add those impairments, we break down and we actually measure them. And from that, the therapist treating the patients will formulate, I should say the MDT team treating the patients, will formulate a treatment plan by dividing the functional activities into several areas. We can then go into goal setting, which is done with the patient. The process is then linked to clinical outcome measures. The therapists record these and use them, and there's a range of these over here on the right. All of these are different data sets. Clinicians record impairment measures, levels of functional activity, patient goals, clinical outcomes, and functional measurement scales. In addition, we record individual treatments and the impact those treatments have on the patient. So this can include medicine or medical or surgical intervention, changes in medication, hands-on therapy, exercise, task practice, and the use of an ever-increasing range of technologies, some of which we've all talked about today. All of those could be used on one particular patient. The assessment and treatment process identified at least 4 different data sets. The challenge is not only to record and collect this data, but also to find a way to link them so it's relevant and meaningful. And I'm going to try and present this a little bit further and illustrate it with a patient case study. I haven't got an older person in this, but it applies equally to the patient case study. So the concept is exactly the same. Okay, so this is Nathan. Nathan is a 38-year-old elite athlete. In addition to competing, Nathan's job and business was he ran a triathlon coaching business called NFT. So Nathan had a bicycle accident while he was competing, and he sustained a mild head injury and a high incomplete spinal cord injury. And after his initial acute care, including surgery, he made good progress. 8 or 9 months after his injury, Nathan joined Hobbs, and he was able to take a few steps with a frame. But his injury had not just impacted on his mobility, it had impacted on all areas of his life. So we used the ICF framework to group his problems into impairments, activities, participation restrictions. Mobility is one of Nathan's most important goals, and I will say this is still ongoing for him. He's progressed from being able to walk with a frame to walking with no aid inside and outdoors with a crutch. And he was even able to walk his dog, which was one of his really important goals to him. He's able to tackle stairs, and he's able to get in and out of his car, so he's able to access his community. These are some photos that were taken throughout Nathan's rehab journey. We often use him as a case study, because he's very happy for us to, and he's a brilliant example. So some of the treatments target his mobility, and others addressed his upper limb and hand function. I hope you can see this illustrates the range of different treatments, including technologies that we used during Nathan's rehab journey. This illustrates the 4 data sets we collected for Nathan. This isn't all of them, but the most I could put in the slides. You will see the therapy included the use of multiple devices. An important thing here is to note that currently each manufacturer uses a different software platform. We need to find, so as a therapist, you could imagine that 8 or 9 different platforms that we're recording the devices on. We need to find a patient-centered solution that link these 4 data sets together to understand the impact of our intervention on our patients' outcomes. So what is the solution? Any ideas? Half of it, David. Okay, so let me introduce you to Abilitate. So the ICF is used by many professionals across the world, and the initial assessment is structured on the ICF categories: activities, environmental factors, functions, and structures. So let me introduce you to the Abilitate app. So the Abilitate app has been developed by a company working with Hobbs in Austria. They're called Tech to People. And they have worked to develop a solution in which this documentation is now on an app using the ICF codes is now possible. So Hobbs and Tech to People have been working on this together. They have done a lot of the coding, and we have been trialing it in clinical practice, advising them on changes to make the app more user-friendly. The Abilitate app provides a platform that documents the therapy using the ICF categories and codes, and this is also integrated with patient goals and outcomes. The Abilitate is fully GDPR compliant, patient data anonymized, and hosted in the EU. Currently working on MDR and FDA approval. So, the Mynd logbook, which I mentioned at the beginning, which is the recording of the use of clinical technology in clinical practice. So, the Mynd logbook, originally designed as part of the Mynd educational platform, collects the data that clinicians record during the intervention while using the technology. Screens take the user through a process of reflection, not only on a device, how a device was used, but what modifications the clinician needed to make the device work to be meaningful to the patient's treatment session. And really importantly, it looks into whether or not the technology used was successful in working specifically towards the ICF impairments and goals for that patient. So we're working with Tech to People and our colleagues to combine the Abilitate app and the Mynd logbook into a single patient-centered software platform. The working name for this, which is not probably going to last, is temporarily Abilitate. I'm not sure it's going to be the everlasting name, but it seems to work for us at the moment.
Myndplay.
We've looked that up. It's already, that's already been taken. Abiliments. Welcome to suggestion. So machine data without context is worthless. We actually need to know who, what, when, why, and how the intervention that was when the patient was using the machine, what happened. So we're now in the process of our next steps of development. So I've divided this into 3 stages. And stage 1 is the Abiliment app, which is the combining of the Abilitate app and the Mynd logbook, creating a software platform for recording rehabilitation therapy data worldwide, centered around the patient. Stage 2 is the app learning from the data pool and linked to the technology device, data-driven building the foundations of AI. And stage 3 is the generative AI rehabilitation pathways. Currently, there are minimum guidelines for actually what we do when we rehabilitate patients. There is minimal evidence, and particularly when you start engaging with the use of technology in this process. So the machine learning. Our team of therapists and software developers are completing a scoring system, thereby laying the foundation for machine learning. The Abiliment app will collect and compare the data from countless therapy plans of patients with comparable challenges from therapists around the world. The app knows which therapy plan has resulted in the fastest progress for each patient, depending on their individual indication and abilities and impairments. So you linking the device use in rehabilitation back to the patient goals and the ICF framework, back to what I presented at the beginning. Gets even more exciting. So MIDAS. MIDAS stands for Manufacturers Independent Data Acquisition System. I mentioned on the case study that we use at least 10 different technologies treating one patient. And every single one of those technology manufacturing companies has a different software platform. So by developing an independent platform for that data to be collected, it can be centered around the patient. We've got some initial manufacturers already on board who would like to have becoming interested to use this, but we also want it to become an industry standard. And Hobbs is a member of ISART. I don't know if you've heard of ISART. Now, ISART is the International Industry Society for Assistive Robotic Technologies in Rehabilitation. And one of the people we're working with is the new president of ISART coming in. A single platform solves a major problem for therapists, as highlighted by the case study, linking the therapy data from different technologies with just one interface. The technology companies would still have the access to their data through the MIDAS platform, but it would have been recorded through clinical application by therapists who are actually working with patients. And that way it is unique. So combining the know-how, I'm going to say the best therapists in the world worldwide, using Abiliment, we can collect and compare data, generate the best therapy plans, improve patient outcomes, and save money. I hope I've presented a disruptive solution that will change the outcomes for patients through the delivery and informed rehabilitation landscape worldwide. This informed solution has been designed and driven by clinicians who have a passion for improving patient outcomes and have real-life experience of treating patients using rehab technologies, getting frustrated through the use of rehab technology and the lack of guidelines. But this solution will empower them to deliver the right rehabilitation for the right patient at the right time. Thank you for listening.
Thank you very much for that, Helen. Do we have any questions of Helen? I'm going to bring in Steve Gardner now. He's in the States at the moment, but he's going to be the next speaker. Steve, you're there. I need to just swap over. I need to swap over the HDMI cable so that the people in the room can see you, Steve. If you just talk for a minute.
Yeah. Okay. Sorry, David. I outside a hotel in Salt Lake City. So I hope the background noise isn't too bad, but the Wi-Fi has gone out in the hotel, and the hotel has a steel frame, so it's a Faraday cage stopping my signal getting through.
Okay, carry on, Steve. Sorry.
That's okay.
Yeah. Yeah. So, could you introduce yourself again, Steve, and then share your screen.
Yeah. Hi, I'm Steve Gardner. I'm CEO and founder of a company called Precision Life. We are a precision medicine business, but we focus on complex chronic diseases as opposed to the usual cancer and rare disease. And a lot of that is highly relevant to the topics today around preventative healthcare and healthy aging. So hopefully, David, you can see my screen.
Sorry, Steve, we can't see your screen. Are you? Did you click on the present? Are you sharing your screen now?
Yes, I am.
We can only see you. Oh, hang on, just a second. See if there's.
It's telling me it's sharing my whole screen.
Further down. I think what's happened again. We have a technical problem here with sharing screen. Just hold on a second. I will stop sharing this one.
So is the game I have to leave.
Okay. Okay. Where you? Can you? Oh, there we are. Sorry, Steve. We're back in business now, so we've got your screen.
Excellent. Shall I go for it while everything's holding up?
Yeah. Can I just say that to everybody in the room that I think Steve's presentation follows on very nicely to what Helen's been talking about with data and the importance of data, clinical data. This is Steve's specialty area, and he's going to tell you about Precision Life and what they're doing in this space. So sorry, Steve, for interrupting you.
No problem. Thanks very much. Yeah, I agree. It's a very good segue from Helen's talk about what can be done when data are collected in a useful and meaningful fashion. I'm going to focus much more on diseases of aging and what can be done with those. The reason that we focus on complex chronic diseases is because they account for roughly 80% of healthcare spending, and they are the primary drivers why healthcare and in many cases social care is becoming unaffordable. When you look at the primary costs in the US health system, you'll see musculoskeletal disorders, diabetes, metabolic disease, cardiovascular, respiratory, a whole bunch of communicable or infectious diseases, mental health, neurological disorders, all massively outstripping oncology as sources of or sinks for funding. And I'll call out diabetes separately, and I've got an example of that coming up, talking about some of the things that we're doing in that space. But I want to go back a little bit and just compare and contrast the way that the world has moved forward in that oncology space versus these complex diseases. And back in about 2000, I was working with the first round of the Human Genome Project. In fact, I'd been working with it for about 7 years at that stage, and there was a huge sense of optimism that understanding the genetic makeup of patients was going to be very useful in providing new solutions. And in fact, that's come to pass. What we've done is turn cancer from an anatomically defined disease where we would give patients with breast cancer the same drug just because they had tumors in their breast, into one that's defined from a molecular standpoint. Sorry. And here we analyze the genetic makeup of a tumor and give a therapy according to that. Unfortunately, the frustration is that hasn't worked as well in cardiometabolic, in respiratory, in women's health, in neuroscience based disorders. And so that's what Precision Life set up to do. Like Helen, we take a wide range of data sources. So here, genomics, clinical history, transcriptomic, proteomic, epigenetic data, imaging, epidemiology of the patient, the environment that they live in, and a range of lifestyle information. These come from a very broad range of sources, and you know, as we've seen, these all have their own formats and their own ways of handling data. What we use that for is best represented in the center here. So this is early onset Alzheimer's. Everyone whose data has ended up on this graph has exactly the same diagnosis. They show up with the same symptoms in the clinic, and yet decades of experience says that they're not going to respond to drugs in the same way. And this is what we're trying to get under the skin of. So the colors here in the clusters represent different patient subgroups with a different molecular cause to their disease. And in fact, we can see that the anti-amyloid drugs, which are very much in favor at the moment, this blue group, they represent the biggest gene target, the biggest mechanism driving disease, but it's only still relevant to about a third of patients. And there are many other ways of getting a diagnosis of early onset Alzheimer's through different mechanisms. And those patients will respond to different drugs. So understanding this is at the basis of being able to treat disease much better, and indeed predict and prevent those diseases from reaching a point where they become as serious to a patient as you would expect, and therefore as expensive to treat in a healthcare setting. So as a business, we have studied about 50 different diseases, covering a broad range of therapeutic areas, with a broad range of symptomology. But these account, as I say, for about 80% of healthcare spending. I'm going to give you a case study in a disease that currently is not really recognized as a disease by many clinicians, even though it clearly is. It has no diagnosis, it has no therapies, and we don't even know which tissues in the body are involved in the disease. Just to show you what can be done now with these types of data approaches. This is a clinical, a genetic stratification of myalgic encephalomyelitis, or chronic fatigue syndrome. So this is a profoundly debilitating disease, like long COVID, but a much more severe form. And it affects, it's estimated, around 100 million patients around the world. So very high prevalence, albeit at different levels. What you're seeing, what we were able to do is to identify for the first time and replicate genetic signatures that are associated with the disease. And in fact, we have about 200 mutations here, which in one shape or form are associated with the disease. And we've clumped them together, clustered them by the patients in which they co-occur. So by itself, this is a groundbreaking result. But what we're also able to do is to correlate those clusters with the patients in which they co-occur to see whether the way those patients are presenting in the clinic is consistent with this form of disease. And here, the green group represent patients who have defects in their ability to recreate energy stores in cells from their mitochondria. And so you would expect that if that is the defect that they have, these would be the patients who would be presenting with profound fatigue, especially after exercise, this post-exertional malaise. And in fact, that's exactly what they present with. As opposed to the group on the left, the blue group, who have defects in neurotransmitter biology, they basically can't produce serotonin at the right level. And so you would expect, and in fact it turns out to be the case, that these are the patients who have cognitive impairment or brain fog, and they have mood disorders and sleep disturbance. So from a disease that's never had any understanding, we've been able to tease apart and use existing clinical evidence to validate the mechanisms driving this disease. So where can we go with this? Well, the theme is around prevention of disease and healthy aging. So what I want to talk about is where some of this biology takes us into processes that we can see are actively protective against complex chronic diseases. So taking this MECFS example, we did something incredibly naive. We went back and said, how many times can we see these genetic risk signatures in patients, which is on the left here, versus controls, which is on the right? And if there was no distinguishing power in our genetic signatures, these distributions would be exactly the same shape. But as you can see, they're quite radically different from each other. And this means that we have good predictive value or good odds ratios from the data. In fact, the predictive value is very similar to the predictive value of genetic tests like BRCA at predicting risk of breast cancer. So this is really exciting, and we can reduce this to practice into a saliva or a blood test, and I'll come back to that in the next section. But what it also allows us to do is to start to say, okay, now we have a very good risk signature that can show whether a person is at risk of this disease. Let's go and screen an entire population. And here we've used the 500,000 patients in UK Biobank. I keep saying patients, I should say people, who don't have the MECFS disease diagnosis. And let's evaluate what their genetic risk score is. Now, many of those will have a low disease risk. They simply don't have the susceptibilities that drive towards the disease. But some of them will have really high risk factors. They'll have had all of the exposure triggers. They'll be as old as possible, but they haven't got the disease. So in some way they seem to be resisting getting the disease, even with all of those risk factors. The question is why? So now we can subtract all of the disease processes, and we get left with a set of genes and drug targets which we believe may be actively protective. In other words, they are processes that are working in the background of your cellular biology to stop those disease triggers leading to a full-blown form of the disease. And this is clearly incredibly exciting. Pharma companies have been chasing these types of targets and have had very little success in doing that. We can now do this systematically. And it means that we can look forward to a new generation of precision-targeted prophylactic drugs. And of course, as we're bringing in new therapeutic mRNA vaccines, we can anticipate having a vaccine that's delivered into, for example, the muscle tissue, which turns your muscle cells into little factories producing proteins that are protective against some of these key disease drivers. And this is super exciting. In fact, we've seen some of these in ME/CFS itself. We have, for example, found the same gene in 2 independent runs, which is involved in the transformation of tyrosine up to dopamine, which is an important neurological driver of some of the symptomology of ME/CFS. And through one of our clinical partners, which is why I'm in Salt Lake City, there's anecdotal evidence that patients receiving drugs that affect this target just coincidentally, because they're being given them for different diseases, they're actually the ones who are responding better and have less severe disease and have the potential for quicker recovery. So we are testing, we've kicked off a clinical trial of 1,000 patients with our partners, the Metrodora Institute in Salt Lake City, to test a series of these. Firstly, we're trialing the diagnostics. So for the first time, we'll be able to predict a patient's disease risk well ahead in many cases of them actually getting the disease or its symptoms. And we're evaluating the diagnostic accuracy here. But we're also bringing in a series of drug repurposing candidates that match the particular mechanisms that we can see in individual patients at high prevalence. And we're recruiting small groups of patients to trial these medicines to see whether they have a disease modifying effect. And this is incredibly exciting because it offers us a route to shortcutting the typical 12 years and $2.5 billion of putting these drugs on market. We're aiming to read out the trial this year. It only started at the beginning of this month, so 7 or 8 months of trial, and get these medicines to patients that for the first time will offer them some symptomatic relief. Now, we're aiming to do this across many of the diseases that we highlighted. I wanted to go back to type 2 diabetes. This is a $2 trillion problem around the world. And that $2 trillion, 3% of GDP in the US spent treating diabetes. It's not spent on metformin or even insulin. In fact, it's spent mainly, 80% of it is spent on treating disease complications. This is when patients go into cardiovascular events like heart attacks and strokes. They get renal failure and need dialysis or transplant. They get dementia, they get blindness, or need amputations. At the moment, there's no way of predicting who is going to have those most severe forms of disease and therefore cost the most. So we've run that study. We found 6,000 patients who tolerated diabetes for decades without undue problems. And we compared them against 3,000 patients who went on to develop serious complications very quickly after diagnosis. So we wanted to separate out that complication signal. And we have been able to develop a model that allows us to predict at the point of diagnosis which disease trajectory an individual patient is likely to go down. And this is really important because it buys us a 5-year window between initial diagnosis and the onset of these complication symptoms, into which we can deploy tailored interventions, monitoring, lifestyle changes, and even therapies to reduce the progression of some of those symptoms. These interventions are well known to work. Just looking at blood pressure on a biannual basis is enough to reduce kidney failure by 80%. The problem is they're just too expensive to deploy across everybody, because about 80% of patients don't need this level of intervention. So being able to do this is a way of saving a huge amount of money. It may benefit everybody. You know, we can pick up patients who would benefit from drugs that reduce the onset of chronic kidney disease and therefore present an opportunity to reduce dialysis and transplants. The problem is this drug at the moment is only prescribed in relatively late stage renal failure. Wouldn't it be great to prescribe it earlier to preserve a patient's kidney function such that they may never experience symptoms of kidney failure? Which brings me to my final slide, which is I was asked to talk about AI. A lot of the methods I've been describing pull heavily on AI, but you will all have heard of large language models and some of the things that they can do. So one of the projects that we're involved in with a very large health system in the US is starting to use their clinical notes as a predictor of those patients who are showing very early disease symptoms that might be associated with being at risk for one of these diseases. That gets us to a potential at-risk cohort. This is a very quick and dirty screen. These patients don't necessarily have the disease. There may be other reasons for that symptomology showing up in the clinical record. But if we now go and test those patients genetically with the type of signatures that we've been describing, we have confirmation not only that they're showing symptoms in the clinic, but also their genetics backs up that they're very likely to have these diseases. And these would be candidates for early prescription of medicines, of high monitoring, and changes in their lifestyle that could bend the curve away from that disease risk. And I think this is a trend that we're likely to see in the future. So with that, I will stop and say thank you very much again for inviting me to speak. Apologies for any background noise that may have come through here.
Thank you very much, Steve. Do we have any questions for Steve?
Fascinating material. Love to work with you, and very excited about the deep dive with your data. It's something that it's all close to our hearts, but we don't know quite what to do with it.
Yeah.
Can I have a question? And it's on the diversity of the number of people. We have 6,000, 3,000. So what is the diversity? Because as we all know, NCD affects people of brown, black origin more than other people.
Yeah, it's a fabulous question, and one that we struggle with all the time in these approaches. The UK biobank population is about 93% white British, and obviously diseases affect people of different backgrounds and ancestries in very different ways, also different demographics. It's one of the reasons why getting into the US offers us an increase in diversity, and we are very actively looking for partnerships with patient populations around the world in order to increase that diversity. But technically, the methodology that we use translates much better across different diverse populations. I can offer you an example from endometriosis, where we found 10 times as much signal, explained 5 times as much disease variance, and our results replicated 9 times better than the best current gold standard analysis that's been done, simply because we recognize that complexity and the fact that different populations have different drivers of disease.
Getting a lot of wind noise.
Yeah, apologies, it's very windy here.
Can I just ask? I mean, I think it's fascinating and inspiring. Often, I think we've heard a lot about interventions and prophylaxis to prevent disease, and obviously identifying susceptible populations is absolutely core. Often these lifestyle interventions require compliance and understanding and education within the patient populations. And as somebody who's very much geared to trying to help people help themselves, I was just wondering whether you had any other alliances or integrated ways of doing that, because prophylaxis requires engagement, doesn't it?
It does. No, I mean that's extremely fair. I think with things like type 2 diabetes, it's very difficult. Sorry, I'm just going to shield my mic a little bit. It is very difficult, but in a variety of the diseases that we work in, we're actually working with the patient foundations very closely in order to understand the patient experience of disease, the things that they care about, the things that are most troublesome to them. And I think one of the things that is very useful in this context is personalization of advice. You know, this is your form of the disease. These are the things you're most likely to be susceptible to. These are the things you can do to actively prevent your disease. Not 5 a day, exercise more, stop smoking, stop drinking. You know, that public health message, I don't think gets through. Personalization does in a much better way.
Thank you very much. Any other questions? No? Okay. Steve, thank you very much for joining us today. I'm sorry you're not able to be with us, but very insightful. As usual, it's what I've come to expect from you. So thank you, Steve. Enjoy the rest of the day. I'm now going to bring in Adam Townsend. Adam, would you like to introduce yourself and start?
Yeah, of course. So, hi, I'm Adam Townsend. I'm one of the founders of ViewIt. We are a data company. We specialize in the ingestion and manipulation and visualization of what is predominantly population health data. So I am going to share my screen. I don't know which screen I'm going to share. That could be a challenge, right? Entire screen. There we go. Am I presenting what you would like to be able to see?
Yes, well, you are. Yeah, sorry.
Perfect. Right. Okay. Well, thank you for having me. It's so inspiring listening to the conversations and the presentations earlier, and some real gems for me. I'm hoping by the end the title of this will make sense. I'm just going to tell a few stories with a few pictures. So our passion is big data and what it's capable of. I use the word passion very selectively. There is an argument that the big data movement is about, you know, something that's our ability to show off by being very, very technical, and we don't sign up to that view of what big data should be about. This is our view. It's very practical. Actually, big data is only useful when it's put into harness, and typically when it's used in conjunction with other big data and combined. And there was a conversation earlier around, you know, how do you make that data interoperable? And there's a lovely saying that goes along with this visualization. So yeah, we're probably a good stupid horse. Why do we exist? So over 10 years we've been combining data, and we've been using this slide for all of those 10 years. This is what our passion drives us to, and without doubt, the ability and need to generate better pharmaceutical solutions is very real as the population ages. But equally, when 75 to 80% of our health and well-being outcomes are driven by non-health factors, and there was in one of the presentations earlier, and I'll reference this a little bit later, there was a product that addresses black mold in houses. So we're very much about understanding the wider life experiences and wider determinants that a population is understanding at a hyper-local level. So taking that data, overlay, making it interoperable, making it longitudinal, and then taking it down to very small geographies to understand where we can deliver interventions specifically, rather than, as Steve said, some of these things are just too expensive to deploy across everybody. But if all you can see is everybody and all you've got is data on what the average person, there's no ability to deploy these interventions precisely. So that precision delivery of interventions into populations is what we're about. People say, "Can we look at your data?" So there it is. This is a visualization of our SQL Server. We've got views and tables in there that are all interoperable with each other. We think we've got about 29 billion interoperable data points. This is what's in there, a sample of what's in there. So everything that is in our data set is fully GDPR compliant, fully available to be used commercially, and is government standard for redaction and consolidation. And we bring it together and make it, as we said, interoperable and longitudinal. But we have everything from Food Standards Agency data, crime data, charities, a lot of the health data that you'd expect to see, care home data, provider data. We bring all of that together, education data, things like adherence to medical regimes. Well, education, skills and training deprivation is going to tell you where actually some people are going to find it really hard to adhere to their medical regimes because actually their literacy and numeracy doesn't support them to read complex labels. So that's just a really quick example. So that's what we have. That's what we serve our customers with. I'm going to touch briefly on AI. We are putting an AI layer, a large language, and a Gen AI layer in. There are two reasons for that. The visualizations I'm going to show you shortly are the ones that our customers have asked us to develop and deliver to them over time. They answer thousands of questions because they're very configurable. But we know that there's the opportunity to answer millions of questions. And the only way we can do that is to allow people with more specific questions than we would have, or more intelligent questions that we could think of, because we are not experts in all of these landscapes. Giving people the ability to do that is really fundamental to getting the most out of leveraging the most out of the data that we've brought together. The second reason is a commercial one. We know that once we built that landscape in a large language model Gen AI framework, we will be able to ingest data across multiple countries without having to reimagine it. So we can tag it into the Gen AI, and we will be able to interrogate it because the AI will understand that data in context because of what we've taught it about the landscape we've got in the UK. So the ability to go multinational and certainly, move into America is very much our next step. And we know that most of the data that we're showing you here actually exists in the US, and we could ingest it and launch minimum viable product very quickly. And it's just a couple of quotes here, in terms of how it might help to support redefining clinical trials, and our big ambition. Could we get a health and wellbeing digital twin of England? I'm going to focus in now, the title, an aging population. I just want to kind of stand that on its head and put forward a thought that we might be looking at it through the wrong end of the telescope. And again, there was a comment earlier about the fact that historically there are enough working age people to generate enough tax to pay the pensions of the older people, and that is not the case. But that's not just a product of people getting older in pure numbers. It's a product of there being massive swathes of England and the UK where people of working age are not able to work because their long-term conditions and their health and well-being prevents them. So we've got the sick working age person looking at the old person who is becoming increasingly old because their ability to keep people alive is increasing. So I just want to sort of take the opportunity in this presentation to just, as I say, look at it through the other end of the telescope. Why do I think it's important? So this is the first of these are visualizations from our tool. This is a graph that shows life expectancy versus healthy life expectancy. And over here, we've got Manchester, who have a life expectancy of 79 years and 61 years of healthy life expectancy. So an 18.4 year gap. And Surrey Heartlands, which is Surrey is adjacent to London for people in the call that aren't UK based. Very, very rich area. Life expectancy is significantly higher, and healthy life expectancy is 3.9 years longer. There are 4 million people in Manchester. There are 1.1 million people in Surrey Heartlands. You know, the rough maths says that ultimately, if we take those 2.9 more people and 3.9 less healthy years, there is an 11.4 million healthy year opportunity in one ICS intermediate care service. These are the geographies that the UK splits itself into for healthcare. They run at about 1 to 1.5 million typically. But yeah, just wanted to frame that, you know, so this is very much about that healthy years opportunity, and that our age versus our and there was a really good presentation about what's my heart age, what's my physical age, my activity and flexibility age. Fundamentally, healthy years is it's the same objective whether you are 80 or 48. That these are the years that we should be supporting people to have. These are the years that if we can improve, will actually reduce that significant burden, partly because more people will be able to work, but partly because people, as they approach older age, will be healthy, will be living healthy years and not unhealthy ones. So again, visualizations of this is a part of the West Midlands, just to the west of Birmingham or northwest of Birmingham. I just wanted to flick through some of this and see what we can start to see. These little coloured patches are called lower super output areas. This is the lowest currency that we can measure a population in with government issued data. Typically about 2,000 people in a town. That could equate to 2 or 3 streets. Obviously, in rural areas, they're bigger footprints. But we can know a lot about each of these LSOAs. And here, for example, this is a heat map of where our over 75s live. So there's a little place called Aldridge up here. And this is our number of long-term conditions per patient. And it's like, well, this is not a very surprising visual. That actually, where we've got older people, we've got high long-term conditions. Actually, what I've changed that to now is to cancer prevalence in this same footprint. So we can see where our aging population is, and we can see where our cancer prevalence is. And it overlays almost perfectly. So if we look back a slide and talk about the average long-term condition burden in our population, we can see that most of our long-term condition burden lies with our over 75s. But when we start to exclude cancer, which realistically is it affects more people as they age, and we start to look where cancer is less prevalent, we can understand that in these populations where over 75s are less prevalent, there's a pretty good reason for that, and that is because the deprivation, the wider determinants, and the long-term condition prevalence of other things that will kill you is much higher. So now we're looking at diabetes versus the over 75 population, and immediately we can see that our diabetes prevalence is not residing where our older population is. So actually, if we want to support and prevent diabetes, prevent diabetic exacerbations, work with people who are at risk of diabetes, and we can show this for obesity as well, which paints a very different picture. But fundamentally, the message here is that, you know, the association between healthy years and or supporting an aging population using the number of years it's been on the planet versus an individual's march towards death, be that earlier or later in number of years, it just, I think, raises a question of, you know, are we using the right currency when we talk about the aging population? And I think we just need to be careful about that. Talked about this earlier, so here again, sticking with the over 75s, this is a subset now. This is a local authority within that footprint I showed you earlier. So this is Sandwell. I like picking this one because it looks like a woolly mammoth. It's got its legs and its trunk. So here we're looking at deprivation, and again we can see that where our deprivation isn't quite so bad, our population is older. So this is where we start to understand the wider determinants are at play. So education, skills and training, crime deprivation, income deprivation are very, very closely correlated to these long-term conditions that will be limiting healthy years. And then I've just picked one of the little LSO areas that I talked about just to show you. So for every one of these LSOAs, we have a raft of information that we can layer because it's interoperable, because it's longitudinal. And this is just a bigger version of the visual to the right. So, you know, just as a snapshot of what's in that little area, there are 3,300 people in there. This is the percent that's over 75 versus 0 to 16. So actually, we know this has got very high deprivation, and very high population of young children as a percentage is clearly correlated with that higher deprivation, because you don't typically get to be over 75. We can look at ethnicity, and there was a comment earlier about how do we engage prophylactic solutions in a community. Well, actually getting the messaging right at a hyper-local level, and that will include making sure that we're communicating in culturally appropriate ways, but also when we look at education, skills and training, that our materials are appropriately worded so they're easy to understand. We have areas where there are digital deserts, so people aren't accessing digital technologies, so we may actually still be putting leaflets through people's letterboxes because we know that typically they're not accessing emails, social media. So all of that information, we start to take that big data and get down to a hyper-local solution, or the ability to deliver hyper-local solutions. And in terms of how could this apply to things like medical trials? Well, if you're looking for a population that's specifically got high levels of Black and Black British people in it, or Asian and Asian British, who have a higher prevalence of smoking or obesity, or you can set a persona against any of these characteristics, and we can show you where you are most likely to find those people in England, and hopefully as we progress across other geographies. So that's why we think we've got a place in supporting better efficacy in clinical trials, and part of that is to enable those people doing those trials to go to communities where they are most likely to see a broader section of demographic. So I've just put this in again because there was a comment earlier in a presentation about black mold. So I challenged myself to say, could I just quickly do something about that? Because we work with a lot of housing associations, and it's a real problem. So what I'm going to show you took me, because we've got these tools that we can deploy and just use the drop downs. This took 6.5 minutes to prepare the slide by dragging and dropping pictures in from our tool. This is energy efficiency, but so when you buy a house or sell a house in the UK or rent a house, an inspection's done called an EPC inspection. You get a nice one-page certificate with some pretty colours on it. There's 96 data points in there that tell you what kind of windows there are, what kind of heating is the primary use, what the emissions are, what the CO2, whether it's insulated. So you can start to identify poor quality housing that, for example, might be prone to having mold. And we can actually start to identify where we've got high levels of privately rented houses, which are poor quality. Why is that important? Because when we start to look at where our children are in this footprint, we'll be able to isolate areas where we've got poor housing and high numbers of children. More than that, this is DWP data, benefit data. So we can see universal credit households which have any number of children in them. Again, all GDPR compliant, and this is where the layering of the data creates incredible insight. So we can start to see vulnerable families on low income in poor houses, which have a higher chance of having black mold. So where would we go? If we could just go to one, we could run the data on this and effectively give you a hit list of start here, then go there, then go there. So the ability to deploy things like the black mold solution at pace to maximum efficacy become very real. This is asthma sufferers, so we might be able to see where we've got high asthma and COPD prevalence versus poor quality housing. And I've just put over here now, so we can see this is the private rented. In that little footprint there are 106 privately rented houses. The current energy rating is 59, good is 30, poor is 70. So yeah, as I say, 6.5 minutes to put that together, but fundamentally, I mean, hopefully that just gives you a view of the incredible solutions, interventions that I've heard talked about today. There is a way of understanding how we could deploy them into populations which are aging fast, but we wouldn't typically associate with solutions aimed at aging populations. And that's me.
Sorry, you didn't hear that. Just somebody said, "Do you want a job?"
No, I started a business so that I didn't have to have a job. And actually, I wear a Fitbit, David, and mine says I should eat less, move more. My heart age and my physical age are, well, my heart age versus my physical age is terrible because I run a small business. You know, there are 5 of us, just for some context. There's 5 of us in the business. We did £500,000 across the NHS and pharma last year. We're going to double that the next 3 years. So no, thank you for the kind offer. We're keen to talk. We're keen to talk to partners that are working in America.
Adam, it was only in jest, but thank you. That was an amazing, amazing presentation. B, true to my heart and my seaboard, which I'd like to introduce you to. But are you, just out of curiosity, just to add a little bit more sort of texture, could you identify the relationship between black mold and medical assistance or litigation or other extended potential for black mold, and how that might be interpreted in an aging and or other population?
So the answer to that is no. However, what we do have ambition to do is to pull in clinical research papers. So when we're chat enabled, we will be able to say what's the highest where are the highest correlations of at-risk populations and poor housing quality, and based on the available research, what's the clinical impact of that on those people. At a higher, at a simpler level, what we can identify is, because we hold prescribing data for primary care, is we can see if there's unwarranted variation in prescribing of things like inhalers and child inhalers in those geographies where the housing quality is poor and the vulnerability is high. So we can actually identify clinical harm, if you like, or clinical risk that's being managed in primary care that's directly correlated to poor quality housing.
That would be great to work with you and have that conversation offline at some stage, Adam, if it's approachable.
Please do. Yeah.
Okay.
Yeah. David, please feel free to. Yeah, please feel free to share the slides, David, and my contact details are on there. But thank you for the kind words. You know, it's quite an illustrious group of people to be involved with, and yeah, thank you.
I wouldn't call myself illustrious, but just an opportunity.
I wasn't talking to you. I'm joking.
Adam, can you hear me?
Yes.
I've got a question on like, where are your main data sources? Is it this publicly available data that you're bringing into one data lake? And you mentioned like wanting to scale out, and like I know that one of the biggest engineering challenges is actually just getting those different data sources into a usable single format.
Yeah.
So how are you like bolting on different data sets?
So we used to be terrified about talking about where we get our data sets from, but the reality is 10 years of taking data that's published into the public domain by the English government initially has made us understand just how bloody awful it is and how uninteroperable it is. So creating the keys and the common currencies to make that talk to each other and overlay with each other is the magic sauce, if you like. But now, as we've become more proficient at that, there are still 40 odd Office for National Statistics data sets that we're yet to ingest, but we know we can do it. There's a list, I think we've got a list of 40 or 50 data sets we know we could ingest if a customer wants them. And then, as as we move to the States, the NHS data that we have, Medicare, Medicaid have got that, but actually will sell it to you with far more granularity than we're allowed to use it in a GDPR compliant world in the UK. So the ability to replicate this product across countries, or as was pointed out to me the other day, if someone wanted a population health data set and tool that actually worked and they had nothing, please don't make it like the British government does, because that doesn't work. That's why we exist.
So if you in the States, if you try and go the partnership route with like Medicare Advantage, they're a little bit like they'll be quicker to adopt and look at you. There's a bit of a regulation kind of crisis at the moment. I think around like two years. But the Medicare stuff, like they have so much insurance-backed data. I'm sure you'll be able to add, but like, yeah, you'd have to go like find some real good partners. But some of the Medicare Advantage plans, that's basically like the value-based healthcare system in the States.
Yeah,
they're a lot more willing to adopt new solutions and partner and kind of especially as companies.
What we do know is that in the UK health economy, the appetite to pump prime these preventative solutions doesn't exist. In an insurance-led, regardless of what we think about insurance-led health economies, an insurance mindset says that if you can show me how I can get upstream and prevent diabetes exacerbations, prevent COPD and asthma exacerbations, if it's less than the episode for that person to be admitted into a hospital, I'll put the money up front. know I'm going to cash the check as an investment. So the insurance model gives us a return on investment landscape, which if we had in the UK, wouldn't be in the mess we're in. That is not to say, you know, putting in privatized, but it's that return on investment mindset as opposed to a profit and loss one, which makes places like America and other insurance-based economies more able to adopt into innovations and more able to use data like ours to say, wow, that's an absolute no-brainer. The 10-year burn return on investment on that is 50 to 1. When can we start? We start tomorrow, but go there first.
Yeah, there's a couple not this, you know, same but similar areas that have done very well by kind of initiating in the UK and then going US for to get the funding and to get that off the ground. So
it's interesting because my background's in doing improvement work in the NHS, and I'd spent a while as a divisional director of medicine, ran an A&E department. But what we built has come up out of our understanding of the UK health economy, so we had to do that first.
Adam, I'm Sandra Cowan, Future Care CEO, founder. We're working with Vitality. Well, we've got an introduction to Vitality. We've had a conversation with them. We're not ready to reapproach them, and we've also had a conversation with State Farm, which is the leading protection insurance company in the States. So there's lots of synergy that I can discuss with you.
Please do reach out. We're really keen to test the capability. You know, just how far can we go with this? It was the fact that it's turned into a business is great. The fact it could be a scalable, successful business is great. But our appetite is to find out what the limits of its capability are. That's what we're in it for now.
I'll happily debate that with you, with my colleagues.
Thank you.
I'm just enough.
Okay, we just need to swap this over. Thank you very much. Thank you very much, Adam.
No problem. Very welcome. Thank you again. It's great to be with you.
Right. Well, while David is setting this up, I'm going to things up a little bit. I'm Dr. Anthony Skip-Basil, and I'm going to ask you to take your chairs and move them because we're going to make a semicircle around.
I don't think we've got time for this.
We do. Trust me. Quickly. Come on, he's in a hurry. And I've got some papers here. This is going to be a bit interactive, so we're going to ask you to get your phones out and scan that, or on your laptop, take this web address here. So move around this way, please. Come on down. Since we're going to be in a semicircle. Here we go.
Change it so that people can see what's sharing and then start sharing something else.
Right. So while David is getting that going and my presentation is up, so everyone's in a position, to sort of make a semicircle anyway here. At least we're not sitting in long rows. That's what we're trying to move away from. So while David's getting that, the comments that the previous presenters made. For example, Neil said, "You don't know what you don't know," and I thought that was a good starting point for my presentation. Fraser and Andrew said that it's the importance for education. All right, so that's what my focus is going to be about. Is the education side. How can we raise awareness? How can we educate? Oops, all right. Oh, there we go. Okay. How can we educate the healthcare staff and participants? Ellis and Rebecca and Tre identified gamification as being an important element to promote engagement. So this is how we're trying to apply this to my talk. Is it ready now, David?
Yes.
Okay,
Yeah.
all right. Oh, well, hold on. How can I access it?
Sorry.
Where am I? Just.
Okay.
Right, just click on there.
Is it that? Do we click on that that V then?
No, that's just synchronizing now your device to the game that we're going to be playing in a minute. All right, so you just bring it up to where the buttons are. Don't start pressing the buttons yet, though. Yeah, that's the QR code. That should bring you to, or you could just go to the browser and then put in abasel.uk/augmented reality, whichever works easier for you. All right, well, is that right then? So then if you just do slideshow.
No, it's not. Yeah, but it's just too long. I'm sorry about this.
That's all right, no problem.
Yeah.
What was it supposed to be saying, yeah?
Perfect. Yeah.
Where's the cursor? Can you see the cursor on that?
So I have access to the cursor here. Well, that's, its scale doesn't look very natural.
And you go, yeah, see, that's working. Right. That should be one.
Okay, but I need to be able to, see, I'm not, but I need to be able to get to, the slide.
Just use your arrow keys to go about the slides.
Yeah, but I want to click on the stop videos as well. All right, well, let's give it a go. All right, so. Okay, so I can't click. There we go. All right. So the title of my talk is Artificial Intelligence Learning Simulation Model to Support Healthcare Professionals. All right. Hopefully you've gone to my website now and you've got access to that. At the end of this presentation, we're going to be doing an interactive display together. What we'll be doing is we'll be using those buttons. So in the first instance, we'll just use one finger to tap on the left and right button. Then we're going to recreate the simulation again, but you'll use two fingers. Okay. So what is this model that I'm proposing? It's a 4-stage model. So when we're talking about training healthcare professionals, or as some of you have identified, making people aware about the different projects that you're working on, there are approaches that we can take. The first is a pre-test to establish a little bit about the stakeholders' prior knowledge. What is their tacit knowledge? What is their professional knowledge? Then, instead of doing a normal training that you might do, where it's procedural and then you have a written test at the end, have any of you done any simulation learning where you've used either augmented reality or, okay, a couple people? All right, okay. So I was a postdoc researcher at Bournemouth University for the School of Health and Social Science, where we were researching quite extensively face-to-face and online simulations. So you've got this role play where the learners actually get to apply the knowledge. That's what we're looking at. And arguably, one of the most important parts is the debriefing. After you go through that simulation, how can you unpack it? What reflection can you have on the learning? And then the final stage of this model is the evaluation. Okay, now that you've gone through the simulation, have you met the learning outcomes? So as I say, with the pre-test, what we want to do is establish this prior knowledge. What do the people come into the learning experience with before? So it's not tabula rasa, it's not blank slate. So with a pre-test that can be generated either by the tutor or the learning facilitator, they can put together a type of multiple choice quiz type question. But if we take a kind of Web 2.0 learner generated content approach, we can get the stakeholders, the learners, to use AI tools to also help generate a pool of questions in that specific subject area. Then the next stage of this is the actual simulation. All right, so now how are we going to create a scenario for the students to go through and experience and apply that knowledge? Well, as I say, we want to be able to identify what their prior knowledge is, and we can get the students, we can get them to work with the tutor, and the tutor can also use an AI generator to develop this script. So we have the script for the stakeholders to go through the scenario. While, just like what David is doing, while this is going on, we're also recording the event. Well, okay, stage 3 then. They've gone through the simulated experience. Now it's time to debrief. Now it's time to talk about what they experienced, what their feelings were. Did they achieve the solutions that the tutor was expecting? What unknowns came about? So in this case, we can have the moderator working with the students in a Socratic discussion circle, as we're trying to simulate here. So you're sitting in a circle, and what we're trying to do is, through this debriefing model, get an opportunity to match that against the learning outcomes, what the tutor was expecting the participants to do. But now David has also worked with me on some projects in the past, and he's a big advocate of using digital twins. So along with having a face-to-face human debriefing facilitator, you could also have a digital twin involved with that process as well. So here's an example, if this is going to work, David, because I wanted to play this. Here we go. Oh, we're not getting sound though. Oh, that's all right. Of a workshop that we did at Bournemouth University, where we have this Socratic discussion circle with some presenters that were in the room face to face, but did their presentations as digital twins. So in the first part, they watched on the screen the digital twin presenting their positions about the use of artificial intelligence. And then David's there in the background on the screen, and I'm over there with our partner from Claxon, which is a collaborative platform I'll show you at the end that we can do some mind mapping with. Okay, so now we get to the last stage, the evaluation. Here, we started with some learning outcomes, and now we need to map the transcript from that recording of the event to see whether or not these learning outcomes are achieved. So the AI agent can be used along with this in order to search out keywords and map that over to what the keywords are in the learning outcomes. Following that, we also want to match that over to the quiz results that we had. So what we're trying to do is what is referred to as an IKSAD assessment model, rather than a criterion-based, which you've all experienced in the past, where you have to do a written exam. Here, what we're doing is we're matching the starting knowledge to the knowledge that is resulted after the simulation. And then we'll also collect quantitative and qualitative data through surveys and interviews, where we can identify the levels of confidence that the people have changed in going through the simulation as well. Now, does everybody have your device ready? I hope this is going to work, David, without having. Oh, and by the way, this model we're putting forward to Birrell, the British Education Research Association, for a grant as well. All right, so you should all be in position now. What we're going to do is this interactive game, which is going to illustrate now this IKSAD assessment approach. All right, this pre and post. Yep, that's it. Okay, so in a moment, I'm going to ask you on your screen to press the left and right button, which is one finger, which is then going to go into this sprint, this 100-meter dash, and the faster you do it, the faster the runner goes. All right, are you ready?
So it's continuous. You want us to go beep, beep,
Yeah,
beep,
yeah, exactly.
And it's on the touch screen, not.
It's if you're you can use keyboard. That's why I use the arrows. If you're on a keyboard, you can do left and right arrow, but only one finger for the first test. And then if you're on a phone or a touch device, you can use the.
Do I know which number I am?
You're number 5.
Okay.
No, excuse me, number 4 in this one. Number 4.
Oh, I see. I've got the color.
Yep. Okay, so let me see if let's hope that this is working. Don't press yet. Wait. I don't know if you're going to be able to hear. We'll see if you can hear. Okay, ready? Wait. Set. Go. Okay. All right. Come on. Press it, people. Come on. Faster. You're not doing very well. Come on. The faster you press it. Left, right. One finger. Keep going. Oh, this is the worst group, I think, David, that I've ever worked with this. Oh.
Mine's moved.
Yeah.
All right.
I might have.
Oh no. Okay. All right. Okay.
Yeah, same
Well,
here.
Did yours do that?
Yeah, it went, yeah. Yeah.
it moved that. All right.
Yeah.
Okay. It still was working though. The data was still going in.
Which
All right. So
which runner was I?
number 5. Oh, you were all the same.
You went
You're all the same. Number 4, which came in 5th place with 15.404 seconds.
For
All
100
right.
meters.
For the 100 meter. Yeah, it's
That's
pretty
my
pathetic, guys.
So that's your individual? That's a collective figure.
That's as each of you press, the data went in.
I will say to you, a team is only as good as its weakest link.
But don't worry. We're going to give you another chance. You got another chance now, but this time we're changing the intervention, and instead of one finger on each, now you can use 2 fingers. All right. So we'll see if that makes a difference. All right. So this is race number 2. Are you ready?
Yeah.
Wait, now don't start pressing until
I'm doing
they
already.
say go.
Stop
All right, no.
How many disqualifications?
Don't do that. Here we go. Ready? Go. Pressing now. Both fingers. You're going better for a moment. Keep going. Oh, looks like you're going really fast.
Why
Oh, come on.
Oh.
No.
All right.
I won.
That's
Okay. So you improved, but give yourself a hand. Nice job. This time, by going 2 fingers at a time, you managed to come in 1st place with 13.78 seconds. All right. So this is illustrating now this IKSAD assessment model that I'm talking about. How is it doing that? Well, Well, if we are looking at an external assessment criteria, then we might be saying, all right, well, how does your time, okay, compare against another measurement? All right, so for example, Usain Bolt's 9.58 for 2009 is the world record. So we could compare your result against his world record. Another external might just be to say the Olympic record. Okay, how did we compare against the Olympic record? All right, or in this case, on this particular track, we have a course record by Joe Bloggs in 2024 where he did 9.9 seconds. All right, so this gives us a chance to take a look at your performance, your knowledge, your skills, your capability in performing in that simulation compared to an external criteria. However, if we're looking at a simulation for the healthcare worker, it might be that what you're doing is you want to do a personal best. So if any of you, for example, do park run, I know David is into his fitness. Does anyone do park run here?
I used to be.
Okay, a couple of people doing park run. You know, there, the object isn't to necessarily be first, but to beat your personal best, your personal record, your PB, or survive, yeah, or finish. So in this case, then what you're doing is you're measuring against yourself. Or we could be looking at it and saying, how are you in relationship to that group, that particular cohort, which means then that, well, we went from 5th place to 1st place. So you have an improvement in that situation as well. So our conclusion would be that our intervention, the change that we've made by going from 1 finger pecking on the simulation to doing 2 was an improvement. So you've improved in your performance. Please do go to my website and have a look at some of the other research that I've been doing in terms of webinar design and simulation learning. There is on a little bit further down a survey that I'd ask you to contribute to. And as I mentioned in that other video, a company that I'm working with is called Klaxon. And they've got a fantastic collaborative environment where I've put together a mind mapping exercise. So you can go in and take a look at that and do that as a kind of reflective activity. So after thinking about this madness that I've exposed you to, you can throw in some little tags and add to create a collaborative mind map. And I think that's it for me. I think I'm in my 15 minutes. Thank you very much.
Very good. Thank you. Thank you.
Oh, sure. It's on the paper.
Oh, is it the same one?
Yeah.
Oh, okay.
Can I ask a question?
I guess.
Please.
I'm involved with lots of universities. I'm currently mentoring one of David's cohorts, which is very exciting. But there are other people in the room who are equally involved in education. One of the problems that I personally want to address is a way of capturing a reflective process, either how I've perceived the student responding, or from a personal point of view, how they perceive of my mentoring. And I want to be able to automate that because I can't deal with every student. And I'm just wondering whether or not there's this, because being dyslexic, I can see there's I can see how it could happen, but I'm not quite sure whether it's the right process or it's something that you think that has legs or could be deployed in a university environment where a student could potentially, without the involvement of a lecturer or a mentor, get feedback on their performance and maybe the course as a.
No, I think that's a very important question. And I think my criticism about my experience in working in several different London universities, as well as working now in Bournemouth University, and I'm also working part-time at Solent University in Southampton, is that assessment tends. Oh, sure. So, yeah, of course. The problem is that assessment tends to be individual.
Yeah.
So what you're doing is you're doing a written report as an individual, or whatever the media is for that assessment.
I was going to use SurveyMonkey.
Yeah, okay, but I mean, you've got some learning outcomes. You need to have some kind of evidence in order for the UK learning assurance process to validate whatever mark or whatever grade you're giving. Okay, as I mentioned, as a criterion-based assessment. But the approach that I take is to shift that into peer review and group focus. So even though they're submitting maybe an individual document at the end, what I have them do is I have them work as a unit. So they're sharing whatever research they're doing as the cohort and contributing to, like, for example, like the bibliography of what it is that they're writing. And trying to get them to have at least one study partner. So what that means is that before they submit any draft work to me, they've already had that gone through with a study partner and other people within the group. So that's a shift in the assessment paradigm that I try to do.
That's not too dissimilar to the way I work at the moment, but you haven't quite, but maybe it's a conversation we have offline.
Okay.
Or separately, not bore everybody.
No, that's hard. I think we're a little bit behind schedule anyway, so
Yeah, so
I'm
what
happy to
we've
chat.
done before, when I worked with the Zambian government for their new university, is for the blended learning, is to get the students to actually use each other.
Absolutely.
So once a doctor, once a nurse, once a patient, once a relative. So they simulate that scenario and then we record it.
Yeah.
Because the idea of the blended learning is that when they are not in Lusaka, they are still learning. So we built the big simulation center in Lusaka. Then we had different ones. They had 10 provinces. I did 7 before COVID.
Okay.
I actually had to go there on secondment.
Yeah.
And then, so we found that worked. But the university in Lusaka had everything set up.
Yeah.
So that when they're outside of Lusaka, the simulation lab that we built for them, we equipped it with Wi-Fi and everything. They can actually transmit what they've learned and it's loaded, watch that, review that, either with a lecturer or a surgeon mentor, or with each other. And then they can put that in there.
My question is, who's generating that content?
It's their content.
So
they have a curriculum.
So the lecturer or the university is generating the content.
Yeah. So I put some of them together. The curriculum, I put it together for them.
Okay.
So they follow the simulation is at the back of the curriculum, but they do it themselves, like peer review, group review.
Yeah.
Video, they do the video. Sometimes they do audio, and then they upload it so everyone can have access to it. They can do more wherever they are at.
Okay.
And then that solve the problem of the gap when they're outside of the main city.
Okay.
It also improve retention.
Oh, absolutely. Yeah. It's interesting because I'm working with in Birmingham a video production company and they've got a grant to do training for healthcare professionals in Zambia.
Oh.
All right. And in talk, because they've hired me as an education consultant on it, and in talking to them, their model was pretty much what you were saying. But I would invite you to look for, in 2009, British Telecom did a project called Dare to Share. And for their employee training, rather than having the HR department set up the normal training, what they did is they said, employees, you make the videos. So the employees would make 3 to 5 minute videos of whatever specific problem that they had in the office, and then promote it themselves in the office. So it was a bottom-up approach.
Yes.
And that's what we're experimenting with now, is can we get the stakeholders in Zambia, the healthcare workers there, to tell us what the issues that they have are, so that we're working with them to generate the videos for the training.
Yeah.
It's a different approach.
This is really interesting because can I just have one more? There's one more. So basically, my wife is running Bristol Translates, which is a multi-linguistic forum workshop over a week. Something about 5,000 delegates, and it's in person and virtual. Are you saying that we could potentially automate that within this type of learning, and the students can develop their own problem solving around text or around issues around text? Well, it flips the whole paradigm. That's a bit of a game changer.
Absolutely. That's why David invited me.
Well, David's very sharp. Thank you, David, for that flexibility.
Okay, thank you. I'm sorry to move on quickly, but Nora, would you like to come and control the machine and introduce yourself?
Oh, yeah.
All right. So thank you so much for having me. My name's Professor Nora Colton. I'm a professor of leadership and management at UCL, and I'm the founder of the Global Business School for Health. And I set the school up in 2021, and we took our first class in 2022. We're now on our second cohort, and the school is growing at an exponential rate. So we had over 200,000 applicants for 4 postgraduate programs when we started. Last year we had about 3,400. We continued at about that rate this year, and we've grown the school. It's about 530 postgraduates now on a number of different programs. So what I want to do today is just talk to you a little bit about the school, but why a business school for health, and be a little provocative. So many of you may or may not know very much about UCL. Of course, it's rate very high, but more importantly for me, UCL has a history of being a disruptor. It's almost coming on to its 200th birthday, and in those 200 years, it has achieved numerous milestones, particularly around accessing very diverse students, focusing on real world problems, not just on theory, and of course theory is very important, but trying to really address many of the issues that we face today. And of course, aging is a very important part of that. UCL has an Institute for Aging. As many of you will know, just a few weeks ago, UCL had a breakthrough in Parkinson's diagnosis. So much of what UCL does is across the brain sciences is probably the most significant area. the medical sciences, population health sciences, and that's where the Global Business School for Health sits, and then of course life sciences. So it's within that tradition then that we set up the Global Business School for Health. The idea was that health and healthcare are often not really dealt with very well in business schools, and that we have been taking a health service approach for a long time in terms of how we manage and think about health, both public health and hospitals. And we need a different kind of lens. The health sector itself is changing significantly, as we know. And so the idea was to create a school that would offer a kind of an alternative approach to thinking about health and healthcare management and leadership, and really challenge that status quo that we've many of us probably been matriculated in. So the school is really focused on real world problems and challenges, and of course aging is one of those. And the idea is to bring people who already have a background, maybe they've studied science in a particular area. We have a lot of students who have pharma backgrounds, biotech backgrounds, other life science backgrounds, but we have numerous clinicians. But we also take business students. We take students with economics backgrounds and social science backgrounds. And the idea was to bring them together to focus not on disciplinary silos, but to focus on these wicked problems, these challenges that we hear a lot about today, to think about how to drive forward solutions. The other premise, and again, you may or may not agree, but bridging that public-private partnership divide. No criticism of public health, but public health in too many countries is almost like a luxury. So we spend a lot of time focusing on public health, but we don't have the finances to adequately fund public health. And so subsequently, you get a vast majority of the population searching and finding their health care in the private sector. And often in some countries, especially low-income countries, ironically, the public health sector will be regulated and the private sector will not be regulated. And so they're going into a very risky kind of place in which to sort out their health needs. So we put a lot of focus on public-private partnerships, and subsequently we've developed relationships around that. But more importantly is this idea of the new health economy, particularly driven since COVID. So you can imagine I was busy thinking about what this school would look like, the vision during COVID. And, the health sector, if we think about it, for about 100 years, we had a very stagnant sector. And the last 30 years, I would say we've had a declining sector. Not because we haven't had overwhelming demand. How do I know that a sector is declining? Well, when all the language is about cost savings and efficiencies, okay? So one thing that COVID has done is it helped to break us out of that cycle and move us back over into the beginning of a kind of a life cycle for an industry with startups and the funding in digital health and the acceleration of many things that were out there. Of course, disruption doesn't happen in a moment. It was there. It was just not being crystallized or actually used within our healthcare system. Having said that, though, we've seen some things go back. I have a colleague who's done a study looking at care homes in the United States, seeing which care homes, of course, during the COVID, during the pandemic, they all had to switch to telemedicine, and in many cases, we know that's very good for patients, putting them into vehicles, driving them to hospitals for various tests. So if we can leave them in one place and care for them. What she's found, though, is that those care homes that embraced it, they embedded it, They hired the technicians. They purchased adequate and appropriate equipment and sourced it correctly. They've continued to do that. The ones that did it much more as an emergency moment have gone back to the ways it were. So we have a lot of work to do, but there are many things, like I said, the use of data analytics. We got much better during COVID. Of course, we all could give ourselves a test at home and mail it off to various places. But we also saw some significant problems around supply chain, and then of course what we heard about earlier, the reprioritization of social determinants of health. So it was people who were older, particularly those who were more frail or had other comorbidities, and of course even young people who were not having adequate health care. So this new health system is not only about thinking about care delivery and vaccines and diagnostics, and of course finance and payments, and then of course wellness and platforms, but it's also about thinking about now who are the new stakeholders. And I think that's again where having a business school for health comes into play. So we can see so much, and I just in the brief time I've been here this afternoon, hearing some of the innovations, some of the research, but it takes leadership, it takes managers, it takes people who can have that vision to bring it into the system. And we see that we're not only aging is an incredibly important topic, because it's not just here in the England and Wales, it's worldwide. I have been to China a few times in the last several months, and I can assure you it's uppermost on the minds of Chinese, because they have had a one-child policy. So as their pyramid flips, they have a real crisis at hand. And so using medical devices and technology is going to be integral for them to address that problem. So what do we need then in our health systems to take care of all of us? We need access, okay, and again, it's appropriate levels of access. One of the biggest criticism, and I'll get on a little more, is around primary care. We talk a lot about needing primary care. Even in this country, we have numerous people who have chronic illness who still go to tertiary care facilities. They could probably be treated in a better primary care system. We have people who go to hospital in this country, and they spend way too much time in the hospital. We often talk about the emergency room, and again, it's teaching health systems thinking, right? And we talk about the fact, I think it was when Jeremy Hunt was the health minister, but they made the 4-hour rule. You could only have someone in the emergency room for 4 hours. The problem does not lie in the emergency room. It's the problem lies, it's systemic. Okay, so the person in the emergency room can't get you up into a bed. They can't get you up into a bed because the rate and the number of days that someone spends in a hospital in this country is 5 times what our European partners do. Why? Because there's no social care. They can't get them out of the bed. There's no one for them to go home to. There's no rehabilitation facilities for them to go to. So these are all system problems, and they're integral to what we do at the Global Business School for Health. So it's not just about access, it's about quality of care. And then, of course, the other thing we see, and we don't see just here, is the wait list. It's the timely care. And what do we, what do managers and leaders determine as being what I would call critical care or elective surgery? Well, if I need hip surgery or knee surgery, that's not elective, okay? But it's often deemed that way, and people wait way too long. And if you're older, that means that you become more frail, you lose body mass. So once you finally get that surgery, you're not able to recover that you should. And of course, if you're younger, you're often out of the labor force. And sometimes when you've been out of the labor force for a significant amount of time, you never get back in. And so then that really exacerbates those social determinants of health. So it's, again, it's all here in the system. And then, of course, we want care systems that don't create catastrophic financial burdens. So I'm not advocating a system like they have in the US that doesn't serve everyone. So the challenges are big. And then, we can see also here that we've got a big problem here when we talk about aging because we're too addicted to our hospitals, okay? And to do much of what I heard earlier, it requires a real mind shift, but it also requires finance, okay? It takes leaders and managers and politicians and policymakers who get it. And right now we do a lot of talk about it, but we're not quite there. And you can see here, we've got way too many of our elderly people going to hospital. We got them medication next, and look how small primary visits are and out of patients visits. So this is a problem because these individuals will often, and in an election, as we all know, they will vote for hospitals. And hospitals are very powerful. They're not just powerful in this country. And we're also exporting it to middle and low income countries, the same mold. But yet we need to be really moving into a different kind of health system because it's costing us a tremendous amount of money. And you can see here, we're spending, if you look, yellow is the proportion of the population and the purple is the proportion of spending. And we spend a lot on people at the end of their lives because they have not, we have not reached the point that we're extending the quality of life. We're just extending life, okay? And then we're exasperating it by not having our health system structured and placed as it should be. So we need to shift our health systems. It's not just in this country, it's globally. And we need different kind of thinking. We need, again, people need to be able to stay at home. They need to be able to use artificial intelligence. They need to have wearables, and the reality is we can't send everyone to care homes. So at some point, there's going to be a tipping point where some people will get to stay at home and they will have devices that will keep them better. And then we'll have some people who are just going to have to stay home because we cannot keep the model of care going that we have given the numbers. And it also gets to workforce. I hear people talk all the time, we need more doctors, we need more nurses. Actually, we need different pathways. We need ways in which we bring technology and use data more efficiently, as we've heard colleagues talk about today. So that is really the heart of the Global Business School for Health. We're an interdisciplinary department. We have people that reflect our students. So we have people who are social scientists, we have psychologists, we have data scientists, we have AI experts, we have a lot of people with business backgrounds, people like myself. And we use lots of different ways that we work with our students. So Anthony was talking about simulations. We use simulations. We use case studies. We do experiential learning where students get opportunities to travel to different parts of the world to see other health systems. So the focus is really on this new health economy. What do we need for the future, and how do we need to train the next generation? So we have a program on biotech and pharmaceutical management. We don't teach students any science. We teach them about the business and management of biotech and pharmaceutical management. We've got digital health and entrepreneurship, very much focused on startups and ideas. And all the students, I heard mentioning these projects. The idea is to build a entrepreneurial mindset into the students. So, because a lot of times health professionals have been matriculated into a culture of regulations, a culture of hierarchies, a culture where you're not encouraged to be innovative. You're actually discouraged to take risks. So getting these health professionals to think differently then takes a kind of bold curriculum. And all of this, just to tell you quickly, we designed the portfolio. We used AI. We looked at an algorithm that scanned all the job ads in various key countries. And then we could see what were the traits that employers were looking for, what were the roles that they were looking for, what were the things that looked innovative and change. And then we did a number of surveys with not just potential students, but also with employers. So we've really landed on 3 research areas. We have health systems and policy, and again, it has a real focus on primary healthcare and looking at things like urbanization, commercialization. Of course, climate change is also very important. And then this piece around public-private healthcare. Then we have health management and innovation. And we've recruited experts across the world. We're a very, very diverse group of individuals, both in terms of our disciplines and our backgrounds. So we have health management and innovation. Again, that's where we have the technology, the AI, the data-driven approaches, but again, really focusing on patients and private-public partnerships. And then last but not least, health finance and operations, where we have a team looking at different models of healthcare and analyzing the different drivers of health spending. So why do we believe then that business and health make good sense for upskilling professionals? And by the way, we do a lot of work, not just our degree students. We're moving quite rapidly into doing short courses, executive education, working with different countries and organizations, because we need those leaders. They've got the insights. They can look across, not just and think about their own country, but think about others, have that business acumen. At the end of the day, you know, I work on with an organization on a program that works with NHS leaders. Trusts don't get in trouble because of you know, being too ambitious. They get in trouble because they can't balance their books, their finances. Okay, and this is, you know, part of the reality. And so also bridging that gap between clinical and management, non-clinical, and getting that understanding. I meet sometimes clinicians, wonderful, great ideas. They have no idea how to put together a business plan, and they have no idea, you know, about the cost structure. Then I meet managers who are working in hospitals. They do not understand what is the day-to-day business. So we need to really bridge that gap as well. We need people in the health sector who have more like zigzag careers, I call them, where people can move from one thing to the other, so they stay in longer. We have a problem with particularly nurses, you know, retiring early. I meet nurses in all sorts of places outside of the healthcare system. Why? Because they felt that there was a glass ceiling. They couldn't get any further up. So giving them those transferable skills, giving them career paths, widening their ability, and then of course this problem solving and entrepreneurial skills. So just lastly, it's about really taking world-leading interdisciplinary academics and having them cover much wider areas of expertise, sometimes areas that they might not feel comfortable with, but they've got other experts that they can tap into to really create subject areas that are much more focused on the health system of tomorrow rather than the silos of today. Thank you.
Thank you very much, Nora. Do we have any questions for? Yes, Nathan.
Hi, Nathan Nagel. Tremendous presentation. Thank you for that. I work with healthcare leaders around the world. One of the regions, which is the Middle East, and we find the approach to leadership in different regions varies. So what works in the West does not necessarily work in the Middle East. How are you approaching that within the school in terms of doing the interdisciplinary element of culture and geography?
Yeah, so that's a really good question. And actually, I do a lot of work in the Middle East, and we're very engaged in the Middle East. I think I wouldn't over-egg the differences. I think some of them are more about history than actually good practice. And I think there's a real appetite in different parts of the world. So rather than, of course, I would say it's not so much, it's how health systems have evolved, and there is always, of course, a cultural context. I think to health systems. What is that culture? It gets back to our values. What do we value in the society? And that doesn't always run clear through all societies. And there are, if I go to China, for example, they put a real focus on efficiency. Why? They've got big numbers, right? So some of the kind of personalized care that we're used to, you don't get, okay? And that makes, in some ways, using AI and some of these other tools a little easier, privacy issues, data access. I think what I see in the Middle East is actually a real appetite for new shiny things. But I think on a management leader scale, I would say they're all, of course, it's very hierarchical, and there's this kind of younger generations coming up. They're very dynamic, but they can sometimes feel constrained by the other generation. So how do we address that? Well, we address it in two ways, and that is coming in and trying to upskill and work with middle managers in an organization. So we've had a big project in Saudi Arabia over the last year, working with the largest private healthcare group, really working with about 1/3 of their workforce. So coming in there, then we've got the upper group. Of course, they want the succession planning. They want the more moldable people. But we're also saying, well, let's bring in the other group, the people that have been here for a while. Let's do some thought leadership, some work with them as well. So I think there's where I see the big difference is actually around finance, how we finance our health systems. And again, it comes back to our values, right? Yeah. Some people ask me, can the United States have universal health service? I would say no. Why? Because you've got people who are being over-medicated. They pay a lot of money for their health care. Then you have people down here who have none. When you average that and what the taxpayer would have to pay to kind of keep everybody happy, it's too high. So I think, yeah, there's of course differences, and what we try to do also when we come into situations like that is work with the client, understand, what are the differences, what would they like, and then how can we help them shift and solve what they see as kind of leadership and management issues.
Thank you. I have some large hospital CEOs that would probably like to talk with you.
Oh, well, I would love that.
Hi, lovely. As a clinician and entrepreneur starting out, I think I just wanted to come into obviously your business model in starting the school, and how those nurses and people who are, I suppose, experts or wanting that zigzag career can afford, the input that you can bring them, because obviously the nurses do not come from a good salary, really.
Yeah, so if they're UK nurses, they get home fee rates that are actually quite reasonable. We also have added an apprenticeship. So we have a senior leader apprenticeship that actually pays pretty much a big chunk, 2/3 of your MBA. So they can go on and pay that up. And actually, we also offer a lot of scholarships, and we're working with different organizations to get more scholarships. So yes, that's a good challenge, but it's something I'm quite active at trying to address and build those and that's why working with industries, being much more agnostic, but saying, look, we're going to work with the health sector, that whole health ecosystem allows us to tap into different funds of money to help support our students.
Two things. It's comment actually, because a lot of what we do at Zenith Global Health is based on my 30-year experience in the NHS. And when we go to Africa, the aim is to bridge the global non-global south divide. And I'm so excited with this presentation because in the last 5 years, we've been talking about changing the mindset about how health is delivered. As you rightly said, public is regulated, private is not. Private is overshadowing everything. So that we are addressing healthcare financing, public-private partnership, and most recently, when I've been to Geneva and then Cairo, what came out from the invitation, the roundtable that I was invited to, is how we can then train the workforce. We do upskilling as well in healthcare financing, because we had a summit in Ghana, and healthcare financing, EMA was, top of it, which was why we were invited. So my question is, when the students graduate, what do they then do? Where do they go?
So, yeah, well, so that's a big question because we're just graduated our first class.
Oh, okay.
Okay, but we see them going in lots of areas, mainly into course management type areas. So, but I just also back to this. So we do a lot of also short courses, and healthcare finance, of course, is an area that lots of people are interested in or want to know more. And I just want to say, I'm not, I don't think we need everyone to go off and get degrees. And you might find that surprising because I'm coming from a university where I'm pushing degrees. I believe very much in, and this is where I put most of my energy in right now, is not in the degrees are fine and they'll recruit. It's in accessing this healthcare, workers, because why? We have a whole generation or two generations of middle managers and senior leaders, and I've seen them in boardrooms. They don't understand a lot of this. They don't understand AI. They don't understand data analytics. And you get two groups. One group that just says yes to everything, doesn't know what they've agreed to, and then the other group that just blocks it all. So I think there's a real piece for us to be doing is just around bite-sized learning. It doesn't, and the other thing, so again, my experience is people are happy to just have a certificate. They don't need a degree. And so if you can put together something that's and the other thing, back even to nurses, they're working so hard. If I go, and this is why we did the apprenticeship, and we also have an executive online, because the first year we launched this in-person MBA, I was expecting more people from the NHS, and then I went to speak to some of the CEOs. I said, Nora, it's not even the price. We cannot have people out of clinic. Yeah. We cannot, and we don't even want to give them a study day.
Yeah.
So there's really, attention here, right? We got these scientists and they're in the universities and they're coming up with these great ideas, and we've got these startups, and I go to the startups and they just go, we can't penetrate the NHS.
I think that's why we have had, because I'm a neuro rehab provider which crosses the NHS and the independent and technology divide, and a lot of the startups are coming through our Mynd program, and we're inundated with people wanting to access the clinicians and the patients through the network, and it's actually got too big to manage almost, but so we're employing more staff to help manage it. But again, that's UK grant funded, a lot of them.
Yeah, but there really is this disconnect, and somehow we've got to be able to. So that's why with our students, really kind of working with them, trying to get them into roles to help be that next generation. But that takes time.
Yeah, it does.
No, you stay there.
I have worked with Rosemary Lushing of EdTech UCL, brilliant, and Becky Sage, Educate. Sadly, I wanted to build on my experience of lifelong learning and work with seniors in educating them to understand the issues relating to caring for a spouse or a partner, etc. Because unless you have that education, certainly with dementia, it's really hard to engage because they don't understand the illness. So therefore, they can aggravate the condition rather than support it, unless they know how. So there's a big divide in, and I said this earlier about the education of doctors with primary care. Because unless you get that education, unless you address those issues, and we've got a program called WISH, which I'd love to talk to you about. Sorry about the pun, but basically it's exactly that. It's educating doctors to understand what AI is, where they're changing, what they can do about it, and how they can adopt it and implement it within their day-to-day work practice. That's one area. The other area, which I think is really interesting, which this lady basically said, is what do you do with all these wonderful, amazing postgrads? And I think that we have a model. David's very kindly invited me to work with you and some of your students. That we have a model where I would go as far as to say, but I'm not going to expand it any more than try before you buy, literally. So they get the experience of working with commercial companies, industrial companies, etc. They get that feedback, which is something that we spoke about earlier, and therefore there is a quality circle, to use an old phrase, that supports the student in moving forward and getting that experience and exposing them to potential employers as part of that work program that they are undertaking as, at the moment, extracurricular activity. But I think it should be endemic within the overall academic process. Trying to get that is another matter, not to mention trying to talk to different departments within the universities, which are very siloed orientated currently.
Yeah, well, and that gets back to,
love to talk to you.
Yeah, the idea of creating an interdisciplinary department, because we are too siloed. And actually, you mentioned postdocs. You know, not sure if I should say this, but one of the reasons I created biotech and pharmaceutical management is I was working in a research institute, and it was painful because there was an army of postdocs, some of them getting, you know, midlife and not able to get a permanent academic job, not able to go out and translate what they were doing to go into the private sector because they didn't understand that space as well. And then sadly, they've been indoctrinated to think that that was failure. And so I thought, gosh, we need a program where they could come on and get some of these business skills and do some of this so that they could translate out because, yeah, I mean, you think about it, we never talk about this. We have people, you know, who are going from research grant to the other. And I remember one of these individuals saying to me, I've never been able to get a mortgage because I never have a secure salary more than 1-2 years at a time.
It happened to me with Nottingham, with a professor of sound engineer who was absolutely brilliant. But he went into he was made redundant by the university, or wasn't linked in with the university anymore, wasn't able to support us because he wasn't linked with the university. But equally, even though he was brilliant, didn't know how to put together a business plan to develop what he was doing, and it was just sad. It was I couldn't develop that.
And one of the important things is identifying the clinical need from the end user's perspective before you start going on this journey.
Well, that's another. That's
a product that is.
That's value proposition stuff. That you don't even go anywhere near the business paper where you define that.
But actually, that is what happens in a lot of the academic research grants. The academics and they're developing things. They haven't spoken to a clinician. People come to the market with products and they've never seen a stroke patient, and their product is designed.
Oh yeah. Well, yeah.
And we're on the receiving end of that from the bottom up, and it's really fascinating because then we actually say, well, why don't you change it, do it like this, this, and this, and then it'd be useful.
Well, there are design methodologies that address that called Double Diamond, which the British Council, Design Council, have implemented, and should be part and parcel of any business structure.
I think that one of the problems is like the research groups that drive that early research, they don't look at that double diamond process
No, they don't.
or theory of change.
No, because they're not business oriented.
Yeah, but they kind of run like little companies. And so my research group that I did my PhD at, it was run like a little company. The professor had absolutely no around this, and he was quite good at bringing money in. But it would, it was all these applications, and you're like, really? Like, he would just kind of add stuff on to continue this stuff that our lab was doing.
And sorry.
That's heading. I mean, I would that actually, in the framework where I'm trying to get my niche accepted, is that there is data, but nobody knows it, and the blinker's been on, and you've got a problem, you have the solution, but nobody's enabled, you know, to accept or find a solution.
Data entrepreneurship.
You know, and it's enormously frustrating as somebody who's worked within the system, being able to see how there could be a solution. We need to obviously have, you know, it's like the light bulbs don't work without the wires.
But you need to step outside of
Yes.
of the NHS to be able to
and indeed
empower,
what
and
they
that's
have
where the private
had
and
to do.
device. But also, we're so far behind in the UK compared to the
We
rest of Europe and America,
Oh.
particularly in rehabilitation. It's shocking.
And the other thing is culture. You mentioned culture as part of the learning exercise, not to mention the entrepreneurialism associated with around culture. And I've travelled extensively in China and some degree India, and I was at the Global Indian Forum talking on education as well. And this is a real serious problem because there's so much innovation, and yet there's such a barrier in understanding how their jobs are going to change and what they need to do to basically start engaging with this stuff, even from a personal behavioural point of view. And they're just not there. And we're not going to get anywhere unless they have that adoption. And I'll shut up, David. And I didn't even see you.
I think I'm going to about 3 or 4 times.
Yeah.
So maybe
I'm sure this discussion can go on quite a while, but we're running about half an hour late. Yeah, so if you could catch up offline, Mary, it's your turn.
All right.
To present. Do you have a presentation?
I
or-
do. I thought it's a prompt actually, not full presentation, just like
Old school, great.
Yeah. Yeah.
Oh, so you're just going to talk, are you? Oh, have you? Oh, okay. Oh. Wait a minute. Let me see if I've got it first before I do anything.
My son's actually my son is perhaps start that in September. Yeah. He's doing the biomed, tech and pharma.
Yeah, I actually weirdly I'm an article.
Have you got a memory stick?
Well, maybe not today, but to share.
Did you hit the time?
Well, certainly, if you like.
No, I because I'm I think I'm follow like it's got a bit taboo, but using things like psychedelics and sticks in mind to make kind of breakthroughs and select behavior change, and like the research is unbelievably positive. How did you?
I'm connecting with her too. I mean, yeah.
It's very, it's a similar kind of. It is obviously it's differences, but it's about getting into a state of acceptability and able to make change. Otherwise, you can't really.
I don't think we need to make essential.
Yeah. Might help that. I think you maybe do rebranding. So you're like you kind of need to like you need to be tethered somewhat in that. But like I need to be like clinically sounding.
Sorry. Yeah, sorry. Can I just interrupt you a second?
Giving that.
I'm just going to sort out Mary's presentation. If you bear with me a minute,
whatever to get people.
Okay, like I said, it's a couple of slides, just like prompt to remind me of what I have to say. So my name is Mary Akongbe. I'm a nurse specialist practitioner in minimally invasive surgery and robotics. and I've been in the NHS for 31 years. So I started in keyhole surgery, minimally invasive surgery, when only consultants can look through the lens. Then we had the 1 chip, 3 chip, then we had the integrated theaters, and then we move on to different kinds of robots, from camera holders to full, the Da Vinci. Now we have Google, we have, different kinds. So I've been through all of that, and I've had the privilege to work in the Center of Excellence down the road in Camberwell, and be part of organizing master classes, teaching training, which gave me the insight into the fact that we all do amazing things globally, but in silo. So what can we do to bring everything together? Especially because in our teaching and training, people come from all over the world. We do different modules, and then sometimes we go out to support them when they've been with us to learn, and we organize different symposium and upskilling as well. So I established Zenith Global Health. Before then, I've been part of Transforming Health in Africa. It's been 15 years now, and I work with industry to establish centers of excellence across Africa for teaching, training, or if they have new products, equipment. It gave me also insight into procurement chain in other parts of the world. Who's in charge, who's not in charge, how things don't match, how they are not fit for purpose, and how some of the things that are meant for good actually turns the places to dumping ground. So it equipped me as well when people now come to me to say, we have this device or innovative way of working, we want to go to this particular part of the world. I have, I'm equipped with the right questions to ask. So we work with, I think I'm going to start from the back. So the purpose is to bridge the global south, global north divide, and to bring healthcare professionals together from both sides, so that when we are coming from UK, US to Africa, for instance, or other LMIC, we know what they need. It's not like this is what you need. And then to educate and support so that they can identify what is relevant as well. So talking about age, actually my first slide said our youth, our future. And you might be wondering that we are talking about age, I'm talking about the youth. It's because for a long time, we focused on the youth, and rightly so, because all the legacy, everything that we're doing, we are hoping that one day, at some point in time, they'll step in. But the other side to that is that the youth these days, they play with AI and the metaverse. And the generational gap tells me that what we are developing right now, if we do not educate, if we do not change the mindset, if we do not invest, then it will not be useful for the population that we are targeting through education and awareness. Also,
Just use your own.
Okay, yeah. So I was talking about the AI, the edge technology, and the metaverse, and I'll come to the ethical implication at some point, and it's being fit for purpose. Now, the generational gap, culture. We've spoken about culture a few times today. Once upon a time in Africa, it's a sign of affluence to be obese. If you're obese, if you have some kind of shape, then it means you have lots of money, you have servants, you have drivers, people can do literally everything for you and you don't have to do it. But now things are changing. But what we need to do as well is to change the mindset. What do we do with the aging population? How do we support them? I've talked about education. Not just, a lot of people in LMS are educated to whatever level, surprisingly. But now that we are moving into AI and tech, what do we need to do to get them to that level? So that all the products, all the data interpretation, data is another thing. Data is not very good. There's improvement, but we could do more. And like I said, Wednesday was presenting, is a big challenge to innovation. Because if your data is not robust, if it's not fit for purpose, if it does not reflect what problem you want it to solve, then we are not talking about health equity, period. Then about mindset again is about home care and care home. Typically, in an African home, you wouldn't take your father or mother to a care home. You'll be seen as a prodigal child. In fact, they'll call you different names that you may not be able to sleep at night. So again, what does that mean? That means it's a financial burden on the children. Psychologically, if you're a woman, it's a problem in your marriage. So what is affecting this population is actually affecting the whole system, the whole family setup, and it could cause disruption. It could cause mental health problem, which we don't do very well with either, And the other side is that older people, let me take dementia and Alzheimer's disease, for instance. Some years ago, they are seen as being witches or bewitched. So again, there comes education and mindset. But now, thankfully, we now have care homes actually in some parts, and we have people actually actively promoting looking after the older people and setting up programs for them. Because otherwise, instead of, for instance, if you have a parent that have dementia or Alzheimer's, you lock them up. You don't want people to know because it's a taboo. So now, how do you care for them? You love them, but how do you care for them? So again, that takes me to why, if we are devising anything, we need to have culture in mind. We have to change people's mindset. Thankfully, like I said, it's changing. But 20, 25 years ago, I use the word changing because, it's gradually changing. It's not embraced, everywhere. So when we talk about care home, we have to talk about access as well. How do these people access the care home? How do we make, this morning I saw some amazing technology and I sat there and I'm thinking, these things, they are replicable. You can actually use them. Although we have to think about finance, which will come to healthcare financing later, but there are some simple things that could be done, like the program that you have with Neumind, like the data collection that you're doing, and even the VR. Because one of the things I work with is skills and simulation. And after COVID, when I came back, we devised a 360-degree camera recording so that medical students and nursing students, they can have an idea what goes on in theater, who does what, the process, what's expected of them before their clinical training. So I know that the VR process is not that expensive, but how do we get them to use it? Now, so that's about tech literacy. The economic impact of aging. It's a public health burden at the moment. For some of the reasons that I've mentioned, there's the issue of access and availability. Access to medication, access to healthcare professionals. We know all about brain drain. You can go to even some secondary hospitals, and you find maybe you're supposed to have like 50 doctors. You'll be lucky if you find 15. 100 nurses, you'll be lucky if you have 30. And these people, right, they still have to cater for the same number of patients that they used to cater for. Now let's couple that with somebody who is frail. So they are looking after patients who are able, maybe they walked in or they were brought in. Now we're looking at patients with non-communicable diseases, usually presenting at the later stage for various reasons, which we don't even have time to go into. It's a public health body. How do we address that? Again, I go back to mindset. From before we get to that stage, it's important to educate people on the implications of self-care, wellness. I spoke about obesity. And, Africa, for instance, we are so blessed when it comes to agricultural produce. What is missing is the education on how to use the produce to prevent diseases. And then it goes back to the same situation where part of what we can do in public health is to invest in these grassroots solutions before we come to the burden of disease. Now, I talk about fit for purpose solution. For instance, a lot of the innovative procedures, the wearables, the VR, and AI generated treatment, we need to look at something. Which group of people are we targeting? Because most of these old people, they are not in the city. If they're in the city, they've come to live with their children. They're not in the city. So, and they need it the most. Especially when we talk about telemedicine, we have lots of people who are start up telemedicine, health tech startup in our network is Zenith Global Health. And some people, from outside who wants to go to Africa as well. And some of the questions that I ask them is the geographical location. How do we take these things to them? How do they power them when there's no electricity? How does it work when there's no water? So before you were talking about looking at the problem before devising the solution, it's very important to make sure that whatever we produce or we make is fit for purpose. Sustainability as well is something that we focus on that, globally we don't do it very well, but we do it better in some parts than the other. Whatever product or whatever solution has to be sustainable. Because, and then I was saying this to them at the World Health Assembly meeting, that when we gather in a room like this, we all know what to do, how to do it, when to do it. But the people that we want to do it for, how much knowledge do they have? What is their perception? And what can we do to make sure that we now use the bottom-up approach to solve some of these public health issues? Because if we break it down, get it to them, get them to, get to address the root cause problems, then, the solution will be easier, it will be sustainable, it will be accessible and affordable. Very important. So we do workforce development and upskilling. I'm very hot on upskilling because I'm standing here right now because I had that opportunity. It wasn't handed to me on a plate, like Prof said. My last year in university, I'm a product of UCL actually for my, and in my last year, I had to use my days off and annual leave to finish my specialist course because I was determined. I was told something like, what do you want a qualification that your manager doesn't want? I mean, I'm older now, but in those days, I just answered back without thinking and got myself into real trouble. So I'm passionate about upskilling, and we do this across Africa. We encourage leaders, we work with policy leaders, we encourage them to upskill because if I didn't have the opportunity to first go back, train, to retrain, and then to train as a specialist nurse, and then to train as, in the robotic and minimally invasive surgery, I wouldn't have the insight to support some of my colleagues who I'm so happy when I see them now in different areas, how they are progressing, or to actually step out and say, you know what, we can do this outside. If he works here, he can work in other parts of the world as well. And we have partners in UAE as well. We have partners in different parts that we work with. It's important not only to have the number, but to upscale. Who's got what knowledge that we can transfer? Who's got what knowledge that, we can use in other areas? So again, we are hot on partnership and collaboration. I said that before. We work with community organizations because like Africa CDC, for instance, when we had a meeting with them, they told us something interesting. They said during COVID, they were looking for community organizations to sensitize the people, or to make them aware of the risk, the level of risk they are exposed to if they do not take the right steps to avoid the transmission of infection, and again for the vaccination. Right now, we are struggling with HPV the vaccination because the media usually is more powerful than the clinicians. And I was so upset because the one that is causing problem right now is, how do I put this? It's not really an elite media platform. It's like a platform where people go and say, oh, he pushed me, she pushed me, and you understand what I'm trying to say? And they made this broadcast, and the whole nation, all the parents refused to give their children HPV. So now the race is on. All the government is coming out, clinicians are coming out, the oncologists are coming out, CSOs are coming out, to say, look, it's good. And then sensitizing some who's had it to say, look, my children's had it, it's okay, and things like that. That's why we tend to work with CSOs as well, to support them, to help them to know how to relate with these people. Because sometimes the population, they embrace the information from the people closest to them than from others who are coming in. So we work with them, empower them, and again, what we are trying to do is to get them into high-level discussions as well, because they know what they feel, they know what goes on, they know the problem. But sometimes, and that is where upskilling comes in. It's not because they don't know what to say, but they are thinking, oh my God, I'm going to this big meeting. The commissioner is there. This one is there. What am I going to say? So we support them as well. Say, look, you can go there, you can observe in the first round, take your notes, come back, make your contributions. And we work with policymakers as well to say, look, you have to empower these people. You have to make them feel as part, of it. And now there's goodwill, political goodwill, to embrace health. Up until now, health has not been a priority. It's not really up there where it should be, but now there's political goodwill. COVID did that one good thing, where everybody is now improving their, focusing on the SDGs and improving the budget to focus on health. We support institutions as well, especially with industry, like the Johnson & Johnson National Skills Surgical Center in Nairobi. I helped them with that. We started on top of a supermarket. It's a very interesting story for me. We started on top of a supermarket. Then the University of Nairobi gave them the space. Now they've got lands. Now doctors go there as well. So they do teaching, training, and then we do management, we do nurse training. And the good thing is, which is what we do at Zenith as well, when we go to any part of Africa, I'll come to that by the time I finish. The good thing is, like in Kenya, people can come from neighboring countries and access those courses and then go back and also give back. The other thing I love doing is creating champions. So if I go anywhere, I'll say to them, give me 3 people who, we embrace this and they can have access to us, either doctors or therapists or whatever, so that even when we are left, because you cannot go to a place like a week or 2 and then, make it all happen. I'm part of the West African College of Surgeons, and when we go, sometimes in a week, we do like 300 surgical procedures. But it's up to the people there, the doctors, the nurses, to look after them because we can only take X number of time away. So we work in institutions to establish centers of excellence like that. Public-private partnership. Universal health coverage is on everybody's lips. We have to do this by 2030 and do this by 2050. But it's apparent from all we are saying today, from what we are all seeing, from all our experiences, that governments cannot do it alone. It's a global problem, but much more so in LMIC. In Africa, where the government, policymakers, don't want to see healthcare as a failure, though it has failed. They know me, they'll say, if you don't want to hear the truth, don't go to her. It has failed. It has failed, but they don't want to see it as a failure. So they always say, we built 400 health centers, You go there, you find equipment and everything, but sometimes there was time we went to a certain place. The hospital has an helipad. The water was dripping to wash our hands. And then in the clinic, somebody called me and said, we are having problems with this. I went there, beautiful instruments, horoscopes linked to the screen that could cut the clinic time into like half. And they haven't used them because it was bought packed, no training, nothing. So I said, do you have electric kettle? They said yes. So I just put the 3-pin behind the screen, plug in the socket, and then we have our, horoscope. So we need that partnership, for when things are bought, to have enough fund to say, look, we don't want you to just buy this. We want the training. We want the post-purchase services. We want, everything to be in place, again, to foster sustainability, to ensure the accessibility, and also to look after our aging population. Because if all of these things are not in place, then, the statistics are grim at the moment, but we are hoping, because things are improving, that it will be better. Now, I want to close on a lighter note. And I say lighter note because, from my experience as well, I asked Stephen again a very difficult question about the diversity of their data. I was involved in the 100 kilo genomics in environment where I can confidently say 60% of the residents are Black ethnic minority. And before COVID, we had a healthy number. And I can count on my fingertips how many people came forward from the Black ethnic minority group. So I know it's a real problem. But I want to appeal to everyone here who's got one innovation or the other to make sure that there's no racial bias, especially now in AI. The ethical implication is really, really, really important. A colleague of mine recently went to the Femtech summit, and she was trying a wearable. She's a doctor. She's a female something. She has her own startup as well. She was trying out a wearable, and the wearable couldn't detect her blood pressure because of her skin color. Yeah. I mean, when things like that happen, it drives it home. And at a seminar for that matter, with lots of people and everything. So everybody, well, they put it on it's on LinkedIn. I can tell you where it is. Yeah. She phoned me and she said, oh, what is it? What happened? I said, look, we'll get there. We're not going to stop. We'll get there, And I think Health Innovation Kent, they have some processes in place to mitigate things like that. So I'm appealing to each and every one to tell somebody that it's important that we do what we can. I see Steve said it's in the US for that purpose, to make sure the data is diverse, and to do what we can to make sure that we address these issues. Thank you very much.
Actually over time now, and Nathan still has to present.
I'll do a quick version. I'll do the summary one.
Come up. I can load your slides, and you can do it very quickly. So
It's only 50 slides, people. I mean,
is that all? Okay.
Can't go without your slides. Font 8.
I know.
So what's your
So I'm the president.
It's loading very slowly.
For
some reason. There we are. Oh, yeah, is that right? Yeah, there we are. Off you go. Where are you based?
Okay, I'll do that.
I'll make it full screen. No. You use the arrow keys to go backwards and forwards. So.
That's a picture of my family. So really starting out with culture. So we're talking about the challenges of the aging population around the world. Well, one of the challenges kind of the culture dictates, because then in America, for example, you may be able to guess which one is American and which one is Italian. Yeah, is that the culture dictates the need, because then the unhealthier the population, the greater the need. And then also what is required, what values is going to be driving it. So the need is very closely tied to what we believe, our values, our food. So when we're looking at addressing the aging population, it really varies. And then also the culture drives the health versus the lifespan. So in a wealthy country, if you're unhealthy and we can keep you alive, doesn't necessarily mean there's any quality whatsoever. The heart's going, the brain function's going, but there's no mobility. And as long as that insurance keeps billing, keep them pumping. So what is the value of an elderly person? Because then if we're looking at how to address the aging population, the value comes into it. So there's two diametrically opposed cultures. Of one is the West and one is the East. So I think it was around the 18th century, the Protestants, particularly the Calvinists, started to say, hey, I tell you what, you go be a little bit more secular and go direct some business, put some money back into the church. Well, that started to really drive to go, oh, we quite like this money, and we like the money, and then it was your value of a person is very much tied to what you can earn. So then we've developed this culture, particularly in the West, of, well, if you're not earning, you're not valuable. And if you don't seem to be valuable, then you generally get poor care, which is diametrically opposed to the East. Yes, looking at China, where there is a difficult problem now, and particularly the geography, because field piety is a lot looking after your elderly relatives and family. But if the people have moved to the city for the work, it's very difficult to look after your elderly parents. If they've moved, you may have the desire there, and people may want to do and have the value system, but if they've left the country to go to the city to work, it's difficult. But still, the value system is kind of the value of an elderly person in the East is looking at the wisdom, looking at the reverence, looking at what we can learn from them. Whereas, unfortunately, in the culture in the UK and US, it's really not. When I was younger, I worked in the care homes just to kind of like while I was studying and everything. I worked in brain injury units, just did loads of different work while I was studying. And I just talked to everyone, apart from learning loads of different things, because I'm high functioning autism, so I've got no filter whatsoever, right? So I used to ask them to say, what do you regret? What did you do best? What did you do this? And apart from a myriad of different sexual things that everyone went, why did I not do that, right? And they used to say, I wish I'd have told someone to shoot me rather than take me here. The UK seems to be an appalling system to go into a care home. The US, well, it can be amazingly good if you've got money. Yeah. And it can be amazingly bad if you don't have money. And right now we're in a situation where again, the state pension or kind of like veterans and things like that, which was fixed, now is lower than the average rent. So we've got a situation where the fastest growing demographic of homeless people are over 50s. Simply because the payment going in, right, has not changed because it was fixed to what's going out. They just can't. Everything's just been swallowed up. And then once you fell through the cracks, you fell through the cracks. So it's really the best country and the worst country in many regards. And of course, Medicaid, you know, like the vast majority is through insurance. So I've used Italy as an example, but it's kind of the Mediterranean. We have a great reverence for the family, not as much as the Confucius in terms of like the East, but more of a family feel. And in Italy, only up to 5% are in care homes, the rest are at home. It's just been a long-standing. But one of the reasons I believe that is allowed, that works, is because in Italy, the elderly are functional, they're moving, they've had a culture of walking, they've had a culture of eating well. It's okay, or it's less of a burden if someone's actually useful and helping, you know, whereas if someone's literally just sat down and doing nothing because they're so overweight and can't do anything, or they're chronically ill, that is a burden. You know, but you've got very functional, fit, healthy, cooking elderly, so it becomes more of a multi-generational family. That is a kangaroo.
Intelligent.
Yeah. So in Belgium they've got a kangaroo care. So for immigrants, what the government are doing is saying, look, we'll sort out accommodation, we'll sort out things, but you've got to live on the top floor, and what we'll do is we'll house the elderly in the bottom floor. And it's just, you know, it's not the perfect system, but that's why there's a kangaroo there. It's a kangaroo care, and it's one way of addressing it to say, okay, you need help, they need help, why don't we help each other? And it makes sense for the elderly not to be on the top floor. Germany are taking different approaches. So Germany is, as a region, takes the greatest number of refugees in. So what they're doing now is saying, okay, you want to be a refugee, you want money, you want this, you want that. Well, you don't want to be a refugee, but you know, you want to work in the system. So what we'll do is you can train as a care assistant. And so then we'll, you know, there's contingencies and we'll do things. They're also doing shared apartments. So where the elderly kind of live together to say, look, we want our economy running, but what we'll do is if you can't see very well, you can't hear very well, and you can't walk very well, we'll put three of you together. Yeah. And that way something gets done. Then also in terms of building properties, and there's multi-generational homes as well. So Germany is taking a multifaceted approach, you know, of it all. So Japan, we're all driving towards longevity. We're all driving towards like this greater healthiness, but like Japan has been there for a long time, and it doesn't look actually so great. You know, really, to go, okay, then it's like we're striving to be super well, we're striving to be super healthy. Well, they've got there, and you've got 9.7% roughly, because all these figures are rough, that are over 80. So you've literally got 70-year-olds looking after 95-year-olds, right? So now there's the trend of family side. So you've got family members killing family members because they're such a burden. And when I started to investigate this, I was like, okay, then it is a real thing, because then they're so old that people are just going, I can't cope, and they're mentally exhausted from decades of care. And then there's various different government ministers going, well, this can't continue on. This is like, when everyone's just so healthy and so old, what we're going to do? Literally, I mean, it's, and then also people are not having, kids, they're not, so Japan is in a real crisis of it all. But this is a country which has got the longevity, they've got the quality of life, they've got there, and it doesn't look so perfect after all, actually. So it's like, careful what we strive for. That guy is an 82-year-old bodybuilder. I'd argue he looks better than the average guy in the UK or the US, at least. Yeah. So one of the ways that Japan is approaching this is to go, look, we want people at work. And actually, the Japanese man in general values going to work, because then this is how it is. So they have started to include robotics. This robot is called Pepper. Does a lot of little robotics that keeps them alive, longer. But then also there's some additional ones that are going, if you've got elderly looking after elderly, then you can use exoskeletons in terms of on how for rehabilitation and incorporation. And the seal at the bottom is actually a robotic seal. So then you've got communication and companionship robotics as well. So there's a great integration of robotics within the Japanese culture of working within the aging society. That was the quick version, everyone. Yeah.
Your top right-hand slide with the back support, that's made by Cyberdyne, and they've been doing a clinical trial with Hampshire County Council.
Cyberdyne. The very name that they use in the Terminator.
Yes, and they've got a robotic exoskeleton called HAL. We've been working with them for a while. HAL.
I was joking.
They've been doing a study in the UK with Hampshire County Council, looking at the use of those to reduce the load on the carers. And they were looking at
it makes perfect sense. Because if you've got 70-year-olds looking after 95-year-olds, they're not exactly deadlifting champions anymore.
Right.
Yeah.
They're using it. They've been doing it on younger carers in the UK, but their research model was,
that's because we're unfit.
They wanted the funding after they'd proved the concept for the study, and we just went that way back in the UK.
Yeah.
That was really interesting.
But that was the quick version, everyone, because I know that I think, am I last or next to last?
You're the last.
Oh, all right.
Mary, did you want to announce, say it, or tell people about it?
Okay, all right. So one of the things we do at Zenith is between the teaching, training, and support institution, we do one big event in Africa a year, and we do one in the UK. So we've been to Nigeria, Zambia, Senegal. This year we're in Ghana. Next year we're going to Cape Verde. And with the one, so what we do in everything that we were supporting with, we realized that lots of people in healthcare are doing amazing things, either as healthcare professionals or doing something in health. And we are not very good at, blowing our own trumpet, so like our colleagues in the creative industry.